in a little bigger way. And we expect a very impactful, and interactive academic discussions. And we'll know everything about devices. And I request everyone to raise questions as much as possible. And any queries, we have experts, and we will discuss things, and this is basically the idea of the program. So to start with, may I request our senior faculties, Dr. Anup Gupta, Dr. Atahar Ali sir, Dr. Sanmuga, and Dr. Umesh Kohli to come for the lightning of the lamp. Okay. Sunil, can you manage? So I'm really thrilled to see attendance, rising, and this is 10:15, and we hope we'll have a, packed house the entire day. So with this, we commence our academic program, and may I invite the chairpersons, Dr. Ravin Chakravarti and Dr. Atahar Ali sir, to please chair the session, first session, and it's my pleasure to invite Mr. T.K. Govind for his first presentation. May I have our chairpersons on dais, please. Atahar sir.
Hello, good morning to everybody. So I think we should start the session straight away. Mr. Govind is a kind of more of a scientist, rather than a technical person. So we learn a lot from him, and I'm sure that his knowledge and his understanding of device, the integrity is phenomenal. So Govind, can you start the session straight away?
Thank you, sir. Thank you for that introduction, and it's a privilege to hear those words from you. Thank you very much, sir, and thank you, Dr. Atahar. And I would also like to thank Dr. Dilip Kumar for giving the industry opportunity to support this program and giving us an opportunity to make this presentation as well. And yeah, my first topic is about pacemaker timing cycle. I can see that this audience knows the timing cycle pretty well. So we can look at this as a short, quick brush up of the timing cycle before the main discussions on the device gets underway. So with that, I start the timing cycle, starting with the VVI mode. As we all know that, it's the time from one initial pace to the next pace in milliseconds. In this case, it's a rate of 60 beats per minute, which translates into 1000 milliseconds as an interval, or V sense to V pace, that's a lower rate interval. And on delivering a V pace or after a V sense, in the ventricular channel, the timing cycle, there is a refractory period, and the first portion of that is a blanking period. And as we all know that during the blanking period, there is no sensing at all. And during the refractory period, as is depicted here, there is sensing, but that will be marked by the pacemaker as a refractory ventricular sense, and it will not restart the lower rate timing. And as a result of that, we will ignore that. This may overcome sometimes the T-wave oversensing that can reset the timer, can be avoided. So that's the simple single chamber timing cycle. So let's move on to the dual chamber timing cycles. In dual chamber, the modern pacemakers use the atrial channel as the basic timing chamber. So it's the atrial based timing. So the lower rate is based on the atrial channel. And here, this picture depicts the AV sequential pacing with A pace, V pace, or A pace with intrinsic AV conduction, V sense. So what happens is it delivers A pace, and in the atrial channel starts a lower rate interval. And if there are no atrial sense or ventricular sense before the lower rate times out in the atrial channel, it delivers the next atrial pace. And on delivery of atrial pace, it also starts the AV interval. And if there is no intrinsic AV conduction happening, resulting in an intrinsic ventricular activation, so it's going to deliver a V pace, which is a programmable value. And as we can see in this case, on A pace, it started a lower rate timing to deliver A pace for the next time. And along with that, it started an AV interval. And in this case, appropriately, the AV interval is programmed long enough to allow the intrinsic AV conduction to prevail. So an intrinsic ventricular activation happened, which is sensed by the ventricular channel and then marks it as a ventricular sense. So that's AV sequential pacing. The other one is the AV synchronous pacing, where the lower rate is, it's a DDD mode. The lower rate is programmed lower than the patient's sinus rate that's going on. So, or we can say that it is a functional VDD mode. There is a sense, and on sense in the atrial channel, there is a start of the lower rate interval. Before the expiry of the lower rate interval, the next intrinsic atrial event comes up, which is sensed by the pacemaker as an sense. And along with the sense in the atrial chamber, it also starts an AV interval. So in this case, the patient probably has an AV block. So at the end of AV interval, because it did not see a ventricular activation, it delivers a ventricular pace. So in this case, there is a sense, and along with the lower rate interval, it also started the AV interval. So the AV conduction happens at a time shorter than the programmed AV interval. So it allows a ventricular intrinsic activation, which is marked by the ventricular sense. So A sense, V sense. So ideally, we would like to program to minimize RV pacing. So in this case, we would like to program an AV interval longer than the patient's known AV conduction time, so as not to pace the ventricle. Of course, there are modern modes available to avoid that totally, but this is in the DDD mode of timing cycles, the basic timing cycles that we can see. So we said on delivery of a pace or a sense, it starts an AV interval. During the AV interval, in the atrial channel, the rest of the AV interval is a refractory period. So if there is an atrial event happens at this point of time where I'm pointing out, it will be marked as a AR. Very often that will be an atrial fibrillation that's going on in that patient, or a atrial ectopic. And as any other timing interval, after a pace or a ascens in the atrial channel, the first portion of that is a blanking period, which is automatically getting adjusted, during which time nothing will be sensed. And here is a little issue that you all know about, which is a crosstalk. And what appears to be going on is a pace, because you see a spike here in the atrial channel, and then the intrinsic ventricular activation happens. And on a pace, this is the atrial electrogram, and this is the ventricular electrogram. You can see a deflection here on the ventricular channel, ventricular electrogram. So what happens here is the atrial pace is oversensed in the ventricular channel, which is a crosstalk. And if the pacemaker senses that, then the pacemaker will inhibit the pacemaker from pacing. So in this case, patient seems to be having an AV conduction. So even if this had been sensed, it would not have made any difference to that patient, because intrinsically activated ventricular activation happened. But as you can see in this case, AV sequential pacing is going on, an AV block patient, A pace, V pace, A pace, V pace, and this A pace is not resulting in a ventricular pacing after an AV interval. That's because of the crosstalk oversensing that happened in the ventricular channel, and this was sensed by the pacemaker in the AV interval, and it considered that it is an intrinsic ventricular activation, so it inhibited the ventricular channel from delivering a ventricular pace. So that is not wanted now. So this is a depiction, but then in the current pacemakers, it would not happen, as I will show here. On a pace in the ventricular channel, for a short duration, there is a blanking. So if there is a crosstalk oversensing, it's going to happen at a very, very short interval. So this duration is just about 30 milliseconds, which is post-atrial ventricular blanking, PAVB. So that oversense will happen during that short 30 millisecond. So it will not be sensed by the ventricular channel, so it will not inhibit. But despite that, in some situations, either an oversensing might happen a little later than that, or something else can happen. Because of lack of time, I'll not go into the detail of that. If that happens, then if there is a ventricular sense after the initial PAVB, still the ventricular channel can get inhibited. And if it's the AV block patient, then the patient will not get a pacing support. In order to overcome that, to deliver ventricular pacing, ventricular safety pacing is there in all the dual chamber pacemakers in the timing cycle. If there is a ventricular sense after a pace, remember it's only after an A pace, not after an atrial sense. If there is a V sense within 110 millisecond after a pace outside the PAVB, regardless of the AV interval that we have programmed, it will deliver a V pace at the end of 110 millisecond. So if this sense was actually a oversensing, no ventricular intrinsic activation, this VP will result in a capture. But if this was assumed was a ventricular ectopic, it will deliver a V pace here within the myocardial refractory period, which will not cause any harm to the patient. So that's the concept of ventricular safety pacing, which is the duration of 110 millisecond, and you can turn it on or off. So that ensures safety for the patient. So that's a pace-related crosstalk, ventricular safety pacing activating at this point of time. And there is another type of crosstalk, which actually is not technically referred to as a crosstalk, which is usually called as the far field R wave sensing. So as you can see here then intrinsic heart rhythm is going on, atrial channel, and this is the ventricular channel. Atrial electrogram on ventricular channel, during the ventricular activation, we can see a blip here on the atrial channel, which is the far field R waves being sensed in the atrial channel. So if this happens, then this pacemaker can misinterpret this as an atrial arrhythmia going on, and it may lead to mode switch and related problems. Ideally, we do not want this to happen. So here is an example of a ICD electrogram. This is the atrial electrogram. This is the far field ventricular electrogram. So this is an intrinsic atrial event, and this is a far field electrogram in the atrial channel. So the ICD despite the algorithm to actually recognize that, might interpret this as an atrial fibrillation and make the device to mode switch. And if this was a patient who needs a ventricular pacing, because mode switch happens and turns it into a DDIR mode, the patient may also lose an AV synchrony. And we will get inappropriate diagnostics when we interrogate the pacemaker. And if you're not very careful enough to look at the electrogram, we might misinterpret this as an atrial fibrillation, where it's actually not an atrial fibrillation. So that's a problem of the far field R wave sensing, and we do not want that ideally. And that's why the dual chamber pacemakers in the atrial channel, after a ventricular event, either a V-pace or a V-sense, has a slightly longer blanking period, which is post-ventricular atrial blanking, which is a programmable value. And then this covers the entire ventricular activation duration. The default value is around 170 or 180 millisecond. So in a conventional dual chamber pacemaker, the far field R wave sensing does not lead to any problem for us at all, because that will fall during the PVAB and that will not be considered for the timing cycle. But the modern pacemakers are built on the ICD platform, as you can see here, where we allow sensing during the blanking as well. So there could be a misinterpretation of the rhythm to be an atrial fibrillation by the device. So that might happen. So in the conventional pacemakers, there is PVAB. This will actually take care of that. So that's post-ventricular atrial blanking. And then here is an instance of pacemaker-mediated tachycardia. As you can see here, intrinsic events happening, A-sense, V-sense. A ventricular ectopic allows a retrograde atrial activation that is sensed by the atrial channel, and it starts an AV interval, delivers a V-pace. That allows yet another retrograde activation, and this cycle goes on. So this, as you all know, is a pacemaker-mediated endless loop tachycardia. Theoretically, it can go on forever, but it can break. But then, yes, by appropriate programming, we can avoid that. So this is something that we do not want the pacemaker to manifest, and that is why pacemakers incorporate in the atrial channel after a ventricular event a timing called post-ventricular atrial refractory period, called as a PVARP. So which is a programmable value. In the event of a retrograde activation into the atrial channel, the retrogradely conducted P wave will fall inside the PVARP. As you know that's a refractory period. A refractory atrial event will not start an AV interval. So right in the beginning, we prevent the pacemaker mediated tachycardia from happening. Despite that, we do observe some PMT happening in some of the pacemakers where there are algorithms which can take care of that. So that's part of the timing cycle. So that's the PVARP, its relation to avoid the pacemaker-mediated tachycardia. And then the ventricular channel interval that we talked about already. So putting it all together in terms of dual chamber timing cycle, these are the things that we need to remember. On A-sense or A-pace, lower rate interval starts along with an AV interval. And it also starts an AV interval. So in order to prevent the crosstalk from inhibiting the ventricular channel, in the ventricular channel we have a PAVB and the ventricular safety pacing to not inhibit the ventricular channel. And at the end of the AV interval, there is a ventricular sense or a ventricular pace, depending on there is an AV conduction or there is no AV conduction. And in the ventricular channel, there is a refractory and blanking period corresponding to that. And after a ventricular event in the atrial channel, to avoid oversensing of the far field R wave, there is a PVAB, and to avoid the I think my time has timed out. So if I have time, so I will just complete the Venki-Bach, or I can stop.
Yes. I think you can continue, sir.
Okay.
With permission of chair.
Yeah, please go ahead.
Okay. So the other thing is upper rate behavior. In order to appreciate upper rate behavior, we need to understand the upper tracking rate. Upper tracking rate interval is the interval that starts in the ventricular channel after a ventricular event here. and it runs for a duration of time where we have programmed. If we have programmed the upper tracking rate to be, let us say, 120 beats per minute, that interval will be 500 millisecond. So if there is, in this case, there is an ascens after the upper tracking rate interval, it will start a AV interval and do a ventricular pace. But if there is a atrial sense before this upper tracking rate interval, and if the ventricular pace has to be delivered here where I'm pointing out, it will not. It will wait for the upper tracking rate interval to time out and deliver the ventricular pace here. This way the pacemaker will never violate the upper tracking rate limit that we have programmed, so that it doesn't pace the ventricle faster than what we have programmed. And this combination of PVARP along with the upper tracking rate interval will result in one of the upper rate behavior, which is the pacemaker Wenckebach. So here there is a ascens which starts an AV interval, delivers a V pace. And here again there is a ascens, but as you can see here, that is within the upper tracking rate interval. But if you go by this AV interval that's happening, so there should have been a V pace a little before the V pace happened here. But here the pacemaker, because of the upper tracking rate interval, waited for that much longer, delivered a V pace. You can see the interval is slightly prolonged, and the next one there is even prolonged, and the next one, the atrial event is falling within the PVARP, and it's an AV block patient. This did not start an AV interval, so there is no ventricular pace. So normal AV interval, extended AV intervals, and one atrial event not resulting in a ventricular pacing. So that is the Wenckebach that happens because of a pacemaker. So it's the pacemaker Wenckebach or pseudo Wenckebach that happens. And then when the rate is fast enough for the atrial event to fall within the PVARP, so alternate P waves will fall in the PVARP. That will result in a 2:1 pacemaker block. So that's essentially the timing cycles and the upper rate behavior put together. And I stop here, and I once again thank the chair for giving me an opportunity here. I'll take the questions if there are any. So.
We'll take the questions now or maybe after the session.
Depends on you, sir.
Huh?
You decide, sir.
Just a quick question. It's a good presentation. I think that a lot of things is very much technical. Whatever algorithm you have shown, is it exclusively for Medtronic product or it is for right across all the
No,
devices?
this is the basic timing cycle, sir. This is universal across all the dual chamber pacemakers. I've not gone into any specific Medtronic algorithm.
The second question is that, these days, most of the time the devices, pacemakers and others are being programmed on auto mode, so that it adjusts on its own.
Yes, sir.
So in that case, is there any sort of failure or is there any problem of this being auto mode? Or what is the recommendation?
Okay, so I guess you're referring to the PVARP Auto. Yes. So PVARP Auto is a very useful thing to program, and the implementation of that is slightly different from different company pacemaker. The essential concept is that, as we actually discussed a little while ago, if there is a P wave that's falling in the PVARP, then it will not start an AV interval and it will not deliver a ventricular pace. So we want this because we want to prevent the pacemaker-mediated tachycardia from happening. So if we, in case the patient has, let us say, a slightly slower retrograde activation, and then we program because of that a slightly longer PVARP, then as we saw, let me go back here, if we program the PVARP longer, even the sinus P wave can fall within the PVARP. So even the sinus P waves at a fairly lower rate of 130 or 140 or 120 beats per minute might fall in the PVARP, and that may not result in a ventricular pace, which physiologically you may want the patient to get a ventricular pace as tracking the atrial channel. So that will be the limitation if you have a fixed PVARP. So in this case, if you program pretty long, then that's going to limit, because the TARP is longer, that's going to result in a 2:1 block earlier, and so that's going to limit the upper tracking rate that you can program in the device. But now going to the auto PVARP, in the modern pacemakers, now for several years in all companies available, automatically adjusting PVARP. At the lower rates, the PVARP will remain longer So if where there is a chance of retrograde activation is higher, so then if there is a retrogradely conducted P wave, that might fall in the PVARP. So it will not start a pacemaker mediated tachycardia. But if the patient is going into the sinus tachycardia because of activity, exercise, or any sinus related increase in rate, it will gradually reduce the PVARP. But because it's reducing the PVARP gradually, so the chance of the retrograde conducted P wave falling in the PVARP is lesser. So you can provide, you can prevent pacemaker mediated tachycardia and at the same time provide a higher upper tracking rate for the patient in whom you feel that physiologically higher upper tracking rate is required. So this is a very, very useful thing. But then in some patients, the sinus rate increase can be quicker. So in that case, momentarily there can be a, pauses that might happen. So that's the only drawback. Otherwise, it's a fairly useful feature.
Thank you, Govind. So maybe you stay back and we may ask question even in other session.
Well,
so the next one is
that's a
Sabri.
pleasure.
Sabri, nice to see you again. Okay, he's going to educate us on lead technologies.
So we have programmed the agenda. We have given 10 minutes to speakers, and you see the slot is 15 minutes. So we have kept 5 minutes for discussion. So we have to utilize this. We have started a little late, 10-15 minutes. The time I think will manage. So the idea is more and more discussions.
Good morning, everybody. So device update, we have been associated for some time, so from the inception. And it is a great journey we have been having. And this device update is something which is really focused on learning and only something which is updating the knowledge about CIDs. So we are very thankful that we could be part of this wonderful journey. And also, my name is Sabri Vasan. I work with St. Jude Medical Abort, and I am a training manager for some time. So today, most of you know about everything about whatever lead technologies I am going to talk about it, but you will just have a revision and also look at how it actually began. So if you look at the pacing leads, this was in 1958, when the first pacemaker was implanted. The leads were just picked out from whatever it was available in the market, and they just made the leads out of it. So there was no special technology or anything, and the leads were not available for more than 3 months or 6 months of time. So they broke. So that was the situation at that time. But do you think the lead is a small part of the pacemaker, or it is a major part of a pacing system? So if you look at the pacing system, that is the impulse generator and the lead, the pacemaker lead carries almost most of the work. So it is the silent workhorse of the pacing system. It has a lot of jobs like pacing, sensing, carrying out some sensors in certain leads, and measuring congestion and shocking. So many things this lead, and if you look at the problems or malfunctions in a device, it is more or less 99% happens in this. Why? Because this lead is going to be in an alien environment, and every single minute or every single second, you're going to have the blood gushing through and also the heart pumping. And all these things are going to put a lot of stress on this lead. And to have another challenge, also the rib clavicle crush, which is quite common. But now with the axillary puncture or extrathoracic puncture coming in, this is almost gone. But in the situation of a subclavian puncture, this always happens to be a situation where we have to look at it. So at this point of time, we need robust conductors as well as robust insulation, because we are putting that in an alien environment. So in such a situation, if we can put a lead like this, which can be big, very big, and it can also take care of any sort of conductor break or insulation break, but we can't do it because it's quite big to go inside our veins. So we need smaller leads, and these smaller leads has to be having a robust insulation. So if you look at the insulation materials which have been commonly used in the leads nowadays, it is silicone, polyurethane. These are very common, silicone with a flexible and polyurethane with durable nature. And the latest available Optim leads, which are combining both of them to get the best of flexibility and durability. And going into minimal information about the construction of the lead. The leads initially started as unipolar leads with one insulation and one coil and a big antenna. And this big antenna was able to get a lot of oversensing and also diaphragmatic as well as pocket stimulation. So this was not good enough. So that was the reason why the lead technology improved and we went into bipolar leads. So the bipolar leads had two insulations and coils, and now the antenna became very small, so the oversensing and diaphragmatic pacing, all those problems were taken care of. But when you go into the fixation of the lead on the myocardium, initially it was epicardial lead, and if you can see almost like you have got a small button-like thing, which is the one which was sutured. And even if you see in a fluoro picture, this was a patient who was getting various implants. He had 2 or 3 buttons and 2 or 3 two long sticks like this. These were all the tips which were left alone of the epicardial lead which was implanted earlier. So from this, now the epicardial leads have also migrated a little bit. Now we have very safe epicardial leads, both screw-in as well as button leads which can be sutured on. And when you go into the leads which have endocardial, now we have both tine leads as well as screwing leads which have come in. And if you look at the history, it was starting with almost without any tines or anything, then it went to fins, then the fins became big tines, then it became a nominal tines which we are having. So these are very good, especially in situations where you have trabeculae in apex as well as in appendage. But in situations where you want to put the lead in a different place, and now the CSP has become very common, and those situations definitely you require a screwing lead. And screwing leads are very easily available and mostly used by all companies, all industry companies are having this. And this is a fluoro picture which clearly shows how when it is extended, it goes into the myocardium and gets fixated. But anchoring and deploying is the most important thing, and there may be many challenges for this as well. So what are the things which we will be looking at anchoring, that is the fixation of the lead to the myocardium? So if you look at this, this is post-implant immediately. Then after some time, like 20 days, you see the whole the lead coiling up around the generator. So what could be the reason for this? So this is called as a reel syndrome, and why this is happening. So when you look at it, we had a good fixation mechanism, either tined or screw-in, but still we had a dislodgement. This could be of various other reasons. One could be the patient himself or herself is helping with the twiddler, or if it is going to be a less of anchoring problem at the generator and also a anchoring problem at the suture sleeve. So all of these things can be helpful in actually dislodging the lead. So we require anchoring techniques especially, and that's the reason when you have a device, all the devices now carrying a space where you can anchor the device to the pocket. And also the latest anchoring techniques, which is also the anchor knot, which has been found to be the best among the suturing the suture sleeves. This leads to less problem on the lead insulation, but at the same time, it holds the lead properly, so less of dislodgements are there. So now from pacing lead, we go into the next part, that is the ICD leads. And if you look at the history, the same thing, history repeats, that is epicardial. So initially when the ICDs were invented, it was epicardial leads and patches. And sometimes they were even having some can-like features which were fitted into the apex, and leads which were subcutaneous leads. So all these things was how the epicardial system for ICD developed. And now came the endocardial leads and endocardial leads with dual coils. So they were able to give shocking through these two coils, and this was fairly very successful. And later stages, this dual coil has now also gone into a situation where the evaluation has bring in single coil because of fibrosis. Fibrosis, especially at the coil level, and this has been the reason why most of the single coil leads have come in, and almost dual coil leads have become a very small percentage where they may give a small advantage of lesser DFTs. And when you look at the connectors were trifurcated with SVC coil and RV coil separately, and patients separately 3 trifurcations, and now all of them have got into one, and that is our DF1 leads to DF4 leads have come in. And coming back to the fibrosis at the coil level, now the developments are that earlier the coils were just wound over the lead, but now you are also making sure that silicone backfilling or a PTFE coating with different industry partners, they do differently, so that in situations where you have this silicone backfilling, the fibrosis is going to be far less compared to a naked lead which doesn't have a backfilling or a covering. So if this thing is happening, then what is going to happen? So if you have a naked lead which is having no silicone backfilling or a flat coil, then possibly you're going to have this type of fibrosis happening, especially in your SVC coil. So when you want to explant it, it is going to be a very difficult procedure. Sometimes it may lead to a SVC tear. So this is the reason why a single coil lead is a lot more preferred. One, now the evolution, especially in ICD leads, has got reversed. So we went from epicardial leads to endocardial leads, and now again we have come back to subcutaneous leads. Because to avoid the problem of fibrosis, we have gone into the next generations where companies are devising various ways they can put the lead outside the heart, and the subcutaneous leads and devices also has become the vogue now. Now going to the last part of the leads, the CRT leads. The CRT leads, apart from the pacemaker leads, we have got one lead which goes to the coronary sinus to a target site where it will be the latest activation. So the leads were being actually an epicardial placements, and initially it started with unipolar leads, then various bipolar combinations came in with various shapes. These were the fixation mechanisms. Along with this, there is also now active fixation leads which has a screw or a jab which can also go inside and give a screwing type lead. And now from the bipolar leads, now the quadripolar leads have come in. So with our 4 poles, this gives you various advantages, because earlier we have to shove in the lead to the apex, and probably the 2 electrodes will be nearby to the apex. So we may be pacing from the apex or maximum by the mid region. But now you can also have your basal region which is coming in, which can be paced, and as well as the mid, because you have various options in a quadripolar lead. So this is something which you can have with various options. So better hemodynamics, then less phrenic nerve stimulation, and you have more options for finding out of electrode combination where you can have also low thresholds. So this is how we are coming through the journey of leads, the leads from pacemakers, ICDs, and CRTs. So now the evolution has gone to one step further. So now it looks like that we don't require to have leads at all. So this is a representative picture. So now we are going into a situation where we directly go into leadless pacemakers. And these leadless pacemakers also are coming up in a big way now. The single chambers have come. The trials were going on for a dual chamber, leadless pacemaker, and we hope this should be coming through any time. And over a period of time, even these leadless pacemakers will be miniaturized, so it is so small that can be easily implanted directly under the heart. Also we'll be having CRT devices possibly with miniaturized leadless pacemakers. So thank you very much for giving your attention, and I think the future is so bright and things are backing up, and the lead technology though has come up a lot, it probably may go off and we may end up with leadless devices. Thank you very much, sir.
So, thank you, Mr. Sabri, for your excellent and brilliant lecture. So, sir, I have a question, but I want to hear from you, sir. Yeah. Sir, regarding the selection of the atrial leads, that is the active versus fixation, do you have any suggestions as who is at what time that which lead should be selected?
So normally, in our practice in general nowadays, most of the time we use a screw-in lead. But there are situations when we do use a passive fixation lead also. But sometimes the heart, the atrium appendage's anatomy is not very clear, or so much variable. And to ensure that the well anchoring is there, I prefer dual chamber screw-in lead. You got any other comment on that?
Yeah, that is fine, sir, because screw-in lead gives you all the options. Because sometimes if you have a surgery and the appendage is not available, then you don't have an option of a tine lead at all. And many situations you have a higher threshold, you can always go to lower septum also, that is another possibility.
Right.
I have two questions. One is to Sabri and one is to Govind. So one is when we put the pacemaker device in the pocket, we suture it, we kind of stabilize it. So does Tyrex do this job? Like if we are implanting, giving Tyrex, do we need to fix it or Tyrex will do that? Because it anchors the device also, number one, to Govind. And second, to Sabri, there are many operators who give turns more than what is required. So if you are giving a screw 12, 15 turns, if someone has tendency to go fast, 18, 20, so what's the harm and is it totally kind of harmless or can it do some problems?
Yes, to answer the Tyrex related question, sir. So, the Tyrex, completes the fibrosis. It takes about 9 weeks or so. So all that problem that Sabri described might happen within that time. So it's a good idea to consider fixing the device in the pocket. Yeah.
Thank you, Govind. So I think that is a wonderful question. Actually, I didn't have time, so I didn't include slides on that, because that is something which is very important, because we industry people, there are 4 companies, and 4 companies we are not standardized. So every company confuses you. So we have 7 turns, Medtronic may be having 8 turns, Biotronic may have 15 turns, and Boston Scientific may even have 25 turns. So each company has a different number of turns for extending the screw into the myocardium. That is one. So that we have to keep in mind always. The second thing is we always look at the fluoro. So you get the W, we stop. Because what happens when you do over-torquing, and this was a published study also which clearly talks about, you start holding the myocardium and the myocardium turns around the lead. And if you do more than 1 or 2, 3 over-torquings, that means this turning around stops and you actually have done a thing called coring. And with LBB pacing, this has become more prominent because you get a coring and this lead gets dislodged because of this. And not only this gets dislodged, the tissue which gets stuck inside the screw doesn't allow the lead helix to retract also. So that way this is going to be a problem. You have to take out the lead, clean the lead, then you have to do this. But always the current of injury is very good thing that will help you to say how stable it is. But another important thing is whenever the screw is completely out, it is always better to stop. Because more the over torquing, it is going to have more dislodgement chances.
Do you have any technology to prevent micro dislodgement? That is a very common problem.
Sir, this is something sir was asking. We have gone into the complete screwing. The W is out, we stop it there. And if you do this, and along with this, also you look at the current of injury. And the current of injury, if you are having around 2.5 millivolts in the ST segment elevation or more, then it means that you definitely are inside the myocardium and you are stable. These are things one. Second is, when you are doing the screwing, you should be doing it slowly. If you are going to do it something like this, then probably after some time a recoil happens or a late recoil also can happen. So that way the screw may come inside or come a little out, little inside, then your dislodgement chances goes up. So it's a textbook, follow the instruction of number of turns, look for the W. If the W is out, look for the current of injury. Current of injury is good, then most probably you should be through.
And change the view also. Like,
Yeah.
Like you are doing in AP view, but when you are turning it, it goes slowly and change it either RO or LO, where the best profile of the screw can be visualized.
Exactly. So sir has said, you have done the turns like 20 turns, which is supposed, but you don't see the screw itself out. Go to a different angle, you probably the screw is out there.
RO.
So,
Yeah. In conduction system pacing, where your tendril lead is used, 2088 tendril lead is used, you give more torque to enter into the myocardium so the left bundle pacing can occur. So what is your opinion? Can it
Sir,
fracture?
we have been doing
Can
it.
it do retraction? More screwing will lead to fracture and then it can retract, or even I have seen dislodgement of the lead.
with tendril in a lead bundle branch pacing?
No, even usual pacing, if you give too much of
Yeah. stellar inventory, too much of overscrewing, definitely you have chances of doing this. Second part, after that what happens, sir? You have given overtorquing, 2-3 turns have gone, the screw got some tissue inside, then you want to retract, it doesn't commit, you try to do more number of turns, you break the whole mechanism itself. So the lead itself will get damaged because of
How this lead can be used for the conduction system pacing?
Sir, it has been absolutely no problem. We have been seeing it in many centers. They have been doing it. So normal turn, you go inside, then you do the normal, what you do in a...
Lead turning,
Yeah, you have to turn the lead after that.
lead only.
Exactly, means you are taking out the screw up front, so means you are taking the screw up front, like if
I think we should move now. We will ask the next speaker because it can continue. This itself can be a full day session.
Can I ask one question?
Can I take the question later on? Okay. The next speaker is Anup. Anup, you are going to talk to us on pulse generator science, longevity, and that matters.
I need a laptop to present my talk. So, thank you very much. So, I am going to what Sabri has spoken about lead. So, I am going to continue with the pulse generator.
So we are not doing a formal tea break. Anyone would like to have coffee, they can grab it outside and come.
Okay. So, thank you very much. So, Sabri spoke about the lead. So, the other important thing is the pulse generator. So, does the longevity matters? And means when we are talking about the pulse generator longevity, what I mean to say by ICDs and CRTDs and CRTPs. The reason is because still we are quite privileged to have pacemaker PGs free of cost replacement. So we are not worried about that thing. But when you are talking about the higher end devices, so it does matter. So what has happened over a period of time, like with the improved battery chemistry and device technology, we know the longevity of devices are increasing, both for ICDs and CRTD. Again, single chamber ICDs are not an issue. The things are always dual chamber ICDs and CRTDs. So why we need any clinical benefit of PG battery longevity? Yes, one thing is you reduce the device replacement, and that is one situation where you are really worried about the infection, because see, if during the pulse generator replacement you get an infection, you need to extract the lead also. That's very problem. And then the economic benefit. Again, what I said, we are not covered patient, and we don't have lifetime warranty for ICDs and CRTDs. So, economic benefit is very important. So, upfront, whenever you are implanting an ICD and a CRTD, so device longevity battery should be the determining factor by the physician and the healthcare commissioners. So, again, going back to the historic perspective, and Sabri showed pretty good about the leads, and this is again the same thing, 1958 when it came. So the first battery, which was epoxy resin, and it was covered in a silicone rubber, it lasted only for 7 hours. And again, means afterwards, after 2 years also, when the Medtronic came with the unipolar zinc mercury, so it lasted for 2 years. So unpredictable failure and short service life, it became imperative to investigate potential other power sources. So then came 1971 and great batch, a lot of lithium batteries are still with the name of his patented. So he suggested we should have a lithium battery, and that is what the anode is still, majority of those devices, all the devices, in fact, not majority, all the devices, the anode is still the lithium. And then it was implanted in 1973. The first battery lasted for 38 months, so little bit of more than 3 years. And the same battery, the very next patient lasted for more than 10 years. And, means if you get a chance, this review by Harry Mond, again, is a pretty good review in 2014, which was dedicated to Great Batch, Wilson Great Batch. So if we are talking about ICDs and CRT, what are the factors which really matters for the longevity? So we know that, background current, to keep the device active, you have to have a background current. Collection and storage, like, what is before the VT or VF episode, storage of the EGM, pre as well as the post, and during the therapy is what's happening, because then you can really settle you can program a device, so the patient should not get more shocks or inappropriate shock like that. Pacing threshold, particularly in CRTDs, if the LV lead threshold is on the higher side, that's very, very important. So if you take here the study which has shown, single chamber ICDs is not an issue. The concern is again CRTDs, because the battery longevities in CRTDs are pretty less. So apart from that, the other thing is the capacitor reformation. So, when we have got an anode and a cathode, so you have to have a separator. So the battery should not deplete. So what it has to do, it has to avoid the degradation, it has to reform every year, at least 2 times every year. And if it is reformed, so the battery longevity again goes down by 24 days by single reformation. That's very important. Other thing, what Sabri was saying, quadrupolar LV lead. So the plus point of quadrupolar leads are, means you have got 17 configurations. So you see which configuration is giving the best QRS and which configuration has got the minimum threshold. So, you can increase the battery longevity. And at the same time, if you are thinking about performing a multi-site pacing, in that situation, the battery depletion will be less by 1 year. And this has become very, very interesting nowadays, like, remote transmission and remote monitoring. So there are pluses and minuses also. People try to transmit their parameters probably every day, sometime every week. So that again going to reduce the battery longevity. So that's again becomes very, very important. So what I said, like, impact of pacing, RA-RV, most of the time we are not concerned about RA-RV. The most important thing is the LV lead output. And initially it said, like, whether the patient is getting multiple shocks or not, doesn't really matter the battery longevity. But yes, if it is a unipolar pacing configuration, or if it is a high left ventricular outflow, then the p-values are significant. So the battery longevity goes quite significantly. Now with the quadrupolar lead and the newer DF4s and all this thing, the unipolar configuration, majority of devices are very, very less. So what are the trial says, and what are the comparison between all the CRM companies, between the Medtronic, the Abbott, the Boston, and the Biotronic? So this is what they said, like, largest multi-center analysis of the CRT devices from all the manufacturers, and practically the major 2 share were Medtronic and the Boston. And what they found, in all the CRMs, like, with the older generation, with the newer generation, so all the newer generations are pretty good. Like, the red line shows the recent generation. So if you take Biotronic, Boston, St. Jude, Sorin or Medtronic, although we don't get Sorin over here, so the newer generation device longevity is much, much superior than the older generation. But when you compare among all 3, so, then the Boston Scientific and St. Jude, they score over Medtronic. And why they score more better over Medtronic, that I'll come, because what is there with the technology of the battery. So other trial which came in 2016, again the battery longevity between these 2, although these were very short, few numbers of patients, short trial, again it shows Boston Scientific is superior than St. Jude as well as Medtronic at the end of battery depletion. So it's important, like, which device has got a longer longevity. So this is important, like, again, we are doing quite a lot of, like, previously it was all primary and secondary prevention for ischemic heart disease. Now we do a lot of ICDs for channelopathies when we are talking about ICDs. So Brugada is one, ARVC is the other. So these are relatively very, very young patient. And, if you have seen the mortality, so if suppose you say Brugada mortality is only, like, 4.5% of mortality. ARVC, again, the percentage of mortality is only 2%. So the longevity is pretty high. So these are young patients who are going to live for a long time. So these are the patients in which it becomes very, very important, like, which device has got a more battery longevity. The other thing, other indication is again hypertrophic cardiomyopathy. So again the initial concept, but most of the patients are dying because of arrhythmia, but that is not true. Like, now the premature deaths of HCMs are reduced significantly. Now what has happened, these patients, when they go into LV dysfunction, and the majority of cause of death is because of the heart failure. So again, when you are putting an ICD in a HCM patient, so battery longevity becomes very, very important because they also live for a long time until they go into heart failure, bad heart failure, and then they die. So what is the need of longer lasting devices? Why you want longer lasting devices? So these are very important things, like, younger age, 35 to 45% of patients with ICD or CRTs are less than 65. More than 80% of mildly symptomatic heart failure, they live more than 7 years. 40% of patients are living more than 10 years with ICDs. Annual mortality is very, very less, 3%. If 50% time you can avoid the change of battery if the ICD longevity is 12 years or more. Same 75% in CRT if its longevity is more than 9 years. You don't have to replace the battery if the battery longevity is good. And if you ask your patient and the family, like, what is your desire? If you give all the technology, whether you want a Bluetooth or you want a DF4 or you want a DF1 or you get more therapies or you want a battery longevity, probably they desire for a more longer battery longevity. That's very, very important. Now coming back to the question, like, what is the chemistry in batteries which is important? So pacemaker, we know that they all use low power batteries. So low powers which is used is the lithium iodine, and that is for a long, long time. And all the batteries, like, what I said, the anode is lithium. Only the cathode screen, they are different. And what the cathode screen now they are using is lithium silver vanadium oxide or lithium magnesium dioxide. This is the latest one, the magnesium dioxide. Again, I will come why it is more superior. And Medtronic has got additional, like, carbon monofluoride. So, they use two things, like, they use silver vanadium oxide also, as well as carbon monofluoride also. So what the French health assessment says that ideally, if you are putting an ICD or a CRT, at least single chamber should have life of 7 years, dual chamber should have 6.5, and CRTD should have at least 5.5 years. That's very, very important. So difference between lithium magnesium dioxide and lithium silver vanadium oxide is, this is now the latest one which all the companies are using. Previously the silver vanadium oxide was used, and still this is used in St. Jude and Medtronic, this thing. So there's a midlife resistance increase during the time of discharge, and that is why, the battery depletion, they say, is little early. So what has happened with the lithium magnesium dioxide? There is no midlife resistance increase. It means the consistent charge time throughout the battery life. That's very, very important. So here there is no midlife rise. So here the midlife resistance, it goes up. And how the companies have evaluated over a period of time, they have changed, like, from silver vanadium to silver vanadium and carbon fluoride, and now they have changed to magnesium dioxide. So magnesium dioxide, this is the longest, like, this is the best, which gives a longevity of more. So that is how these two technologies are used by Boston and Biotronic presently. So that is why they claim that the battery life is more than St. Jude devices and as well as Medtronic devices. But again, the engineers are working on that. So every company wants their device longevity more and more. So, probably over a period of time, probably Medtronic may change their technology or Abbott may change their technology. So that's very important. And when we are talking about the physics about the battery, so this is what is important. The ampere per hour, that is very important. Ampere per hour, it does predict the battery longevity. So initially when it came, so, it was all like 1 ampere per hour. It developed into 1.4 hours, and now it is majority devices are 2 ampere per hour. So when you're talking about 2 ampere per hour, so the longevity is definitely more. So device survival function for ERI is high. No matter whether the LV threshold is more than 3 volt at 1 millisecond pulse width, or it is less than 3 volt at 1 millisecond pulse width. Still the 2 ampere per hour is much, much superior than 1 ampere and 1.4. So this is what it says, that it's a very strong predictor of survival to ERI for modern system, and further system on cost and morbidity associated with early PG change in 1 ampere per hour is warranted. So there are still devices which works on 1 ampere per hour, but it's 2 ampere per hour is a better option. So how it works, again, magnesium oxide battery are able to maintain high battery voltage and relatively stable internal resistance. There is no mid-rise in resistance, and that is why the usability from 70% of total capacity can be obtained from SVO cells to 90% with MnO2 batteries. So that's very, very important. So from silver vanadium, if you go to magnesium dioxide, it's far superior. What is our desire? What is our desire for the battery? It should be, there should be two components. One is the low current for pacing and the powering electrolytes, like, the background thing. And it should be like, silver vanadium oxide for HV capacitor charging as well as RF telemetry. This again is important, like, one thing I want to stress here. Many of the patients, every follow-up they say, like, interrogate our device. So interrogation, if you're doing with the wand, sometimes it doesn't affect. But if you're loading all the data, it does deplete the battery. So, you need to explain to the patient and family, if it is not required, don't get it done again and again. And particularly with the remote monitorings. So, what Endura Life battery from Boston has done, so, it has become smaller by 18%. And it has become 2 times more usable battery. So, it has not gone up with the size. So, the anode is still small, the separator is still small, the cathode is there. And the volume still remain the same. So again, if you see the latest generation of Biotronic and Boston, so probably their battery is a little smaller than the existing one. How it has evolved over the period of years, the old battery technology, what was stressed between 92 and 96 was the stored EGM. We want store EGM, so you can go with the therapies with the guided EGMs. Dual chamber electrograms were important in the dual chamber devices, and the concept was to make the battery less than 30 cc of this. From 96 to 2000, again, the emphasis was on cardiac resynchronization therapy and rate responsive pacing, and get it the battery less than 40 cc. From 2000 to 2004, ATP became wide usage, like, most of the devices, ATP during charges also was there. RF telemetry became very, very common because during the implant, you don't have to put a wand to get away with the infection and all this thing. And remote monitoring came. And then again, the purpose was to get the size smaller to 32 cc. Newer battery technology, what they say, now they concentrate on this battery chemistry. So, silver vanadium and carbon monofluoride versus magnesium dioxide, which one they want. The device side still want to be less than 30. And what has happened in 2010, 2014, particularly there, but with the thing is multi-site pacing and quadripolar, everybody has come. Just to add what Sabri said, is quadripolar lead again, it comes active fixation with Medtronic. So, if the vein is pretty huge, so you can still do an active fixation in a CS lead also. So, if the replacement are less, so what exactly happens when replacement? There are two concerns. One is hemostasis. Sometimes, patient on anticoagulation because of maybe chronic atrial fibrillation, patient with valve patient. And if you have a hematoma, then chances of infection. So, the rate is pretty high, 4.57% of surgical reintervention and infection of 2%. That's quite a lot. And lead malfunction. When you are replacing the pulse generator, sometimes you can damage the lead. You have to put another lead. So, that's again is an important thing. So, obviously, you want less replacement. So, the battery longevity should be on the higher side. What the National Institute of Heart and Care Excellence has recommended nowadays, it recommended that, magnesium dioxide batteries should be given to all CRT-D devices. The reason is because the economic data, so they obviously, they emphasize that, the cost should go down. Model used for public data, you reduce the complication, particularly the infection, hematomas and all those things. There's a comprehensive literature review on that also. And real-world device longevity. So 6 studies have clearly shown that CRT-D is superiority if you are going with a magnesium dioxide battery. So what the 2021 recommendation, it says that Endura Life powered cardiac resynchronization therapy defibrillator devices for treating heart failure is supported by published evidence, and extended battery life is of clinical and patient benefit and assured fewer replacement procedures. So this is what they recommend right now. How the economic implication works in our country. So there are two components. We know that, the implant charge and the hospital charges. So this is like, the follow-ups, what they say, like, this is mainly for the Western world. Here, most of the follow-ups, it doesn't really matter. Now, majority of the companies are charging for follow-ups, so, that has become an additional burden. But again, since the patient gets out of the warranty, some industry give 5 years warranty, some gives 8, some gives 10 years. But after that, when you're replacing the battery, so, that is a full cost battery. So, that becomes important. This is my last slide. So, is battery longevity the real concern? So, yes. So, how do you plan your battery? If it is a very young patient with channelopathies, you should try to go with the battery with the maximum longevity so that the replacements are very, very less. patient with mild LV dysfunction who have got an indication for ICDs and you're giving CRTDs, again is important. And patient who's on transplant list is the least priority because you know that probably you require battery for 6 months or maybe 1 year. I think I'll stop here and take your question. Thank you very much for your attention.
Thank you, sir, for such a nice and wonderful discussion. Sir, as I said that some companies like Boston is claiming that they have longer battery life than others. What is your personal view, sir, on that? Is it really we are getting that kind of...
Yes.
Yeah.
So if we are talking about the battery longevity, like last 3-4 years, so the Boston and the Biotronic, the battery longevity is the maximum. So now, over a period of time, the Abbott has improved. So Abbott has come quite close to Boston and Biotronic. But Medtronic, like, Govind can give an answer, but because Medtronic is stable, like, they have not gone, like, they are not using two things. So the battery longevity of Medtronic is still on the lower side in comparison to Boston, Biotronic and Abbott. But among all four, if you're talking, Boston and Biotronic are the higher side. No question about it.
Yeah, thank you.
I have a question, like most of the new devices have auto captures and it is being there for many years. So if at maybe 3 years, 2 years after the implant, we see the threshold is still 0.6, 0.7. So if we take off auto capture and keep the threshold of pacing at 1.2, what would be your idea? So it should be, does it become risky? Sometimes lead fracture can happen and then auto capture helps.
Chronic threshold, means suppose you are talking about a chronic threshold, so probably less than 2 is, I think is fine, because see, the safety, what you really want safety is the initial 3 months or 6 months of after the device implantation. So when you're replacing the battery after 3 years or 5 years, you got a chronic threshold. So anything less than 2.
My idea was if we remove the auto capture, because auto capture keeps on sensing, testing.
You are talking auto capture.
So if you remove auto capture, you pace at just twice of the chronic threshold, maybe 0.6, 0.7. Does it save the life? So, pacemaker battery.
So
does it if the trade-off between safety, like if someone has a lead fracture happens at 6 years and you have fixed it to 1.2, considering 0.6 as threshold. So and keeping it a unipolar give you kind of a safety again from other point of view. If the lead fracture, unipolar can pace. So this way can we program the device?
So yes. So first question comes again when Rabin was asking the same question to Govind about the auto capture. I am not a very favorable guy for auto capture. I don't keep auto capture on because that is what I feel like a battery depletion with auto capture is very, very high. So I don't, because what you're saying, suppose the threshold is 0.6 or 0.7, why you want to keep an auto capture? Because see, it will keep on changing. So, probably you keep it 1.5 or 2, output is fair enough, right? One question is that. Second thing, what you said, change the configuration of unipolar. Now the newer devices, which comes if you're talking about a dual chamber ICDs or CRTDs, many of the times you cannot program to unipolar program, and particularly if you're putting a DF4 lead, so you don't have any option of changing over to unipolar program.
Unipolar gives us safety because if there is a lead problem, a unipolar configuration can still pace.
It will, if suppose there's a, what you said, if there's a lead fracture or something, so the device will automatically go into unipolar for the safety period, so the patient should not get any pacing failure.
Regarding the regarding the pacemaker, particularly for the premature battery depletion is a major problem, and surprisingly even some patients is going for 12 years, 13 years, 15 years. It is quite surprising for the doctors, but at the same time some patients is having even not fulfilling the criteria for a standard 7 to 8 years. So premature battery depletion, and particularly I'll not name, but Indian our make also in we are using so many variety. It is very common in setup.
Circuit problem, over a period of time, majority of the CRMs, they will have a recall, they issue that these are the problem with this models and these leads or this pulse generator. So that is basically is a manufacturing problem of early depletion of the battery. That's very, very common. Otherwise, if it is no manufacturing problem, we don't see until unless, if the device is not programmed properly. Many a times what we have seen, patient get an implant, and at the time of implant, the threshold is kept at 5 volt. And that 5 volt has not been reduced for next 5 years, although the threshold is less than 1. So it has not been programmed properly. leave aside that thing. So if it is not properly programmed, early depletion battery, that's totally a different thing. Otherwise, if suppose early, like, some of the patient, the battery depletes within 2 years, 3 years, that's basically manufacturing problem. It's not because of the implant or because of thresholds or any other lead parameters.
And regarding the standardization of the replacement of battery by various companies, particularly for the ICD, CRT, and this is very variable for various make. Some is giving for the even 5 years and 2 years before that the standard criteria is keeping up. So
means what I say, like how you can judge how much the battery is going to last, what the company is giving warranty. Suppose a company gives warranty of 10 years, like 10 years total full warranty of replacement free. And at the same time, the other company is giving warranty of 5 years totally free plus 3 years. What does it suggest? It suggests that, that the company which is giving 10 years warranty, flat warranty, probably that device is going to last more than 10 years. That is why they are doing, because see, these are all US based or a German based company. Like, they do so much research before coming out. So if they are giving more than 10 years warranty, said 10 years warranty, and at the same time, other guy is giving 5 years warranty, it means there has to be a difference of longevity of the device. Otherwise, it will be standard. All companies should give 10 years warranty. That is what I feel.
Does remote monitoring increases the battery, decreases the battery longevity?
Holter monitoring?
No, remote monitoring.
Remote monitoring, yes. So now, see, this is one thing. So there are two things in remote monitoring. One thing is how much data you are transmitting from remote place. That is very, very important. So if you are transferring your data from remote monitoring, it does decrease the battery longevity. And if you're not transferring your data, you're just checking that all the parameters within the range, it doesn't.
Thank you, sir. Thank you, sir. So our next speaker is Dr. Sanjeev Mukherjee, and his topic is troubleshooting in pacemaker.
Respected chairpersons, my co-speakers, my dear friends, good morning. I thank Dilip and industry for supporting in this conference. So after a great discussion on lead, PG, timing cycles, I am going to talk something on troubleshooting. So we are behind schedule, so I'll go very quickly. So when do you have a device malfunction? What are the situations where you will find that you need to troubleshoot a device? Most of the time it will either be an output failure. By output failure we mean that you will not have a spike, you will not see a spike, whereas capture failure is where you will see a spike but there will not be any complexes that the spike will form. The second thing is sensing. Most of these leads you will find many a times while you troubleshoot a device, it is mostly related to sensing issues. Either it will be an under sensing or what we call as under detection, where the lead is not able to sense the QRS. So in that situation, your pacing, you will get more spikes. So that is still okay. But over-sensing is something that we are all concerned with, because when you have an over-sensing, your device is not going to deliver therapy and you might have an asystole, especially in a pacemaker-dependent patient. So therefore, over-sensing is definitely a matter of concern. In pseudo-malfunction, we know pacemaker-mediated tachycardia, crosstalk, runaway pacemakers, all has been discussed nicely by Mr. Govind, so I'll leave it. So we'll go straight to some cases to look at how we can troubleshoot. So this is an 80-year-old gentleman, CKD creat 2.48, symptomatic twist to an AV block, had some LV dysfunction. So he was given a dual chamber ICD. So mainly we are looking at the pacing function. He did not have any heart failure episodes, and 7 days after the implant he got occasional giddiness, and this is the strip that you see. So what do you think we should be doing? So obviously this is not lead dislodgement. You still see nicely formed, well-formed complexes, but patient has got giddiness. We see, areas where probably the response, there is no capture. So what do you think is happening? So whenever you see such a scenario, my suggestion would be always go ahead and interrogate the device. It is always good to interrogate yourself, go and see what is happening to the EGMs. And EGMs are the one which will give you some answers. Always interrogating, while you interrogate a device, do it in different postures, right? You can do it in deep inspiration, deep expiration, hand movements. Ask the patient what symptoms are coming and when is it coming. Based on that, your programming or your interrogation should be targeted for. So this is what happened when this patient's EGM is taken in deep inspiration. So you look at the marker channel. The marker channel is called MC, or the marker channel. That is what the device is seeing. How the device is seeing what is going on is seen on the marker channel. So you see a Asense V-Pace in the first initial 3 beats. Then you see that the device is giving some horizontal marks. So it is not able to bin what it is seeing. So it is not there. So there is some delay, and again you start seeing Asense V-Pace. So in between, the device is not able to do anything. And why is that? Let's look at the atrial EGM. So atrial EGM nicely sensed A signals. What's happening in the ventricular EGM? Now if you look at the ventricular EGM, you notice that after the third beat, the third paced beat, there are some very high frequency signals, very rapid signals are there. And that is the time, if you look up on the ECG, the device is not delivering any output. So that is what is the problem. And again, you see that is settling. So this is something which is happening with cardiac cycle. So in this individual, what was happening? Now, what are the possibilities? So most of the time it is extracardiac. This was a diaphragmatic myopotentials that the device was sensing. So the moment there was deep inspiration, this was a large RV, there was a screwing lead which went close to the diaphragm, picked up diaphragmatic myopotential, stopped pacing, and again when the inspiration went off, the device started functioning well. And this was what they had to do finally was they tried to put the lead in septum. The septum R wave was less than 2 millivolts. They couldn't put it there. And finally, this was, this troubleshooting was done by changing the lead to a tined lead because screwing lead was not working. So what I am saying is, it is essential to pick up an abnormality and appropriately interrogate the device. 59-year-old male gentleman had a history of giddiness, dual chamber pacemaker before 10 years, PG change before a month. And on interrogation, we had a capture of 4.5 at 0.4 and an impedance of 6,000 ohms. So 12 lead ECG. What do you think is happening? So if you look at the ECG again, this is what you see: a P wave, you see a spike, but there are no QRS. So definitely there is what we call as capture failure. Now, in this scenario, this is an old lead, and there are only 2 things I can think of. Old lead had got a recent box change and has come with this. So whenever the clinical scenario is always very important. So you have this, there is, the patient has gone back to CHB, there is no, there are spikes, but no QRS. So obviously the next investigation would be to look for a chest X-ray. So obviously old leads doing well, leads are well placed. Now look at the PG. Now what has happened? So you can look at the lower pin that has not gone down well. So whenever you have got a box change and there is something happening very close proximity to it, most of the time, and this happens especially with ICD leads and DF1 leads where you have got multiple ports to put in, the leads are fibrosed, many a times, they will not go down well. So this is something we all must keep in mind. When you do a box change and put the lead in, initial part of career, we should be very, very cautious about your screw should be put well. You should screw it pretty well so that the lead is well in the header. If it is not, this is what you are going to encounter. We'll not go into theory. 60-year-old male admitted with a sick sinus syndrome. He was on anticoagulation for paroxysmal AF, had got a dual chamber pacemaker, RV lead in apex, RA appendage lead in standard position. On the first post-operative day, there was lead dislodgement, which was repositioned again, and he was discharged on an MVP mode switched on so that there is minimal RV pacing. Anticoagulation was on, and this is what is an ECG. So if you see such an ECG with an RBB, all of us who implant pacemakers very often will see that we have put the lead properly in the RV apex and still we will see an RBBB. I've just kept this case to discuss on this point. So when should I worry? When should I think? Many a times, when you go for rounds, you'll say, sir, RBB has come. Do you think the lead is in LV? So this is what is the ECG. Do you think this patient needs any further evaluation? You can send him home. So whenever you've got an RBBB, just try to see the X-ray properly. And this was his X-ray, and this is a lateral X-ray again to look at lead. And look at what is happening, definitely your RV lead is sitting posteriorly close to the spine. So it is not in the RV. The lead has gone through a septal defect into LV. So when you get an RBBB, right bundle branch block, there are specific things, and this was by Omken et al., a very nice paper, and that's why I've kept an ECG on the other side. This is what you should get. Two things you look at. Look at the left axis deviation. If your axis is leftward, -30 to -90, and you have got a deep S wave in V3, so your transition has, is by V3 you have got a transition, that means your lead is in RV. If that is not there, like in this scenario, look at RBBB. It all suggests that LV is getting depolarized early. So you have got RBBB extending till V3. There is axis which is not extremely left. So this is a left, the lead is sitting in the left ventricle, has gone through. In this case, they accepted it. He was on anticoagulation, no symptoms, but you can have embolism, you can have mitral valve damage, and this is something that you should keep in mind when you are getting an RBBB in spite of putting your lead in the right ventricle. Okay, this was a simple strip of a dual chamber pacemaker, and patient is otherwise all right. You see this, what will you do? Ask the patient to come back after a year, or do you think patient needs a workup? So in this strip, if I see, there is only one P which has not been tracked. Rest there are all P's, A-sense V-pace or A-pace V-pace, everything is looking fine, except for one P which is undersense probably, or probably not tracked, whatever it is. So always remember that whenever you see something which is not being explained, it is always better to investigate. And this is what the EGM is showing. Anything that you will notice here? So if you look at the EGM, the lower is the marker channel. Look at the marker channel. You've got an A-sense, you've got a V-pace. Pretty fine, all good. Then there is something that is happening. You've got a V-sense. That V-sense, there is no reason for a V-sense to come, but you see something that in the ventricular channel, the lead is sensing something. And the P wave that you saw, which you felt was an undersensed P wave, this P wave or a non-tracked P wave, is basically because of the timing cycles that Mr. Govind just discussed. That V sense has caused a P warp to come in. This P fell into the P warp, and that is why it was not tracked. So the lead is sensing something in the ventricle. And then if you move forward, you see again there are standard A-pace, V-pace, A-pace, V-pace, and again there is some sensing happening there. On the ECG, if you see, there is nothing. There are no signals for the lead to oversense. So the lead is oversensing something. And this was basically one thing you must always remember, that in the lead technology that we just saw, you've got coaxial leads. The lead, there is a conductor, then there is an insulator, and then you've got a conductor. So many a times this inner insulation can have defects. If the inner insulation have got a defect, then during cardiac contractility, the conductors can come in contact, start generating a noise, which the ventricular lead will sense and might inhibit pacing. And that is what was happening here. Patient was all right, asymptomatic, because there was no suppression of pacing. But for you, it is important to interrogate this, because now I know that there is something happening with the lead, and over follow-up, I will keep this in mind and let my patient know that he probably might need a lead replacement. Okay, 65-year-old male, dual chamber pacemaker implanted 11 years ago for complete heart block with normal LV function for the St. Jude. He presented with recent onset recurrent dizziness and presyncope, and this is what his ECG is showing. And I thank Dr. Devabruto, it was his case, and we had a discussion. So what do you think is happening here? So if you look at the ECG, again same, first A-sense V-pace, A-sense V-pace, then there is a P wave which is not tracked, and again you have got subsequently A-sense V-pace with the last P which is again non-tracked. So whenever you have this, you always remember that, because we do not see anything here, so most of the time it is oversensing. Now what is the simplest way to counter oversensing? Ask for a magnet ECG, because in a magnet ECG, there is sensing function which is not going to happen. So magnet ECG will give you some idea, and this was his magnet ECG. So you have, again, see everything is fine, A-sense, A-pace, V-pace, everything is there. So probably that sensing issue is taken care of. So your suspicion that something is being sensed was correct. Now let's go on the EGMs. So this is what is EGM. Top is your bipolar, down is your unipolar EGMs. And this was on the right, I have kept the X-ray, because many a times when you have this, you look at the X-ray leads. So leads were all in position. I'll just take 30 more seconds. So leads were all in position. But what is happening? In the EGM, if you look, after the third complex, there is A-sense in the atrial channel, and in the ventricular channel also you are seeing something during that A-sense. Now you may say that it is a far field from the A. It will not happen because this is not an A paced, it's an A sense. So it is not because of atrial that the ventricular channel is oversensing. So there is something that is oversensed. So again, in this case, it was basically because the lead in the ventricular lead, which was well placed in the RV apex, was sensing something in the far field. It was an insulation defect probably in the RA segment of the lead. Because of that, during systolic contraction, the lead was oversensing. And that is what, so this patient RV lead was changed and he did well. So this was again an insulation defect in the atrial part of the lead, in the ventricular lead, and during cardiac motion, there was noise that was being generated and that was causing an oversensing, and the device was not functioning. So again, here in this case, we had one important thing. Over 10 years, there was only 100 ohms fall in the impedance. So other parameters all looking good. So always don't go by basic parameters that all are good, so it should be good. And this was published in IPG. So I'll end here. Thank you.
Thank you, Sanjay Das, for such a compact and excellent discussion. May I have some questions from the audience, please?
Any comments from Atar Ali, sir?
One important troubleshooting, particularly for the long-term repeated, particularly change of the PG replacement, suppose 30 years a patient is on single chamber pace, and erratic behaviors of the at the time, sometimes firing with a VT, sometimes Brady with things. And sometimes we are facing immediately after putting up next day, third day, very erratic behavior of the pacemaker in dual chamber, particularly for like cross-talking and this. And one major, sometimes we are facing huge number of patients with having the sudden rate of putting up patient at 180, 134, particularly for 6 sinus type of behavior. Putting a Brady episode, sudden leading to 170, 80 of that. So this type of troubleshooting we are facing hugely.
Right.
So overcoming of, particularly for 6 sinus, whether trachea and Brady is the episode. For Brady we are facing, suppose single double chamber, landing up with the huge rate of this. This is the common problem here.
Right. So I think there are multiple questions. I'll take the first, I'll start with the first one. The first one that you said was erratic behavior. This can happen. We have a terminology called runaway pacemakers. I didn't go in detail. So this mainly happens when your battery life is depleted. Towards the end of the battery life, the pacemaker might start behaving in a very erratic way. You will have capture beats, you will have noise, that will cause suppression of pacing. So those things are known. That's called a runaway pacemaker. So moment your battery has reached ERI, it is time to tell the patient to quickly get it replaced. Otherwise, the behavior can many a times will not be explained by standard things. Second thing is about 6 sinus syndrome, and you talked about very high rates that you sometimes get. Now, for that, I would say that 6 sinus syndrome per se, if you look at, it is a symptom complex where patient will have episodes of Brady and patients will have an episode of tachy. So during Brady, your target in a 6 sinus syndrome should always be to avoid RV pacing. Make sure your atrial parameters are good. You have either programmed an MVP or a prolonged A-sense sensing delays are pretty long, so that there is only atrial pacing and no ventricular pacing. 2, this patient can have an atrial tachycardia, can have a sinus tachycardia. Part of 6 sinus syndrome, there your pacing will not do much, and there I think it has to be a medical management. So make sure that good rate control is there, and that should take care.
Great. Debu.
I have just a comment to make if there is 1 minute. Yeah. So as Sanjeev very elegantly illustrated, so especially for the beginners, so often we find a patient who has a pacemaker, and there is an issue. There are 2 comments I want to make, especially for the beginners. One is if a patient is dependent, especially ventricular dependent, any seizure-like symptom, any syncope, it is almost pacemaker related unless proven otherwise. Many times we have seen technicians or even doctors, we have told that everything is all right, patient is having syncope recurrence after a pacemaker. So always dig into detail. Number one. Second is look into the trends, as Sanjeev showed in the last case. So sometimes you find the trend of the impedance and the threshold. That will tell you a single point impedance will be normal, threshold will be normal. If you look at it, this last patient had the impedance was straight around 400, 410 for almost 10 years. And in last 1 year, there is 100 ohms increment in that. So that tells you, if you look at the graph, that will tell you that possibly the lead is the culprit. Third is the most or maybe the earliest problem in lead failure is oversensing. So if you can, if there's any proof of oversensing anywhere, your threshold may be normal, your impedance may be normal. Sometimes technicians say, okay, there is no lead failure, sir, because impedance is normal. Impedance can be 100 times normal. It is the last thing to get problematic in a lead failure. The impedance change, let's say increase or decrement in the lead impedance in a lead insulation failure or a lead fracture is the last thing to change. Other things, lead noise will be most often picked up very early. Sorry for the late.
Very important inputs, Niku. And with this, we come to the end. Thanks to chairpersons. And Trali sir, any final remarks from your side?
Sir, excellent session, sir. Thank you very much. And really I enjoyed all the sessions and really beautiful discussion. And thanks everybody, all the speakers.
So we had a fantastic, Debu, you have any comment? No. So we have fantastic first session which comes to an end. And now may I request chairpersons and moderators for the second session, Dr. P.K. Hajra, Dr. Uday Shankar Das, Dr. Sumit Shankar, and Dr. Amit Bhuwalia. And Dr. Ullas was the only dropout. Unfortunately, he excused himself because he had some very, very important commitment came up, personal family commitment. So he is not there. He has sent his presentation. So Sunil, can you upload the presentation?
Hello everyone. It is my privilege to be participating in this Device Update 2022 conference. Thank you, Dr. Dilip Kumar, for asking me to provide you the recorded presentation. It must be really great going there, and I'm certainly missing it. So Dr. Dilip Kumar asked me to speak about stillet-driven lead technology in context of conduction system pacing. Well, we all are aware conduction system pacing is recognized globally as the most physiological way of pacing. And so far, we have had the experience mainly limited with the Medtronic tools, which are called lumenless leads. And we always believed that there are certain shortcomings and we are in need of better tools and technology, and hence this is the presentation. Let's look at the C315 Medtronic sheath and the Select Secure lead, its pros and cons. We know that the sheath is quite a low profile. That's good. The lead is also very low profile, 4.1 French. That's again good. And of course, there is no discrepancy between the helix and the lead body profile. It is isodiametric, and most important, there's a huge faith in this particular tool and the lead globally, and so there's the largest experience. The limitations are we are handling a helix which is exposed. That's an unfamiliar technique of pacing. Since there is no lumen, we can't put a stillet, and hence there is a less supporting manipulation. Depending upon how many cases you do or you have done in the past, there is definitely a learning curve. The beginner may actually feel the curve to be steeper. Because there is a fixed curve, many a times we end up in some suboptimal results. To overcome the fixed curve nature of the C315 sheath, Medtronic brought a deflectable sheath, C304. It can actually get you almost everywhere. But the problem was it requires another tool, and it is a little more complex. And when we tried to launch this, we did it in March 2022. But then we believe that it is actually more complex than the regular 3315, and there are not many takers for this deflectable sheath. So when it comes to the Medtronic system, we have the C315 non-deflectable, very fragile sheath. And hence, we were looking for some more tools. And fortunately, we have as many as 3 players in addition to Medtronic who have brought their tools. They are the Stilet-driven leads. Biotronic and recently Boston, they have the fixed curves with their regular leads. Abbott stands out here in this technology because it has a deflectable sheath. And as we go through the presentation, we will understand several advantages of that Agilis His Pro sheath. Biotronic, which has a fixed curve and the regular Solia lead. Biotronic tools comes with 3 curves, and each curve has 3 lengths. Most often, the length that is used is 55, 39, and 42. Quite a robust sheath, several curves as I said, and the regular Solia 60 centimeter lead could be used. In fact, we were the first in the South Asia to use the Biotronic system successfully. Boston recently brought that their kit. It is called SSPC family. In addition to the left-sided sheaths, they have also a right-sided sheath. The experience is quite limited world over. We can use one of the 2 leads. I prefer to use the Ingevity plus 59 centimeter lead. Fine line lead could also be used, but it has its own limitations. So this is the Biotronic, this Boston, and there comes Abbott. Looks like very fancy, but I believe this is how the conduction system pacing program would evolve, because it is made for the recording of the intracardiac potentials, the right way of doing the conduction system pacing. Quite a robust. That could be a disadvantage as well, because it has a very large profile, 10.5 French. It has necessarily a single curve, there's no secondary curve. Quite a handful of the size, and the regular trending lead is recommended to be used with this sheath. We recently had a workshop on the Stilet-driven deflectable mapping catheter of Abbott Agilis His Pro. It was quite a learning. There were 2 experts in person and several experts online taught us how do we actually optimize using this large tool. And looks like everybody now is going to be taking this up, because this indeed is the right way of mapping and pacing, I believe. So this is an overview of the existing tools, Medtronic, Biotronic, Abbott, and Boston. As we understand that the diameter of Abbott is pretty large. We have a deflectable, but we need Abbott. Medtronic is not so popular. The lead size, the thinnest is the Medtronic. 6 is again large here. The FDA has approved all their tools of the Medtronic. I think over a period of time, Biotronic, Abbott, and Boston would receive some approval for the conduction system pacing. The greatest advantage of the Medtronic system is there's a large experience world over, but I think the other 3 systems are catching up. The methods using the Stilet-driven leads, deflectable or fixed curve, is no different from the way we use with the Medtronic tools. Of course, it is necessary that we map the conduction system, not necessarily exposing the lead, the helix. Without exposing the helix, a lead could be used. All the company leads, the Solia, the Ingevity, Fine Line, or tendril without exposing the helix, we may actually be able to map. Mapping could also be performed, as I said, with the Agilis His Pro Sheet. We always take the lead inside unprepared because I believe exposing the helix might cause injury to the conduction system. It may get entrapped in the chordae. Our default strategy of conduction system pacing always is to begin with the His bundle pacing because we strongly believe that is the way of doing the conduction system pacing. We may not be successful all the time. At least 30 to 40% of the times we achieve the His bundle pacing with good parameters and ensuring the stability. We go down for the left bundle area pacing only when the His bundle area, the capture thresholds are more than 2 volts, or the R waves are less than 2 millivolts, or maybe there is an issue about the oversensing. And definitely, if there is any degree of concern regarding the lead stability, we do not hesitate to go down towards the left bundle area pacing. But again, I would like to repeat, our strategy to begin with the conduction system pacing is to spend at least 20-30 minutes to look around the His bundle area. And we define the conduction system capture not different from anyone else, but I put it in here simplified because I think what intimidates the conduction system pacing practitioner is a huge list of criteria. But I think this particular slide has, I think, makes somebody to understand it in simple way. In the His bundle area pacing, we define successful conduction system pacing when at the site we have a distinct His potential, not necessarily going by the far field potential. There has to be a crisp His potential, and the pace QRS morphology identical to the native QRS with or without the aberrancy correction. Pace QRS, we wish that the lead 3 is not very positive. If it is very positive, it is going to be towards more RVOT area. In the left bundle area, in the unipolar tip pacing, we need to get a QR or R in V1, and we should always ensure that there is ring in the unipolar fashion is captured, while the tip shows the QRR pattern. The ring capture should show the W pattern, which ensures the stability. And sometimes you get QS in V1 in a bipolar configuration. We would like to have a short LVAT, and we would like to demonstrate the change in the morphology if possible to ensure that the conduction system is indeed captured. I would like to show some case examples to begin with the Biotronic tools, which we are very familiar with now. It is almost like 1 year plus months, very robust. I think it is a 55-39 curve, very robust. And this is at the His bundle. Pretty much the same way as what we do with the Medtronic. It's possible to delineate the septum, and then you have the stillet inside the lead. You have a great support, and then you can drill that lead inside to reach the His bundle area, all right. But when it comes to the left bundle area pacing, there indeed is a difficulty. Without creating a secondary curve, you can go only to the mid or the distal septum. For example, this is without making a secondary curve. You will end up, of course, getting good potential here. This could be left bundle or a fascicular potential because you are too inferior. Great potential, but then the axis usually becomes leftwards. You get dominant negative complexes in the limb leads. So this is the disadvantage. If you want to reach the proximal or the left bundle trunk, then you need to be creating a secondary curve. This video demonstrates how you can reshape the distal curve. Very simple. Hold it and twist it posteriorly and inferiorly with respect to the main curve. Simple. And because it is quite sturdy, it's robust, it's a braided structure, manipulating this lead does not damage the lumen, and this shape is retained inside the heart for a long time. So for example, this is a demonstration. At the end of it, you can have this kind of a curve, pretty much looks like C315 sheath. After reshaping, the proximal left bundle branch can be accessed this way. And look at the way, how solidly, how firmly this sheath is abutting against the septum. You will have great comfort in pushing the lead. About tendril lead, use the Biotronic stellate guide, make it as a single unit, and you can safely push it through the septum, continuously monitoring the change in the QRS morphology and the impedance. For example, a BOT tool, how we do it at the left bundle area. This is demonstrating you can actually delineate the septum very well, and you have this left bundle potential and proximal, almost similar to the Vito QRS, and having the positivity in the inferior leads. So you can reach, even with the BOT tool, left bundle area. There are certain challenges, particularly with the Agili-Sys Pro. As with other Biotronic and Boston, the availability of the lead length, the working length is quite less, is about 20 millimeters. There's another unique challenge when you use the Agili-Sys Pro is that you need to straighten the sheath before slitting. And when you do that, the braided design of the sheath tends to drag the lead. For example, it's actually a very anxious moment whenever you are, especially when you are lower down, the length becomes less, and the stability becomes a question. You need to make the sheath absolutely straight before you slit, and during that time there can occur quite a drag onto the lead. There is another challenge, and that is the slitter, I would consider, is low powered. It can cause quite an anxiety. It is not as friendly. For example, a couple of times we ended up in having the slitter broken during the procedure. For example, look at the original slitter with this insertable tool, which gets broken and stuck in this. So they need to bring a slitter as robust as the sheath. Boston tools, as I said, it's good. So ladies and gentlemen, I think we have wide choices here. Maybe we are spoiled for choice. We learned the technique using the Medtronic C315 select secure lead. A lot of an experience. As we gain experience, we also understand there are limitations. We wanted to do the conduction system pacing more widely practiced and using the system which we are used to, and that is the stellate driven, because we have been doing that kind of a pacing. So Thanks to the other companies, Biotronic, Abbott, and Boston, they are also the players now. We have a wide variety of tools. So I would like to conclude, conduction system pacing using stellate-driven lead with or without deflectable mapping sheet is gaining acceptance. That's a good news because ultimately the way we should pace is to pace the conduction system. However, there is always a room for improvement. The better tools are very much required for improving the success rate and to become the standard of cardiac pacing. Thank you, Dr. Dilip Kumar, and all of you, and you people have a great conference.
So, chairpersons can invite the next presentation, next presenter, Uday.
It's my pleasure. I would like to invite Dr. Shamuga Sundaram. As per Dr. Ullas sir, the little master of conduction system pacing.
I am so thankful to Dr. Shanmuga. So he came in 2019, I think January, and we did 4 cases that day. And all of them were successful. And since then, we could start our physiological and CSP program at Medica. And we are really, really thankful. We have been, able to do around 150 cases so far, proctoring maybe 30 cases. So credit goes to Dr. Shanmuga to lift this therapy in India. So it's better to hear from the master. Thank you.
Of course, the credit goes to Vijay Raman sir, who has actually nurtured us in getting into the real world experience. I would like to thank Dilip sir once again for giving me this opportunity. Like he said, every year I'm coming here, but for that COVID break, which happened as an online conference. So now my job is to discuss implantation technique with the conventional 3830 lead. So after a great talk by IHRS president, I can assure you that it is not going to be a debate, 3830 versus styler driven, but I'd like to simplify the technique where every one of us can take this wonderful therapy to the community level. These are my disclosures. Of course, why conduction system pacing? So not only for a cosmetically better ECG, we know that conduction system pacing is going to activate the normal physiological conduction system of the heart, thereby providing superior electrical and mechanical resynchronization. But the most important thing in our part of the country is to get a cost-effective cardiac resynchronization therapy. So if you can reduce the triple chamber to a dual chamber for providing CRT, it is all the more good for our population. Having said that, can all pacemaker implantation be a CSP? It's not the right time to answer this question, but probably I would say patients who needs a committed ventricular pacing, for example, who needs a pacing percentage of more than 40%, as an alternative for cardiac resynchronization therapy, in patients with an AV block and EF less than 50%, non-ischemic cardiomyopathy, and in ischemic cardiomyopathy with probably limited scar burden, pacing-induced cardiomyopathy where you have to just pull out the RV lead, if feasible, and put a left bundle or a his bundle lead, and you can use very well the same dual chamber pulsar. Another indication which is upcoming is this AVJ ablation, which was not being performed so frequently before the advent of conduction system pacing because RV pacing was not a recommended one for treating one disease. Tools for implantation, this has been already discussed by Ullas sir. We have delivery catheters and pacing leads to perform conduction system pacing, but the most frequently and most experienced tools for performing conduction system pacing is the 3830 lead and the C315 sheath. So there are certain important dimensions in the lead which we have to know before proceeding into left bundle branch pacing. So like all active fixation lead, this lead also has a helix of about 1.8 millimeter, And there is an anode which is 3.5 millimeter, which is going to be radio big. And the inter-electrode distance is going to be 9 millimeters. So this is very important because you're drilling the septum with this lead and you need to know exactly how deep you are going inside the septum. Though you can see the PACE QRS morphology, you can give contrast injection, all these things you can do. But if you remember this number, it will be very useful for you while deploying the lead in LAO position. Of course, we know the sheath, it has three dimensional curvatures. Two curvatures are there. One for facilitating entry into the right ventricle, the proximal curvature, and the distal septal curvature will face the lead towards the septum. EP lab provided an opportunity. It's always a luxury to do the procedure in the EP lab. So you have to have 2 electrograms if you have an EP lab. Connect the pacing lead, bifurcate the signal. One should go to the EP system and another one should go to the PSA system. In EP system, we need to have 2 different electrograms. One to identify the potentials, left bundle potential or his bundle potential. And second, most important thing is to identify the current of injury. Of course, if you don't have an EP lab, still you can perform CSP. So you need to monitor the ECG continuously, either with a 12-lead ECG system or even a TMT monitor, which gives you a continuous run of ECG in front of your eyes. And PSA will give you the intracardiac electrograms. Any scientific terminology needs definition. Left bundle branch pacing defined as capture of either the proximal bundle per se or even one of its fascicle along with the septal myocardium at preferably a low output. So the output capture threshold will be usually less than 1 volt. There are n number of criteria to confirm the capture of left bundle. The foremost thing is right bundle branch delay pattern. So you are pre-exciting the left ventricle, you are pre-exciting the left bundle. You need to have a right bundle branch delay pattern on the surface ECG. So that is probably considered as a major criteria. Apart from that, you need to have one more additional criteria that I'll discuss in the other part of the discussion. So this is how our EP system will look like, our working page will look like. We'll have at least 4 or 5 set of ECGs, and it's our practice to place a catheter across the his, to localize the his through the procedure, and the other catheter will go into the RV apex for backup pacing. So getting an idea of his location throughout the procedure will simplify the procedure and will help us in identifying the target zone. But if you don't have an EP catheter, if you don't have an EP system, just try to place the conventional TPI lead at RV apex, get a parabola-like configuration of that TPI lead, and you can see it from the picture that RV catheter summit corresponds to the his bundle. So if you don't have an EP system, if you don't have a his bundle catheter, just place your TPI catheter at the RV apex and use that summit of that TPI catheter as an equivalent of his bundle, and you have to go 1.5 centimeter below that area. So this is a fluoroscopic anatomy of the cardiac conduction system. You can see the summit corresponds to the distal his bundle, divides into right bundle and left bundle. The left bundle is little inferior and the right bundle is little anterior. Remember, your sheath or lead should not go and hit the right bundle, because in patients with an underlying LBBB, you are going to create a iatrogenic complete heart block. So you have to keep your sheath little below that summit of the RV catheter. Target site, like I said, there are 2 ways of identifying the target site. So one is anatomical, 1.5 centimeter below that summit of that RV catheter or below the distal his bundle. The second way is electrocardiographic identification. If you feel that that site is optimal, pace from the RV side of the septum, see whether you are seeing a W pattern in lead V1. Remember, this is seen only in 80%, the rest 20% they may not have this W pattern. And you should have a discordant QRS complexes in lead AVR and AVL. AVR will be negative and AVL will be positive. So like happens for any parahesian pacing. So it should have a discordant complexes in AVR and AVL. And I would like to get a predominantly positive QRS in lead 2 so that I will enter into the proximal bundle and not into the distal fascicle. So you have identified it, now you start deploying it. This is how Dr. Wang has described. So you have to start from the right side of the septum, give turn by turn, monitor the PACE QRS morphology, monitor the unipolar pacing impedance, because you want to know what is happening exactly at the lead tip. You don't have to bother about the anode, which is comfortably sitting inside the sheath. So you want to know what is happening at the lead tip, so you have to monitor the unipolar impedance. You can see how beautifully the notch on in the lead V1 migrates up to form an R wave. Just follow the lead B1 and as the lead traverses into the septum and as it traverses from the right side to the left side of the septum, you can see the notch on lead B1 gradually migrates up to form a QR pattern. And once you reach that area, you will be able to demonstrate the potentials. So identify the target sign in RAO view, deploy the lead in LAO view. That is how you will appreciate the movement of the lead, and you should have your hands dry before giving rotation, because that helps us in giving an effective rotation, and your lead part where you are going to give the rotation should be dry so that you will have an effective grip over the lead, and the rotation should be really rapid so that you will be able to penetrate the septum. So this is how we give rotations. We will pan from the RAO to LAO view, and you can see with a rapid rotation, the lead just traverses like a trace of a bullet from the right side to the left side of the septum. So simultaneously, you can see this is a case of a complete heart block. So as the lead traverses, you can see some PVCs getting generated. So when we started tracking these PVCs in 2019, we came out with an entirely different way of performing the procedure, what is known as a PVC guided approach. So in this particular methodology, we'll give rapid rotations. That rapid rotation will generate PVCs, and the generated PVC morphology, as you can see here, just track the lead B1. It starts from QS, that PVC morphology, and it ends at a point with the QR morphology. So once that QR morphology is reached, you have to stop giving rotations. You will be surprised to see that you will be in the left bundle zone. So that is how we do this PVC guided approach. This particular PVC is be labeled as a template bead. This template bead guided approach usually simplifies our procedure. It takes just 2 or 3 seconds, or in fact maximum 10 seconds to deploy the lead from the right side to left side of the septum. So we further changed these PVCs. We came out with yet another terminology, what is known as an M bead. So this particular PVC will have an M configuration. So lead V1 will be M, and it will have a slurred S wave in lead V6, and will have a routed configuration in lead AVR. The importance is this M bead PVC or M bead will be generated only if the lead is on the left bundle. So this all the more reassures you that you have reached the left bundle and not the left bundle area. Left bundle area includes the LV septum as well as the left bundle, but this M bead will tell you that you have reached the left bundle per se. So it has a low sensitivity, but it has a very high specificity, and in fact the incidence of the template beads or the PVCs when you are giving rapid rotation is going to be more than 90%. So to put it in a nutshell, to simplify the criteria, the one major criteria which I have discussed in the first slide is to get a QR pattern in lead V1. Apart from that, you need to have one of the other additional criteria. Though at least 12 criteria are available, take these 3 criteria, look into the patient's ECGs and electrograms and see whether one of these 3 criteria are satisfying. The first one is demonstration of the potentials. You will be able to demonstrate the potentials easily when you connect the patient's lead to the EP system, but even your PSA is going to give, it will be a sharp upstroke preceding the local electrogram. You can even do a contrast angio to show the depth of the lead, but the simplest thing is to look for the LVAD, or otherwise known as R-wave peak time. So measure the R-wave peak time in lead V5 from the pacing artifact to the peak of R, and you have to measure it both at high output and low output. For example, I measured here at 8 volt and 2 volt in lead V5 from the pacing artifact to the peak of R, and I've shown that both is constant. So if you show this finding, this particular finding is very difficult to demonstrate. So once you show this, you can confirm that you have reached the left bundle. And non-selective to selective capture transition, you can see some change in ECG morphology. You can see the 12 lead ECG here. The first 2 beats are non-selective, the last 2 beats are selective. You can see a distinct change in QRS morphology. Apart from that, see the local electrogram mentioned as LBVP. The first 2 beats, the electrograms are crumbled, but the last 2 beats, there is a distinct interval between the pacing artifact and the local electrogram. So this is how we demonstrate the capture transition. It can be either non-selective to selective or non-selective to septal. The Chinese have come out with yet another way of performing, again simplifying the procedure so that everybody can do it. So here you don't have to identify the his, you don't have to identify the potential target area. All you have to do is partition the heart in RAO view from below upwards, low segment, mid segment and high segment, then from above anterior, middle and posterior, so that you have 9 segments now. So what you have to do is, you have to take the lead at the junction of the 2nd and 2 and 5 segment. So 2 usually corresponds to the his bundle and 5 usually corresponds to the left bundle. So this is a much simpler way of doing it. Go to RAO, expose the heart in RAO at probably 25 to 30 degree, divide into 9 quadrant, quadrant number 2 will correspond to his bundle area. So if you want to perform his bundle pacing, go to that 2, you can do the procedure. If you want to do a left bundle pacing, go down and enter into zone 5, where you'll be able to get into the left bundle area. Of course, with the availability of 3D anatomical mapping, you can use a 3D system, either Insight or Carto. These days, people are even using an ICE or even a transesophageal echocardiography to perform a fluoroless left bundle branch pacing. Before finishing off, I would like to highlight the importance of recognizing the septal perforation. This is one important thing which everybody should know, because the utmost fear of performing this procedure is perforating the septum. So you don't have to worry about it. It's a much overrated complication. So we had encountered in at least 14% of our patients. All you need to do is identify these complications by these parameters: a unipolar impedance of less than 450 ohms, a current of injury, absent current of injury, that you can get it from unfiltered electrograms, or any one of these 2 patterns. So all these 3 things will tell you that you have perforated the septum. So what you have to do is, you should not just simply pull it back and leave it there. You have to pull out the lead, put it at a new site. So there are several ways of identifying a new site. I'm not going to go into the detail, but for just before completing my discussion, I would like to compare this styler-driven leads versus lumen-less leads. So these are the data. This is the data from Singapore, where they have quoted almost 12% loss of capture during follow-up. This is one data which is worrying, because loss of capture during follow-up, especially when you are doing it as an CRT alternative, it's a little worrisome, because the patient will ultimately end up in having recurrency of symptoms and fall in LV ejection fraction. So in our series, where we have used entirely the 3830 lead, the incidence is much less, 4.6% as compared to 12%. So this is one thing which you have to look into. So you have to choose the right tool, and probably for Brady indication, any lead is good. But as far as an CRT alternative, when you are doing it as an CRT alternative, you need to have a tool which has a robust evidence. But as of now, I think 3830 is probably a better lead when it comes to a CRT alternative. Thank you very much for the opportunity.
Thank you, Shanmuga sir. I have 2 questions. First is, how does left bundle potential or left anterovesical or posterovesical potential looks like? Sometimes it looks as artifact, or it is potential signal.
So usually potentials are very consistent, so you can get it in filtered electrograms, and it will be seen both in PSAs as well as in your EP system. Artifacts are artifacts, because usually it will not be that much consistent, but these electrograms are really good. It is a sharp spike which precedes the electrogram, and potentials to the QRS varies, depends on the site where you are. If you are on the proximal left bundle, it will be somewhere around 20 plus milliseconds. If you are closer to the posterior vesicles, it will be less than 20 milliseconds duration. But it should be consistent, and you can easily differentiate it from the artifacts.
The next one I have faced in my last case in 3830 lead, unipolar tip during pacing, its lateral activation is quite good. Its latency almost nil. QRS width is quite good, but whenever I've been doing bipolar tip and ring, its morphology getting changed. Yeah. And LAO septogram, I'm confident that it is penetrated well throughout the sheath, throughout the IVS, and through echo, it's almost just subendocardium on the left side. So whether it go for further turn, or we'll stop it, or we'll keep it in unipolar mode?
It all depends on how deep the anode is inside the septum. In fact, some people have discussed about the utility of anodal capture for further narrowing down the QRS, but many a times it produces a bizarre QRS like it happened in your case. So usually we go by what is happening with the unipolar pacing parameters, be it a QRS morphology or it is a pacing parameters. But ultimately we'll end up in programming bipolar. I have a session on programming also, I think after next Dr. Class talk. We ultimately will end up in programming at a bipolar output, but the pacing output will be less than the anodal capture output. We don't want the anode to pace, because sometimes the anodal capture will be good, as happens in a normal septum, normal LV function. Many times the anodal capture will produce a bizarre QRS. Right. It will be like a notched W pattern. So you just try to program it just below the anodal capture. Luckily, the anodal capture threshold will usually be more than 2 volt. That's what we have seen in our series. It will be usually more than 2 volt. So you can program at 1.5 volt or less than 2 volt, and you'll be able to get a better QRS.
Any question from the floor? Yeah.
Does stellate-driven lead has less fracture, less perforation as compared to 3830 lead?
No, perforation depends on how aggressive we are in getting the left.
14.2% is quite high.
Yeah, so perforation depends on how aggressive we are into the procedure and how frequently we are observing it and noting it. In fact, before our series, which was published 6 months back, the highest incidence was 3%. The Chinese quoted 3%, and we have only quoted 14%. In fact, in real world scenario, if you are going for a selective left bundle capture, the perforation rate is going to be very high. It all depends on documentation. And but when you speak theoretically, this styler-driven leads has better power of penetrating the septum. So if you speak theoretically, the incidence will be more if you are going to be more aggressive. But otherwise, I don't feel like there should be any difference. It all depends on operators' experience as well as operators' aim in achieving a conduction system capture.
See, Shanmuga, it also depends when we talk about perforation during the procedure or after we have finished the case. During procedure, I don't think it matters. You know, we come to know right away. But after the procedure, at least in our experience, we had only out of 300 cases, we have only one going to next day. But during procedure, yes, many times we feel that we have gone there, come back and take a new, and it really doesn't matter at all.
Exactly. So,
I don't know. I feel that the perforation actually may be less with the stellate driven because they are thicker leads. So, you know, 383 is a thin lead. It may go early. I don't know. Still, we don't know the
driving force is much higher with a thick styler-driven leads.
Right.
So.
You're right. So, I think a very nice session. But if I give my few cents here, you know, sometimes this can be done within 15 to 30 minutes if you have RV angiogram in front of you. So, initially started what Shomoga Sundaram has taught us, but nowadays we do a selective RV angiogram. Now, if you have a stellate-driven sheath from Abbott, you keep the wire inside the RV, and if you are seeing the septum nicely, then it's just a 10 minutes, 5-10 minutes job, because you know where you have to go, zone 1 to 2 or 3 and 4. Now, if you understand that his bundle is a cloud, and you know, is like a toll gate of the car toll gate on the highway. The toll gate, you know, the car always converges, and when they exit the toll gate, all the fibers, all the car or the expressway, they diverge. So if you really want to catch the maximum fiber, you go up, and zone 1 or 2, you said, 1 and 2. If you go down, you have to penetrate a lot of meat. Lot of meat means, if you understand the septum, the meaty portion of the septum is lowered down. But there, all the expressway are spread out. So you have to, either you catch the posterior fascicle or anterior fascicle. The different leads, you know, stellate-driven lead is very good in cases if you really want to do it from the right side. If you have existing ICDs or a lead, then it is little difficult for the 3830 because the maneuverability or entering in the RV, staying in the RV, because the RV is completely different now. The native RV without any previous device or lead is very nice to start your LVV pacing. But if you're upgrading your existing pacemaker to LVV pacing, then it is possible, but better to have a proper sheath like Abbott. The Biotronic lead is also good. So obviously, you can enter anterior, posterior, or exactly the septum. So how do you know that? If you have already entered and you just take the lead down, you do not know where you have gone. It may be anterior, it could be exactly in the septum, because it is two-dimensional. So once you see that a lot of trabeculae in the septum looks funny, it's like a saucer rather than a clear-cut straight line, then you come back in the RA, go back again in the RV, and if you see the septum properly, 1 to 3 zone makes you happy that you are entering in a quick chance.
So, Dr.
Then
Sarmuga,
rotation, you know, you can just go, you can come back. If you push the sheath, it will go in a different directions. Or you just pull the sheath, from 3 o'clock you can go to 5 o'clock, from 3 o'clock you can go to 1 o'clock. So if you never penetrated, just anti-clockwise rotation, come back. Then you change your course. This all depends on your experience, but it is very easy to do. It can be done on fluoroscopy. He has mentioned that continuous to 12 DCG, but have a print. without printing on fluoroscope, on your ECG machine or in your cath lab ECG, you can't make out whether the axis is good, the QRS duration is good. So have print every time, have angiogram every time. Okay.
We have Shanmuga will be available again, sir. So we will move on with the next presentation. Shanmuga will again talk on programming.
Just one question I have to ask. Sundaram very well experienced in his been study. So without EP study is it possible? In your experience, how much success rate of the procedure without EP?
So without EP system for Brady indication, I don't think so there will be any difficulty. So the success rate will be the same as with the EP system. But in patients with an underlying cardiomyopathy, the problem occurs. So there we need to get the help of the EP system. But otherwise, the success rate wise, I don't find any difference. But whether it is a left bundle pacing or a LV septal pacing, there comes the problem. If you take both together as an LBBB area pacing, the success rate will not be any issue. So it will be almost the same.
So we'll move on to the next session. Thank you, Shanmuga. Conduction system engagement, what and where to look and document. Dr. T.S. Clare.
Well, thank you, Dilip, for inviting me. But, we should be proud to feel that actually the conduction system pacing story started with Dr. O.S. Narula, our own Indian doctor in New York, who first demonstrated almost 30-40 years back that in a patient with the left bundle you could capture the distal haze and produce narrow QRS complex. And I certainly give a lot of compliment to Shanmuga, who popularized conduction system pacing in India. But I think we were the first to do conduction system pacing in 2015 with the help of our Italian friend. But then we lost, that time this 3830 lead was not available. We lost some interest. And thanks Shanmuga to wake us up again. So we took it very, very solidly from 2017 onwards. I think there is going to be a lot of the haze bundle pacing. See, when we talk about conduction system pacing, we are talking about either haze bundle pacing or we are talking about the left bundle pacing. And these are the anatomy is a very, lot of variation in the anatomy you must understand. So considering the anatomical approach may not be the ideal. So this is the conduction system pacing. You have the membranous septum. And the membranous septum, that it also separates the right atrium from the left ventricle, as also from the left ventricle and the right ventricle. Some part of the membranous septum separates the LV and the right atrium. This is to show in the another picture. This is the extension of the ventricular myocardium tissue over that plane toward the membranous septum. This is the reason for ventricular capture at higher output from the selective haze bundle pacing site and even in membranous septum, because there is some myocardium when you come to the distal portion of the left bundle. So the most common type, according to accounting for the almost 50%, is HV courses along the lower border of the membranous septum and is covered only by a thin layer of myocardial fibers. Type 2 is the most common arrangement in which the haze bundle runs within the interventricular muscle and is separated from the lower border of the membranous septum. Type 3 is approximately 21% referred to as also naked AV bundle. The haze bundle traverses immediately beneath the endocardium and courses into the membranous septum. At times, getting selective haze bundle pacing is not possible, or it may be very difficult due to anatomical variation in that particular patient. The same problem sometimes we can even face when we want to ablate the AV node. Recording of haze bundle may be difficult in some patients. So, anatomical fluoro-EGM correlation. Unfortunately, anatomy doesn't give that much. You have to have a rough assessment. Like here, you have a position 1, 2, 3, 4, 5. And these are the kind of electrograms you will get at number 1 position. Number 2 is a little above, lot of big atrium signal, a ventricle signal. If you go a little below, a small P signal and R becomes bigger. So depending upon the site, see, somebody asked the question, Dr. Panja, that whether you can do non-EP or without the EP lab. You can do that, but I think the conduction system pacing, at least you have to have a good basic knowledge of the electrophysiology of the conduction system. You can do that, but if you have EP lab, then certainly it is a much superior way. So when we see the proximal to his, this is the typical signal of the proximal his bundle, and when you go down, the A will become smaller and B will become bigger. So you have to know proximal to distal position. And typical distal bundle is this situation here. P wave signal is small. You have his, and this is the area which we would like to actually concentrate as far as the his bundle is concerned. So same thing to show in anatomically from proximal to distal bundle. You can see big A here, and when you go to this is distal bundle, this is a proximal his bundle potential. Now this is how the anatomy is. The from distal his bundle, proximal versus distal pacing. Distal his bundle pacing is preferred. Why? Because you could get it at a lower output, better R wave sensing, and lesser chance of atrial sensing and capture. If you are proximal, sometimes you can even capture the atrium, so that's why the distal bundle is there. Now proximal non-selective and distal selective. Here is the picture. This will be the fibers predestined to the right bundle, fibers predestined to the, just like a spinal cord, fibers start separating very early. Proximal to his bundle pacing sites, usually HV may be more than 55 up to even 70 millisecond. It can lead to non-selective his bundle pacing as the output requirement for correction is higher. Distal his bundle sites with HV are usually less than 55 milliseconds may have more chance of selective his bundle pacing due to lesser output requirement in the distal bundle. So this is typical, when you see the distal bundle recordings. Well, what are the, when you start pacing here, what are the possibilities? Recruitment at, you could have a his bundle capture but no correction. You could have a his bundle plus you can have a correction of the QRS complex. You can have a his bundle capture plus myocardial rupture, capture plus no correction. Or you could have a his bundle myocardium and correction, that's called non-selective his bundle. Or sometimes you can have atrial capture if you are a little bit above. Or if you are a little bit low, you can have only ventricular capture. Or you can have no capture. So these are the various possibilities when you start doing that. So now this is a slide to show native QRS on the left side. And if you see on the right side, it's a selective capture because the spike to ventricular spike is 45 milliseconds. So in its inception in 2000, this was described by Deshmukh et al. Narrow QRS complex, these are the characteristics of his bundle pacing. The pace ventricular interval is almost equal to the his ventricular interval. It has a lower pacing output. QRS widening is absent during his bundle pacing. If you increase the output and you capture the myocardium, it is still a little bit non-selective. So non-selective is that is defined as based on capture of the basal ventricular septum in addition to his bundle. There is no isoelectric interval in this between the pacing spike and the QRS. Recording of the his bundle electrogram on the pacing lead, you can do that. Electrical axis of the paced QRS concordant with the electrical axis of the spontaneous QRS complex. Narrowing of the QRS will occur at a higher output due to the fusion between the RV and the his bundle capture, and widening of the QRS will occur when you start lowering the threshold. So this is the non-selective his bundle. So if you see the his bundle pacing from spike to his bundle one threshold, There are two thresholds we have to keep in mind. One is the capture of the conduction system. The second is the correction threshold. So these are two different things and which we need to understand. For example, if you see this patient here, there is a capture of conduction system, but there is no correction in this particular patient. Now, non-selective His bundle pacing mechanism, direct or indirect, of QRS narrowing, it could be again His bundle, direct His bundle plus myocardium plus correction. It could be myocardium plus correction, that's indirect His bundle, and it could be only myocardium, ventricular myocardium. So if you see this picture here, direct His bundle pacing, non-selective to selective His bundle pacing. Here it is a His and indirect ventricular capture, but if you see on this, on the right side, it's a direct His capture with a narrow QRS complex, because you have there is no initial spike in this patient. It's like a spike followed by narrow QRS complex. This is a non-selective, this is a direct His capture. So, not optimal if the thresholds are not optimal, his capture thresholds are higher. Even if they are higher, that means it's not really optimal situation. Now here is a narrow complex with indirect His bundle in this this patient, but when you go higher, then you have a widening of the pace QRS complex in this patient. This is again to show the unipolar mapping and his current of injury, as Shanmuga said, is very important, but that can be recorded only if you have the EP system at implant 5 minutes later and 20 minutes later. This is when you have a good current of injury, that means the pacing is more likely to be successful in this patient. Now, just to show a couple of cases, this guy came with the recurrent syncope, intermittent heart block. Basically, there is a right bundle in this patient. Ejection fraction was good. And this is his current of injury. This is a good predictor of good chronic threshold if you have a good current of injury, as I told before. So, this is this patient had right bundle mass block, as you told you. And on the left side, is what is the His bundle pacing in unipolar. There's a big spike, and this is in a bipolar situation. This is the data from lower pacing threshold when His bundle current of injury is present. This, I think they compared the thresholds His bundle injury negative, His bundle positive. Threshold was lower as compared to you don't find the injury, current injury. P-value was very significant in this study. Acceptable pacing thresholds were achieved again when you have a good current of injury. If you see the right side, the left side versus the P-value was significant. So benefits of distal His bundle pacing are: measure the HV interval. Too big HV at the implant side may suggest more distal disease and may have higher correction threshold. Distal His location is preferred because smaller His potential, no or very small A wave, smaller HV interval always, a bigger V, lesser chance of atrial capture. Another patient, dilated cardiomyopathy. I had done the traditional CRT in this guy in 2015. He was practically non-responder. He came with the battery depletion. So we suggested him that we will have a conductive system pacing. So this is a QRS complex was 150 millisecond, and distal His bundle HV native was 82 milliseconds. And if you go further, we could achieve a QRS complex was 69 milliseconds. This patient. Now this is the thing to understand, that here you are recruiting there is a conduction system recruitment, but there is no correction. The QRS is still broad, and when this is the correction threshold, then the QRS becomes narrow and you have the 52 milliseconds from spike to QRS complex. This was the patient and he improved fantastically. Actually, I think traditional CRT failure is one of the strong indications to go to a conduction system pacing. This is the paced QRS in this patient. While we talk about his bundle pacing, our intention is always to try his bundle pacing distal. But we don't waste too much of time now. We go to left bundle pacing after just 35 minutes of trial. Now, unipole pacing is performed to assess for an ideal site to lead fixation, a paced morphology QRS complex with a notch in the. I think this has been covered by actually Shanmuga. We have a. There should be notch in the nadir of lead V1. AVR, AVL disconcordance, negative AVR and positive AVL, R wave in lead 2 taller than lead 3, that is a better site. So this is a good left bundle site on the septum, because if you see V1, you have a W pattern, and lead AVL and AVR are discordant, positive in AVL and negative in AVR, and W in V1. This kind of, if you find the picture when you start pacing on the ventricular septum, is a good site. So another example is lead 2, lead 3 are discordant in this patient, and in lead 2, R wave is more than lead 3. Lead AVL and AVR discordant, W you can see in the lead 1. So, missing the left band by starting too high, sometimes if you start too high, you may miss it, you have to come little bit lower down. Even though the lead 2 might be having small R wave or lead 2 might be negative to begin with, lead 2 should always be at least have an R wave. There should be R wave in lead 2. It is the good position, and sheath orientation has to be rectified according to that. So I think this has been already covered. You have the V1, give a little bit more turn, then you start the end of the V going up, and ultimately you get a good right branch run branch pattern. This is how you can show that you have capturing the left bundle selectively. You check the pacing parameters, and you have to, first rotation will have to be fast, but then you have captured the right side of the endocardium, then after that you go 1 or 2 turns every time and check threshold, track the everything, threshold. Many times you get good left potential, but it is not always that you are trying to look for the left potential. If you get a left potential, it's a positive sign, and that possibility of, is I'm crossing the time, PK?
Yes, sir.
Yeah, so I think I
so
will.
You can come and join the chair.
Yeah, I will rather shorten it. So there were 2-3 things I would say that now, Shanmuga told that you put a catheter at the his position. We don't use now the his bundle catheter at all. We don't do any temporary pacemaker from the iliac, from the femoral vein. We use the atrial lead. We first of all, we fix the atrial lead into the ventricle, and we do everything from above, perhaps just to avoid infection. We just do intracardiac, we go by monitoring of the EGM. So that is this is a typical situation of the. Now, when we talk about anodal, or you can have, like for example, this patient, you can capture anode in you can, like a QRS may be narrow, just you are capturing both the left bundle as well as the right bundle. But I think this is possible only in minority of the patients. Usually we always keep them in the unipolar mode, but few patients where we are happy that anode is being captured, we program in a bipolar mode. The problem, very occasional problem with unipolar may be if somebody has a diaphragmatic contractions. So then you have to convert into bipolar mode, and most of the times actually if you keep the anodal capture on, TOS worsens most of the situations. It's a few patients where you get a very good. So I think in the interest of time, another thing is he has already emphasized, it's very important to have the LVAD. So if your LVADs are below 75, that means you are doing good. Conclusion is that EGMs, intracardiac ECG, 12-lead ECG is very essential for conduction system pacing. At least some form of assessment by conduction system capture should be done during the procedure. Give some time to understand the system in that particular patient. Any of the differential threshold, differential ERP, left bundle, his bundle potential, and local V can be used for assessment of the conduction system. Unipolar and bipolar configuration must be tested separately. And nodal capture must be checked for during and post implant follow-up. AV interval timing also needs adjustment for conduction system from the his or left bundle. Proper training of the staff is required, and documentation is essential, as lots of information and parameter don't show up in the program. About Shanmuga's first slide, whether conduction system pacing should be used in every patient, well, though there is no word from the ACC/AHA at this time, but if you ask me, I will say yes, it should be used, because I don't think it is difficult. It is becoming, once the experience comes up, it's not difficult at all. Most of the patients we can get a conduction system pacing. Yeah, do we fail in about 5-7% of the patients? Who are those patients? Very big hearts, anterior wall myocardial infarction, septum very difficult to penetrate. We do fail in those situations, but otherwise most of the patients, I think conduction system pacing can be captured, and it's a great modality. We have also done many patients CRT with a double chamber pacemaker. They are done fantastically well. It's a poor man's CRT, but I will say it is a better scientific CRT than even the traditional CRT. Thank you very much.
Thank you, sir. Please join the chair, sir. Sir, you can come and join, sir. We have, sorry, the time says he's very apologetic. She's apologetic because she's running faster than the science. We have an elegant speaker. ECG, the proof of putting up any pacing, conduction system pacing is the final ECG the patient carries back home. So we have Dr. R.D. Jadhav, who's a friend of us, and he is in this business for quite some time. He's a versatile intervention cardiologist, from the holes to the ECG, ECG to the angioplasty, angioplasty to the mitral clip to TAVR, what not. Pan cardiologist. So, are you ready, sir? Okay. As Dr. Clare was mentioning, if you go too high, he may be like, if you do not know where your initial catheter is, if you start from the RV apex, you are sure that you are not penetrating the separate liplet. And that's the most fibrotic part. What's your comment, sir?
Because we have time, so I don't know, PK said RV angiogram. We don't do RV angiogram. Actually, I don't know whether there is anybody who recommends that. I don't know, Shanmuga, you do? We don't do RV. Yeah. Some of these patients, I think, even they are sick, so giving dye, giving an angiogram may be additional burden, but if it helps, fine.
I think you just give just 2 cc, 3 cc, not very light, just to have, but you have to keep the wire, that 3.5. Are you ready, sir?
It's not projecting their
The high creatinine you should not do. The Medtronic sheath can take 2 cc, Biotronic can take 5 cc, St. Jude can take 5-6 cc. But definitely if you have sick ventricle, the limit is, yes sir, please.
Yeah. Sorry for the delay. Many things has been already discussed by Dr. Shanmuga as well as Clare sir. I can only say that conduction system pacing can be successfully done only with the 12-lead ECG. So you have to know the 12-lead ECG and its changes may not need EP system. And because I go also like Shanmuga to do cases other places, only they have availability of only 12-lead ECG, and based on that we do the conduction system pacing, particularly the left bundle pacing.
but I will here discuss something more about that. So physiological pacing entails capturing of the cardiac conduction system, his bundle or left bundle branch, in order to prevent or correct pacing induced or LBBB induced electrical and mechanical dysynchrony. Physiological pacing may involve his bundle pacing or left bundle branch pacing, his bundle pacing along with the LB pacing, that is the hot CRT. Few cases has been shown by Dr. Clare sir. Left bundle branch pacing along with the LB pacing, that is the lot CRT. This term was given by our Shanmuga. And his bundle lead can capture the his bundle, can capture the RV myocardium, can sometimes capture the atrial myocardium, that you have to distinguish with the ECG. LB lead, left bundle lead can capture the left bundle trunk, can capture the left anterior fascicle, can capture the left posterior fascicle, or it can capture the left ventricular subendocardial myocardial septum. And you have to distinguish, and in addition to the anode may capture the RV septal myocardium. So you have to distinguish which part is captured by your lead by the ECG only. And so confirming that conduction system capture has occurred, conduction system capture results in faster and more homogeneous depolarization of the left ventricle than myocardium only capture, because myocardial conduction is slower as compared to 1 meter per second, whereas cardiac conduction system pacing is 2 to 4 meter per second. Confirming capture of the target conduction system is important to achieve the goal of maintaining or correcting ventricular dysynchrony. ECG is the primary means of confirming the cardiac conduction system capture. Variations in QRS morphologies during pacing, however, Sabal, need to be recognized, because that is the way whether conduction system has captured or not, you can determine. So, why is the QRS morphology different in conduction system and myocardial capture? Because conduction system and myocardium have different electrical properties that are exploited to decipher what is being captured. If conduction velocity, that is the rapid in conduction system, where is slow in myocardium, so that will have, if myocardial capture is there, QRS duration will be bigger, R wave peak time will be, R wave V6 R wave peak time will be longer, and capture threshold may differ in the conduction system and the myocardium. As you know, the capture threshold of the conduction system is even lower, whereas in myocardium is higher. So that is called differential differential output pacing technique, which I will show one case. Refractory period, then conduction system and myocardium have different refractory periods. Myocardium refractory period is shorter as compared to conduction system refractory period. So program stimulation or burst pacing or VO pacing, that is the asynchronous pacing, can determine which one is captured, whether the conduction system is captured or ventricular or myocardium has captured. Transition from paced QRS morphology from one to another is the mainstay of confirming the conduction system capture, whether the conduction system has captured or failed, or myocardial capture has occurred by changing the threshold, voltage threshold. So methods to confirm conduction system capture is the intrinsic rhythm. Look, here you need EP system, but potentially his bundle potential during intrinsic rhythm, left bundle branch or left posterior or left fascicular potential during intrinsic rhythm. Absent of any underlying left bundle potential will be absent if there is LBBB, may be retrograde during complete AV block, not seen in majority and not essential to be present. So you may not need EP system for that. Stim to QRS, you have to look in the ECG. Selective conduction system capture, there will be a delay akin to his bundle or left bundle to V or left fascicular potential to V interval, and that is the isoelectric line, there will be there. And myocardial capture very short or absent, so it's maybe they are delta-like thing because of the initial myocardial depolarization. Paced QRS morphology, similarly to have baseline or QRS duration, correction of bundle branch, and look for notch, slur, plateau, and V6 R wave peak time. Transition in paced QRS morphology by using differential output pacing, program stimulation, and burst pacing. So here, this is one of the examples where the his bundle pacing is there, where the stimulus to V and the HV interval will be equal. Stimulus to QRS end, QRS onset may not detect by pacing spike. So you have to measure from the QRS stimulation spikes to QRS end, which will be equal to his to QRS end. Paced QRS duration will be equivalent to intrinsic. Morphology is like intrinsic here. And in second case, non-selective his bundle pacing, stimulus to V interval will be shorter. Stimulus to QRS end and hitch to QRS end will be equal. and pace QRS duration will be longer, slightly longer than the intrinsic. Morphology, you will see some delta-like initial wave, delta-like wave, whereas in myocardial only capture, the stimulation to V interval will be shorter than the His interval, and there will be stimulus to QRS end will be longer because of the wide QRS, slow conduction, and pace QRS duration will be much longer than the intrinsic conduction, and morphology will be like of the some bundle branch block. So this is the selective His bundle capture, and second one is the non-selective His bundle capture, and third one is the non-selective His bundle capture along with the left bundle branch block, because if the bundle branch block is below your lead, it will have that bundle branch block. If non-selective His bundle pacing with RBBB, if the bundle branch block has occurred below that, those things will appear. And so, and also the correction will depend upon the voltage, which I will show here. In the first case, is selective His bundle pacing. As the voltage is high, selective His bundle capture will occur with a isoelectric line, and as the voltage will come down, there will be capture failure and pacing failure. There occurs, capture failure will occur. Where in second example B, there is non-selective His bundle capture, and as the voltage you will decrease, there will be selective His bundle capture. Particularly if you have your lead in the first case, lead is in the middle of the His bundle where there is no myocardium, whereas in the second B, the lead is near the myocardium where you have myocardial capture as well, so there is non-selective myocardial capture. And in third, where in C, non-selective His bundle capture, and once you lower the voltage, then only myocardial capture will occur, and there will be no His bundle capture anymore. Whereas in D, selective His bundle capture with LBBB, there is a correction, and because the LBBB has occurred, the lead is below the left bundle branch block has occurred, so it will have correction. Whereas if the lead is or you can increase the voltage. If you can increase the voltage, there will be correction. If you have no voltage increase, you lower the voltage, there will be no correction. So higher the voltage, you can recruit the non-blocked part also, and you have conduction. Similarly, in the E, if you have seen that there is a non-selective His bundle pacing with correction because of recruitment, selective His bundle, as you lower the threshold voltage, selective His bundle pacing with correction, and as further lower the your voltage, selective His bundle capture without correction. So this type of correction will depend upon whether the high voltage you recruiting or not. And the last one, F, where is right bundle branch block has occurred, where is high voltage you are recruiting, conduction is corrected. In middle one, voltage, non-selective His bundle, correction is there, but at lower voltage there is no correction, so RBB will be appear. So this will also depend upon the voltage. Higher the voltage, you will have four type things can occur: selective capture, non-selective, then selective His bundle capture, and then loss of capture. Same thing what I have described there, it has been there. You can look for by the program pacing also, that if you give atrial extra, lead extra, ventricular extra by this pacing lead, and you can see failure of capture because of the refract. It's the myocardial capture is there because of the refractiveness of the conduction system capture. Then morphological features, if you see, if the conduction system is captured, then the R wave peak time in V6 will be below 100 milliseconds. Whereas if it has failed, myocardial capture has occurred, it will be more than 100 milliseconds. So this is distinguishing the non-selective His bundle pacing from the myocardial only capture. If you see the lead 1, where there is sharp pointed in lead 1, and once the myocardial capture has occurred, because failed, as you have decreased the voltage, myocardial capture has occurred, the conduction system capture failed, there is a plateau, and you can see there is a notch in the V1 and V4, there is slur. So notch, slur, plateau means myocardial capture is there, not the conduction system capture. Same thing here. Here left bundle branch patient having started the pacing, this is non-selective Higgs bundle capture with correction, it is 160 milliseconds, and without correction, there will be no change. Slur is seen in the V5, V6. Then R-wave peak time and QRS duration in conduction system pacing. R-wave peak time in V6 differentiate non-selective Higgs bundle pacing from RV septal pacing. There is a peak duration is different. That is below 100 is conduction system pacing, above 100 is right ventricular septal pacing along with the morphology. R-wave peak time in V6 also differentiate non-selective left bundle branch pacing from left ventricular septal capture, but here there is a lot of overlap. You cannot make with the duration that you have captured the left bundle or you have captured the septum, LV septum. So with that LV septum, this doesn't hold true for the V6 time, but there are other techniques for that I will discuss. QRS duration is not useful for differentiating non-selective left bundle capture from the LV septal capture, because they look almost similar and almost identical. Although long-term benefit is there or not, that we cannot tell at the present moment. So algorithm for ECG diagnosis of loss of non-selective Higgs bundle capture, that if you see QRS node, slur, plateau in lead 1 or V4, V6, then yes, it's a RV septal. If no, then look for V6 R wave peak time more than 100, that means it's a RV septal pacing. If not, then our conduction system, non-selective conduction system pacing. Look for the ATL capture with the Higgs bundle pacing lead, because here you have isoelectric line which is equivalent to HV interval. Once the another 2-3 more minutes, sir. Okay. You're the master. So here the PR interval will increase, and you may confuse that it is, you will say initially it's a Higgs bundle pacing, but that is spikes to QRS interval is long, that means it's a ATL capture. You may or may not see the ATL electrogram properly. Now, confirmation of the left bundle branch pacing capture, already discussed by Dr. Shanmuga as well. Successful left bundle branch area pacing is considered when 3 of the following criteria are met: paced QRS morphology, RBBB pattern, presence of left bundle branch potential, left ventricular activation time measured from the stimulus to R wave peak time, V5, V6, and short and constant high and low output pacing. The LVAT will be constant, it's same whether you pace at 5 volt or 1 volt, it will be same. That means it has captured the conduction system. That is the left bundle pacing has occurred. And determination of selective and non-selective left bundle branch pacing. Selective left bundle branch, again you will have a latency between the stimulus to QRS isoelectric line, and discrete local electrograms separate from stimulus artifact can be seen. Just you will see the spikes and then the stimulus, stimulus and then the electrogram. Non-selective left bundle branch pacing, no stimulus to QRS latency, immediately starts the electrogram, ECG electrogram, and no discrete local electrograms separate from the stimulus artifact. Evidence from direct left bundle branch capture can be seen. Here, left bundle trunk pacing, axis will be normal. Left bundle anterior fascicular pacing, axis will be right axis, because your lead is more looking towards the up, and left posterior fascicular pacing axis is down. That is the left axis deviation will occur. And in procedural outcome, whether you are pacing the left bundle trunk pacing or left bundle fascicular pacing, there is no difference in outcome, overall outcome. The ECG patterns confirming left bundle branch capture, differential output maneuver, which I will discuss, non-selective to selective left bundle capture, non-selective to myocardial only capture, program extra stimulation, drive train of 8 beat followed by extra beat, non-selective to myocardial only capture, non-selective to left bundle only capture, single or double extra you can give, or ventricular overdrive pace, VOO pacing you can give slightly longer cycle length, and see at what capture what has happened. Like here, transition from non-selective left bundle branch to selective, already is discussed by sir also, selective left bundle branch capture. So if selective left bundle branch capture will occur, then you see there is a S wave, appearance of the S wave in V6, as well as there is a S wave in lead 1, and other leads as discussed previously. So increase in V1 R wave peak time and V6 R wave peak time remains stable. V6 R wave peak time remains stable. It is when you LBB capture, the V1 R wave peak time increases. Oh, battery is low of this machine.
Yes, your battery, not ours.
Can I go or stop?
Thank you.
Sir, I think Shanmuga has to catch
Should I
a
go or
flight.
stop?
He has to
So,
catch a flight, so we can we go to the last slide, sir?
Almost. So, appearance of broad, slurred, notched R wave in V1, V2, or increase of S wave amplitude in 1 and V6, which already I have discussed, and discrete potential. Now, native QRS and paste QRS R wave time here, I am just skipping. Another thing, LV septal capture, how will you know? If the distance between the R wave peak time V1 versus minus R wave peak time V6 is more than 33 milliseconds, that means it indicates left bundle branch selective capture. So this is one point, V6 minus V1 interval criterion is important. This is one of the case where RBV with complete hard block, intermittent complete hard block, they have put the left bundle pacing, and there is, if you see, anodal capture has occurred, so there is a initial, instead of R wave, initial QR pattern, and at 2.5 volt, and once the voltage has decreased, further bipolar capture has, from bipolar capture to the bipolar capture, because 2 volt above bipolar anodal capture will occur, below that it cannot, so it becomes RBV will appear, selective left bundle capture has occurred, and so loss of anodal capture is here seen. Unipolar tip to RV coil, so you are doing the tip to, so similar left bundle capture, selective left bundle capture is there. If you have unipolar tip to RV coil, same capture is there, but if LBBB ring to RV coil is there, same, you have your capture of the ring, since your ring anodal stimulation is there, so there will be LBBB like pattern.
Thank
so
you.
Same thing has been discussed. So program stimulation I am not going to discuss because it's really slightly complex, not more, and perforation is already discussed by Dr. Shanmuga. I am not going to discuss about that. So goal of conduction system pacing is to maintain or restore physiological activation sequence of the ventricles. Confirmation of the conduction system capture by his bundle or left bundle branch is critical during implantation and is guided by QRS complex morphologies. Conduction system capture results in faster, more homogeneous depolarization of the left ventricle than myocardial only capture. His bundle system and myocardium differ in their capture threshold, refractoriness, and that is used in program stimulation to know whether your his bundle has captured or left bundle has captured or whether myocardial capture has occurred. Dynamic pacing maneuvers are used to utilize these differences to confirm the conduction system capture. When perforation of septum by lead occur, lead to drop of the impedance below 450 ohm, loss of capture and loss of current of injury or change in current of injury. If you connect both the anodal as well as the cathode tip, then you have tip, there is no injury in the tip, you have current of injury in the anode. Or if you pull the lead into the position, then current of injury can appear in both.
Thank you, Dr. Jadhav. Please join the chair here. By the time Dr. Shanmuga get ready, one quick question, the final ECG endpoints, is it different from his bundle to your typical LBB pacing, Dr. Claire? And is there any role for 3D mapping in a luxurious situation?
Well, I think, yeah, there will be role in the 3D mapping, but I think that is more or less, that will be, mapping will be more for, new research rather than a routine practice in medicine. There is a, you can, like you can locate the his bundle, tag it, where the bundle is. But I think practically speaking, 3D mapping may not have a role in the long run. Dr. Sarah, my friend in Milwaukee, they have a system, a new 3-dimensional. You can map the left bundle very early. That's what they claim. But ultimately, practically, I don't know how much role they'll have.
I will take up few questions after we run up through the session. Over to you, sir.
Having discussed the implantation techniques and ECG features, now it's the time to discuss about programming the device. Can I have the slides, please? So these are my disclosures. So we know that CSP has gained significant momentum, at least in the last 5 years in India. So with the availability of better hardware, the procedural success is going to be better. So though there are dedicated catheters and leads available now, we're still using the same devices. So you have to be little careful in programming the devices because these devices are not primarily meant for CSP. So running a device clinic is, an effective device clinic is very important. You have to scrutinize. You should not leave it with either your techs or staff nurses because the CSP is entirely new thing. So even we don't know the long-term safety of left bundle pacing. So you have to be very careful. You personally sit in the device clinic at least for the initial 6 months or so when you start the CSP program. And it is our practice, like in any medicine, you need to have a good clinical history because any patients with a dilated cardiomyopathy who has undergone a CSP is coming back with a recurrency of symptoms which happened in a couple of our cases. A patient had actually a micro dislodgement and loss of conduction system capture. So this is very important. Getting an history even before taking the patient for a device clinic is very important. Trellis DCG is fulcrum of the device clinic. Program system analyzer, of course, our industry partners, they'll have it in their hands. Echocardiographic follow-up, at least for left bundle pacing, we need to know how the lead is behaving inside the septum, and echocardiographic assessment of LV fraction, LV ejection fraction. And in patients with heart failure, if you have the luxury of doing NT-proBNP and 6-minute walk test, you can always do it. It should be an integrated approach. Follow-up timeline, there is no proper defined set guidelines, but this is our practice to see the patient at the end of 15 days, just to see how the wound is and get the parameters checked, then at the end of 1 month, and after that every 3 months thereafter. As I said, the devices are not primarily meant for doing CSP, so it's a must for the techs to label the devices as a CSP device, and you have to mention it clearly, it is his bundle pacing or left bundle pacing. And mention the connections. It's very important because with an availability of DF1, the connections have become really crazy. I can show you how confusing the connections are. So you have to mention which lead is connected to the which port of the pulse generator. That's very important. Device configuration, as simple as that. If you are putting a single chamber, there is no doubt the ventricle lead will go to the ventricle port. If you are doing a dual chamber in a patient with an underlying sinus rhythm, again, there is no confusion. The atrial lead will go to the atrial port and the CSP lead will go to the CSP port. The confusion occurs when you are doing it for an AFib, ABJ ablation. So you will have luxury of using a dual chamber pacemaker. So many times you will end up in connecting it to the atrial port and the RV backup lead will take the ventricular port. This has its own implications while programming the device. In CRTP, if you are doing it in sinus rhythm, A will go to A and CSP will many times go to RV and the CS lead will go to its conventional port. If the underlying indication is AFib, when you are doing a CRT, CSP again will go to atrium to confuse us, and RV and CS will go to their respective ports. Just to confuse us still further, so we have a DF1 lead which is actually resurging in clinical indication. We can perform a LOT CRTD or the recently coined terminology LOT ICD with a DF1 lead. So where the atrium will go to the atrial port and RV DF1 coil will go to the TF1 port of the PG, and the CSP lead will go to the RV patient's port and CS will go to the CS port, LV port. In LOT ICD, where it is nothing but a dual chamber ICD, the atrial lead will go to the atrial port, RV DF1 to go to the DF1 port, and CSP will go to the CSP port, RV port. I'll just show you how the connections will be. So this is how the LOT CRTD will be performed. Here 4 leads will be using. So as I said, the atrium will go to the atrium, and the DF1 lead, you know, it will be either bifurcated or trifurcated. So we don't want the pace sense coil of the DF1 lead. You have to cap it. And the defib coil, whether it is an SVC coil or an RV coil, will go into their corresponding port, and that pacing sensing port in the chamber will take the CSP lead. So we are converting a single lead into a dual lead now. So the ICD lead will function as only a shocking coil, and the CSP lead will function as a pacing coil. Of course, you have a CS port or LV port where you can attach the LV lead. This is how this LOT CRTD works. So we tried converting a dual chamber ICD into a CRTD, so by what is known as a LOT ICD, where again a DF1 lead is utilized. We'll cap the RV pacing sensing port of this coil, and DF4 lead goes into that corresponding section. So into the pace sense part of that PG, the CSP lead will go. So this is how a dual chamber ICD will be converted into a LOT ICD. Pacing mode, of course, single chamber, there will not be any doubt, it's going to be a VVI mode. Dual chamber depends on the underlying indication. If it is for a Brady indication, for example, 6 sinus you are performing dual chamber, just prolong the AV delay, keep your search AV stresses on, and make sure that the patient gets his or her own AV nodal conduction. But if it is done for on CRT indications where you are putting a dual chamber pacemaker, keep everything off, allow the ventricle to get pace from the CSP lead, so the managed ventricular pacing algorithm should be kept off. If the CSP is connected to the atrial port, that's where the confusion arises. You should not be programming into a DDD mode because all the crazy ventricular pacing on a vulnerable period will occur. So it's better to pace in a DDDI mode, which in fact allow the device to function in the ventricular timing cycle, because we know that the ventricular lead is now in the atrial port. So it's better to program it in the DDI mode. Pacing polarity, like discussed in the previous session, the S bundle many times will pace in unipolar configuration. And almost always in our center, the left bundle will pace in bipolar configuration, but we'll try to keep the pacing output less than the anodal capture output. We don't want the anode to capture unless it's going to give a beautiful appearing QRS, but at the expense of draining the battery. If the CSP is connected to the LV port, we know that the LV port will not have a unipolar configuration, so you can use some extended bipolar configuration by pacing from the CSP tick to the RV ring. So these are all the options available for pacing polarity, but many times left bundle pacing means it's more of bipolar rather than unipolar. Pacing outputs, it has to be individualized. It's based on the underlying indication and underlying capture threshold, so it has to be individualized. Remember, a clinically programmed output, almost always the left bundle pacing is going to be non-selective. So whether you are getting a selective capture during implantation by showing that classical transition, it doesn't matter because you are going to program at an output of more than 1.5 volt. Many times we will be giving at least 1.5 or 2 volt as an output. So clinically programmed output, it is going to be non-selective. Role of anodal capture is plus minus. If your QRS is looking better with an anodal capture, you can always go for it. But I always try to program it below that anodal capture threshold, at least to conserve the battery. The major thing is AV delay optimization, which plays a vital role when you are doing CSP as an alternative for CRT. For his bundle, we have to subtract that 35 to 55 milliseconds, which we know that that is a HV interval. And for left bundle, we are little below in the conduction system, so you have to subtract 15 to 30 milliseconds from the usual programmed AV delay. For example, if the CSP lead is in the atrial port, that means that there is one more lead in the ventricle, so you just have to program the AV delay out so that you don't want the RV lead to pace. But on the other hand, if the CSP lead is in the LV port, you can use it like any other CS lead. You can utilize that adaptive CRT algorithm to pace it exactly at the time when the RV is getting activated through the RV AV node and right bundle, and LV can get activated through the CSP lead. In LOT CRTD, you have to optimize the AV delay. I'll just show you an example. This was one particular patient who had undergone a dual chamber pacer for a left bundle branch block, LV dysfunction. The first few QRS complexes are at an AV delay of 30 milliseconds. She had a robust AV nodal conduction, which was not allowing us to program at a longer AV delay. So at 30 milliseconds, you can see V1 is showing a beautiful QR. When I reduced it to 60 milliseconds, the R wave came down little. When I reduced it to 70 milliseconds, I had completely masked that RVVV delay pattern. So this is how we usually optimize the AV delay when you are doing it for a CRT indication. And I can assure you the most beautiful appearing QRS will be there in your ECG if the baseline indication is LBBB and if you are going to do a better AV delay optimization. There are a lot of device specific features which you have to keep in mind when you are programming it. Like I said, if you are doing it as a CRT alternative, turn off this search AV stresses. We don't want a device to search for native AV nodal conduction. Turn off this managed ventricular pacing. Make sure that your pacer is pacing the patient at 100% of the time, because we know that even in a BiB pacing, 100% pacing means the patient will do better on a long-term follow-up. As far as ventricular safety pacing is concerned, you have to turn it off, especially when the CSP is connected to the atrial port in AFib patient, because the sensed ventricular event will elicit a safety window period that's going to produce a pacing spike on a peak of R wave that's going to precipitate arrhythmia. So VSP should be kept off, and automatic AV delay, VV delay optimization are not primarily meant for the CSP, it's all meant for conventional CRT. So we don't know what to do, it's better to turn it off rather than keeping it on. A triggered ventricular pacing algorithm, especially in patients with an underlying indication for CRT, you have to keep it off. So ICD programming, you have to be very careful when you are connecting the CSP lead to the atrial port, because many times since we are reversing the lead, this ICD itself will reverse the diagnosis. It can diagnose VT instead of SVT, it can diagnose SVT instead of VT. So you have to keep off the dual chamber algorithms, and you have to keep the single chamber algorithms, discriminator algorithms on to make it sense properly the underlying arrhythmias. So in fact, the devices can be used to show this capture transition. So this can be there even after 2 or 3 years. I had a case where I had implanted in 2019 left bundle pacing. Till last week, his device integration showed this classical non-selective to selective transition. So on follow-up, it is our duty to confirm that these patients are getting consistent conduction system capture, be it in the his bundle or the left bundle. So you have to show this typical capture transition. You can see the EGM showing a distinct pacing artifact, which I marked as an arrow, followed by the local ventricular electrogram. Even the leadless ECG on the top showing a characteristic changes when there is a capture transition from non-selective to selective. So with the advent of using this CSP lead for arrhythmia sensing, all these nonsense features can occur. So you have to always follow the sensitivity very carefully. This one particular patient where the CSP lead was connected to the patient's port of that DF1 lead had oversensing of T wave. So this you have to be very careful, because they can get an inappropriate shock. So we are just investigating whether this will hold good or not. Luckily, this patient didn't have any inappropriate shock, but you have to keep an eye on it, follow these patients carefully so that they should not have an inappropriate therapy. So just to put it in a nutshell, things to look for during follow-up: assess the capture threshold, which is very important, both in unipolar and bipolar. Assess the pacing impedance, both in unipolar and bipolar, like we discussed before. We want to know exactly what is happening at the lead tip. So unipolar impedance matters a lot as far as the lead tip is concerned, rather than a bipolar impedance. Sensitivity, like if you are using that CSP for a shocking purpose, for a sensing the arrhythmia purpose, you have to monitor the sensitivity. And all the more important is confirmation of conduction system capture, because at least in 4 to 5% of the patient, they can have loss of conduction system capture during follow-up. Thank you.
Excellent talk, sir. I'd like to invite you to come and chair the next session. For the next session, I'd like to invite Dr. Dilip Kumar.
So in his bundle, it
Sanmuga sir, one question. In DCM with LBBB, we are doing CSP with left bundle pacing. Suppose a patient with complete RBBB, could he get benefit from right bundle pacing?
Right bundle pacing is not at targeted for doing for patients with an underlying RBB. Probably you can try it, but so far it is not tried. But DCM with RBBB, we have a series of almost 120 patients, which was published in Heart Rhythm O2, and still left bundle pacing works beautifully well in this patient. The QRS reduction was minimal, but the EF improvement was good, and NYHA functional class improvement was good. So even in patients with an underlying right bundle branch pathology, especially if you have an abnormal axis, left axis, masquerading left bundle branch block, prolonged HV, left bundle pacing still works.
Yeah, thank you. And I kept. Yes, sir.
There are a few things here. The one thing that if you are really doing a conduction system pacing, I would seriously think that don't depend on the industry, company, people to program your patients.
Right.
They don't understand. Let me tell you, not at all. You know, you have to do it yourself. You understand that conduction system pacing has to be confirmed on each and every visit. Otherwise, you're doing disservice to the patient. Most of the times, many times we don't keep this auto things on. We put it off. They may create, issues in some of these patients. Basically, I think you have to have a proper pacemaker monitored by either you or your colleague who understand this.
Exactly, sir.
And there's another thing is somebody asked for the right bundle block. If your patient has a right bundle block and he needs a CRT, there's no trial to show that conventional CRT helps these patients. There's only one trial and some data from Shanmuga that if you do conduction system pacing, there was 11% increase in ejection fraction in these patients, and they could recruit the left bundle in 77.
Right.
No, you
So
can
thank you,
selective, like in right bundle branch block patient with dilated cardiomyopathy, because left bundle has intrinsic conduction, you can selectively pace, but you don't know where is the block in the right bundle. You selectively pace the right bundle and you can get it narrow.
We don't know, sir. Many times they will have an associated left bundle disease also. If you look into the ECG,
Yeah, if you
they'll
have
I think optimized CRT is a better way.
Yeah, exactly. Large CRT.
No, but
Of
there
course, you
was
have to start with the his bundle pacing in these cases.
Ultimately, what the conduction system pacing in CRT is, you want to narrow the QRS complex. And in this trial, with right bundle branch patients, they could narrow the QRS complex in around 78% of the patients.
Because of transeptal conduction.
Exactly.
By the left bundle.
And anodal capture.
Or anodal capture.
Right. So I purposefully kept so many talks on ECG interpretation, programming, so that everyone would be aware, at least at the end of the CME and this entire program, there will be takeaway which will be hammered many times. What is V1, V6 difference, R-wave peak time or LVAT is same, and non-selective, selective pacing. So I will be rushing through evidence. We have, I think we are a little late, so I will be covering up some time, making up some time, and I will not go in detail. So whether we go for a stylus driven or a 3830 lead CSP, we get ECGs of this kind. So these are really, really narrow, and the kind of ECG we see, we have discussed so far many times. Dr. Clare, Dr. Shanmuga, Dr. Yadav has shown. It depends where you are pacing, at what voltage you are pacing, and how the ECG is coming. For those who have not seen left bundle potential, this is classical left bundle potential, which is seen as 25 to 30 milliseconds before the QRS. And this is already shown whether you recreate where you pace the left bundle trunk or fascicle, this is not going to change the outcome. So let's now look at the evidence and where we are standing today at this day, So this is the electrical synchrony with CSP versus BIV. This was the initial randomized control trial, HIS-SYNC trial, very, very less number of patients, but it gave us a hint that CSP can surpass CRT, and this showed benefit in ejection fraction improvement as well as QRS narrowing. Another randomized control trial, HIS pacing versus BIV pacing, again very less number of patients, 50 patients, and it again showed, it reproduced results of HIS-SYNC showing QRS narrowing and the ejection fraction improving. And look at this is, the forest chart. The amount of QRS narrowing is maximum when we go for a kind of HIS pacing as compared to BIV or left bundle pacing. So HIS pacing has its own problem, so we are now moving to left bundle branch pacing. So we need to have evidence for that. So these are the evidences which I am putting forth in front of you. This is Dr. Huang's article showing observational trial. This is all observational trial, which showed that if you go for a left bundle pacing, you get a QRS narrowing from mean of 164 to 104 millisecond, and which reflects into increase in ejection fraction response and reduction in LV and systolic volume parameters. This is a left bundle branch area pacing for cardiac resynchronization therapy. These are international LBB area pacing collaborative study group where Dr. Shanmuga's contribution was also there. And again, it was just evidence that observational trial that once you go for a CSP in lieu of CRT, you get benefit. Okay, and this is something like the success rate is around 85-90%, and there is an increase in ejection fraction and narrowing the QRS. Again, this was a CRT versus BIV. Now there is a comparison. All the evidences which I showed till now was a CSP 500 patients, CSP 400 patients, and what was the results? It showed reduction in QRS and enhancing the ejection fraction, but this was a comparison. So you see Dr. Shin article, observational, still it was a kind of they did a trial, observational trial. It's not randomized control trial, but it was a 1-to-1 BIV versus LBB area pacing, and they showed that yes, LBB area pacing, in fact, indeed is better than conventional BIV. And in heart rhythm, this time 2022, there were a lot of publications, lot of articles were there, and one was from Dr. Vijay Raman of something around 500 patients, again showed a similar kind of result. And this is very important, this piece of evidence I wanted to show. This is a 14 centers in Europe where the operators had more than 200 cases experience. So not like someone like us who had done 150, 140 cases entitled to do a kind of a study and showing it to world. All these operators were having more than 200 cases already done, and then they recruited patients in a kind of a systematic manner, and this was the basically the inclusion criteria, and they finally said that yes, we can recruit these patients as this patient had a LBB pacing, which was documented by either diagnostic QRS morphology transition, diagnostic QRS morphology transition during programmed stimulation, RVAC peak time less than 80, or intraventricular conduction defect if it is there then less than 90, LVV potential was shown, and V6, V1 was more than 40. So all these patients had these strict criteria, good operators, and then they gave us results, and this was really, really remarkable. So they reflected, and they said, they showed the same finding which was shown in earlier trials, but you can appreciate here the good contribution of stylus-driven lead also. So 16% of the patients were stylus-driven lead, CSP, and 83.8% of the patients were 3830 lead. And these were the complications. So you see intraprocedural perforation 3.7%, chest pain 0.98%, so 8.25% was the problem, but none of them were life-threatening. And this is, it is us to, accept how much we are accepting. And again, finally, with this piece of evidence, there is a RCT also with LBB versus CRT. First piece of RCT coming from China showing better response with CSP. So I will show you one or two cases. This was the AF with LBB. We did the AV junction ablation, and the CRT, we got the CCG, patient improved. So these kind of patients where this is again where there is a AF and we are going for ablation, they respond much better with conduction system pacing than CRT. So this is an important area where CSP really holds ground better. And finally, LOT CRT. If someone has a very wide QRS, if someone has a RBB with LAHB, what happens to these patients? So these patients have a QRS of 182 millisecond, did a LOT CRT, and you see the ECG, if I don't say that this is paced, you will pass it as a normal. So this kind of ECG narrowing you can get with optimized CRT. This is again a case where RBB and LHB was there, and then we optimized it with this kind of ECG, and patient is still doing well. And Dr. Claire was right, spot on. When the patient went home, next time the patient we were interrogating, the company person has kept programming parameters like, first there was a CS, the left bundle, CS lead was spacing, and then left bundle was spacing. So we really had a bad time. We thought this is just optimized by initially by the left bundle, and then you have to optimize by 30 milliseconds through CS lead, or like that. So it's very right, we have to optimize ourselves. So these hot or LOT CRT gives you the best synchrony. So this is the future, and sometimes when you have to rescue, you don't have any target vein, there's an infection, then and then this is a study from rescue patients where 212 patients where CRT was not able to be done, and this is Dr. Vijay Raman. 2 out of 212 patients, 200 patients, they could do CSP, and they got reasonably good results. So finally, we have some evidence, and we have FDA approval. So FDA just cleared 1 month back CSP as a valuable tool, and it can be done, although still awaited in guidelines, 2021 ESC pacing guideline, where they had the evidence till 2019, they showed it, they kept it in 2B indication, and maybe near future, with more and more RCTs gaining up, we will get it right there in the guidelines too. Thank you so much for the patient hearing.
Thank you. I think.
Yes, sir. I think FDA has cleared.
I think we have come to the end of our first session and running behind the time. We have a last comment from Dr. Claire and from the audience.
See, I think I have a feeling that conduction system pacing will become the standard of care of pacing and CRT both in future. You know, the AHA, ACC criteria come after a lot of trials and lot of, they are still collecting data, they will come ultimately. And I think, in my opinion, the Micra technology will have a very small niche. It came as a big thing. It is a great innovation, but Micra doesn't give you physiological pacing. So I think it will have a very small niche in the future of pacing. The main thing will be conduction system. That's my estimate.
Right. Sunip?
Yeah. One thing is that if you have a thrombosed left subclavian vein and it's a de novo case, is worth to try this conduction system pacing from the right subclavian? Is any idea?
Yes,
or
we
any
can do it from the right.
You have to make an extra bend.
Not a problem.
I thought you'd be asking you, the both subclavian are occluded, whether you can do subclavian.
That's what I was.
I was scared of that.
I thought he's going to ask that question. In fact, we have a patient right now, you know, who has this problem, and I'm thinking.
So thank you so much,
Thank you.
chairpersons, and it was a wonderful second session, and we move on to the third session. And now may I request our chairpersons of the session, Dr. Mantosh Panja sir, Dr. Soumya Kanti Datto, Dr. Ashish Haldar, Dr. Umesh Kohli, and Dr. Sudev to come on the dais. Can you have an extra chair on the dais?
Can I call Dr. Anil Mishra not there, so please come, welcome. And Somo, other people come, very interesting session. So here we are going to talk that is effectiveness of new generation remote monitoring, very important talk.
So, yeah, Dr. Ullas, he will,
Ullas is talking
he has
on
sent the
this
presentation.
line,
Sunil, can you upload the presentation? Start. So we can reverse the sequence. I think it's ready, huh? Okay. Dr. Ullas couldn't come, so he has sent his presentation.
Hello everyone. Let's now discuss a few issues about the next generation remote monitoring, also called Bluetooth technology based remote monitoring. Remote monitoring of the implantable devices has been strongly recommended by all the cardiological and arrhythmia societies as strong as class 1 indication. They recommend that all patients with implantable devices should be offered remote monitoring as a part of the standard follow-up management strategy. However, very few centers in India have embraced the remote monitoring technology. I think it is because of the several challenges which are often true and often not true. Major challenges from the physician community itself. Physicians believe that there's an added responsibility and they imagine certain legal issues which are not based on any true facts. Apart from the physician perspective of the challenges, there are certain real issues when it comes to the participation of the patient. Patient has to be, especially with the older devices, need to be more actively involved for his or her device to be monitored. There has to be a proactive participation, education is required. The remote monitoring tools with the older generation tools, they are very large. Of course, they come with an additional cost. The data that is gathered and transmitted could sometimes appear to be enormous. And sometimes, what we should be doing with that data and how to pick the data for a proactive intervention by the physician becomes difficult. However, with the next generation remote monitoring, that is the Bluetooth technology based, there has to be almost nil participation of the patient. It's because the compatible mobile phone becomes a transmitter to the physician, and that mobile phone is always connected to the Bluetooth technology with the device all the time. No participation, and that is absolutely a great comfort to the patient. Because there are no larger size tools, and the way the data is transmitted, the cost to an extent is reduced as compared to the older technology. What appeared to be the data aggregation and the proactive interventions, what is considered to be difficult with the older generation, with this technology, it is pretty much systematic and simplified. The older tools are still existing because not all the devices are Bluetooth technology based remote monitoring. If you compare the older generation tools which are still existing, they are pretty large, and the patient has to be meticulously following a device for the scheduled transmission. And to pick up a red alert, the patient has to be once in a while per day has to be in and around that large tool which is placed at his bedside or one of his halls. The newer generation remote monitoring tools which are Bluetooth enabled or Bluetooth technology based, few of the models from the Medtronic and Abbott we can monitor now with the patient's mobile phones. Not all of the devices are Bluetooth enabled. When it comes to Medtronic, the Azure model of the pacemaker and the CRT only pacing, the Serena series, you can monitor them remotely. Both of them are advanced devices. They also have, their cost is also more as compared to the lower versions. So that is indeed a concern when it comes to the Medtronic Bluetooth technology based remote monitoring. However, Abbott, the cost wise, I think as long as the physician himself is involved in the remote care, the cost doesn't seem to be a factor as long as the patient has the compatible mobile phone. Like Medtronic, Abbott also has brought in, not for all their devices, only for the high-volt devices, which are CRT-D and then the ICDs, both single and dual chamber, Gallant series. They also have the Bluetooth enabled implantable loop record of the Conform RX series. So not all devices now are going to be monitored with the Bluetooth devices. We have been adopting this Bluetooth technology as vigorously as we had done with the older generation. At MMM, we believe we were the early adopters or embracer of this technology way back in 2013 when there were only older generation. There were some apprehensions, how do we handle? It really required in the beginning, for example, in 2016, really a big infrastructure. There's a dedicated office, a computer, 2 dedicated allied health professionals, 24/7. It really looked like an exercise, but we pursued on that, and that's the reason why I think MMM is now famous, because patients think that getting implanted at MMM, they will have this remote monitoring facility. That fear has come among the patients. Since 2019, we started using these Bluetooth-enabled devices. Now, when it comes to the Bluetooth-enabled devices, we have the Abbott and the Medtronic series, about 100 each, I think. So far, these are the older generation tools. More than 1,000 patients are recruited with the older generation remote monitoring. At MMM, the remote monitoring is done this way, and that is, there is a dedicated mobile phone for remote monitoring. And that dedicated mobile phone has registered with the websites of all the three manufacturers. And that dedicated mobile phone stays with an allied health professional 24/7 on a rotational basis. That mobile phone has the complete data of the patients. There is nothing more in that mobile phone. It has the details of the patients in the form of the diagnosis, detailed diagnosis, how many follow-ups in the past, each follow-up outpatient record, each interrogation report in person when the patient had come, the complete data about whether the scheduled transmission had arrived, missed, and if there were alerts, what action were taken. So every time there is any message that could be in the mobile phone, not at the office, could be analyzed. Scheduled transmissions are discussed with the consultant. The three of us are into the pacing practice in our hospital. We rotate with respect to the responsibilities, if you wish. Scheduled transmissions are discussed with the consultant if necessary, and of course, the red alerts are conveyed to any one of the three consultants immediately for an appropriate action. I think it's a very oiled system. We really do not feel any challenges in monitoring our patients remotely. So this is an example. This is a mobile phone, that actual mobile phone, and you have all the details. For example, the age, the CC number, the hospital number, the diagnosis in detail. And down you see for example, this is the Biotronic, one of the alerts, and everything is there. This is some examples how the mobile phone could be used by our allied health professional. There are scheduled transmission against each patient's name, whether the scheduled transmission has arrived or no, and what was that transmission, is it really requiring any actions or no, and then if there is an action that could be taken, a red alert of course are looked at immediately, and action is taken. And this is the picture taken from the mobile phone. The traces are very neat, as crisp as what you see in your pacemaker clinic. Any alert could be analyzed whether that alert was worthy of taking action immediately, or for example, in this case, you have set the remote unit for monitoring some ET episodes, and then you know that this patient is having some slow ET around 150 or so, and it has not been considered for therapy. But if there are more of such events, well, you can take a proactive intervention. Patient may not be having any symptoms here, but remotely you monitor the load of the arrhythmia, and you can guide the patient regarding the therapy, so that before you develop symptoms, the action is taken. Remote monitoring helps us to treat our patients before they become symptomatic, because it is seen that proactively intervening actually increases the quality of life, and especially with the devices, the CRT and the ICDs, there is enough data that these kind of a proactive interventions before the patient becomes symptomatic actually has increased the survival among those patients who are monitored this way. This is a red alert. Again, you could look at whether it says that there's a VT which was treated, and whether it's an appropriate or no, it could be looked at it. And before the patient gets panicky about the shock, your team could inform the patient that, well, we know that he got a shock, and that's the good thing that has happened to him. It saved his life. This kind of an immediate call to the patient or to the relative brings in a lot of assurance to the patient, and the so-called the fear out of the shocks is allayed very much. When we're talking about this Bluetooth-based technology, Bluetooth technology-based remote monitoring, we should not forget the age-old Biotronic remote monitoring systems. They have stood the test of the time. They have not made me feel any inferior to this Bluetooth technology-based remote monitoring that is using the mobile phone. The only difference between the Biotronic tools and the so-called newer generation mobile phone-based tools is that Biotronic has a dedicated transmitter. It is not a mobile phone. However, this is simple. The patient may actually carry this with the mobile phone, and the technology is here is radio frequency based. So I still would consider the Biotronic is as good as any one of the Bluetooth technology based remote monitoring. It is just not to forget Biotronic technology, and 3/4 of our remote monitor patients are having the Biotronic technology. Recently, this is one of our publications in Heart Rhythm. We looked at why the adopting the remote monitoring in Asian countries is low. What are the issues? And as usual, the statement was we need to be making our physicians and the patients to be aware of this, and the so-called the fear of extra work or legal issues are not based on any true facts. To conclude, remote monitoring I consider strongly is a very good way of following our implantable device patients. We need to embrace the technology very generously, and most important, we need to be prepared soon to adopt this technology because very soon patients will demand. Thank you.
Okay. Thank you for the excellent presentation. Thank you. Actually, during our time, now 15 years before, we used to do the pacemaker clinic to follow up all this.
Hello everyone.
So, patient used to come regularly and wasting of one day, and also the cost of money. You have to come to the clinics of the consultant. And thanks to all the particular devices, those are new generation, particularly Azura from Medtronic and HB device for Abbott, and recently also Biotronic, also equivalent, very useful for assessment of follow-up program. So any comment or question from my others?
Any regulatory and legal aspects associated with this newer?
It was a recorded presentation. He is not online, so we can move on with the next presentation. Thank you.
He is online, that is because he is not possible to come.
Yes, sir.
Once again, okay. Thank you, Ullas, for excellent presentation, brilliant exposition and your experience also. Now, next speaker, Dr. Prakash Hajra, the head of the department of MRI Dhakur Hospital. He is the largest experience of the leadless pacemaker. You know, will present how to implant, how to do the program and new current generation. Dr. Hajra, please.
Thank you, sir. Thank you, Dilip. Can I have more? Yes. Okay, so he is the first man to have Micra, and since then we had many people who are living with Micra in India and abroad. So this short video tells us that Micra is the only device which can work in the space station. Micra is the only device which can be switched off. Micra can withstand the gravity, the fall of gravity with supersonic speed of your the missiles or the satellite you throw into the orbit. And in this experiment, when the Micra was छोटा second. Anyway, tiny shot. So when this micro was packed inside the satellite and reached the orbit, and they were retrieved in a capsule, a shock absorber. This is the shock absorber. When it was opened, the micro was intact. And during the acceleration from the Earth to the orbit, a micro senses the acceleration. The single chamber pacemaker VVI did sense the change of gravity and the change of speed, and it could switch on its own from VVI to VVIR. And we know that double chamber micro is going to be available very soon. For the time being, this is first in man, but commercially not available. So Abbott is coming the shorter version, a larger battery capacity, and the fixation mechanism is different. It is much more easy to retrieve if you have endocarditis on the micra. And this chronic retrieval mechanism is unique only to the Abbott, and it has got a different footprint, and the longevity is definitely a little higher than the micro pacemaker from Abbott. And it has got a special material cover which can prevent this micro getting infected. You know, most of the device, whether it is a valve or conventional pacemaker, the chance of infection is very high because you touch, it comes in touch with the skin, and most of the time we do not get the bugs detected by culture. And you can conclude there may be slow growing virus, slow growing bacteria, or some kind of bugs which are not detected by routine culture, may be responsible for pacemaker pocket infections. Some of them are culture negative endocarditis in device. But since we do not touch the micra from the very beginning and ultimately falls into very turbulent zone of right ventricle, the chance of bacteria getting settled and growing on the device is very less because of less surface area, no connections with the lead, and the constant jerking motions of the micro device or any other wireless pacemaker. So micro implant, you know, there are many components. I'm not going to the details. Smallest one, and always tell you that the micro device is a fall from above rather than push from below. Sunip was asking either both the subclavian is occluded. These are the usual patient. It can grow from the groin, and it falls from above. Like you go up, release the micro automatically comes down. It knows where to go. And in programming, you know, once you put this AB micra, and most of the time it is done by the programmer itself. But out here, you know, this A4 segment is very important. After the atrial contractions, there is 20 millisecond delay of your micro sensing. So effectively, if you have P wave which is around 100 millisecond, then 20 millisecond of delay, that means your PR interval will be 120 millisecond, that is physiological. So you have 20 millisecond to play after the P wave. If you see good P wave followed by a good QRS, this micro is instantly sensing the A4, which is a mechanical sensing. It is not electrical sensing like conventional pacemaker. Conventional pacemaker knows the voltage, but the micro pacemaker knows the mechanical contractions of the atria, and it is AM. And once you have those kind of informations on the table, you are happy. But if you do not have, it takes almost 4 hours for the algos to come to a definitive pattern, whether it's a vector, whether it is your A4, A3 threshold. But you have to wait for 4 hours. Once you have 4-hour waiting, then you can program this pacemaker, micro pacemaker according to your suitability. If you have complete heart block, you can have almost 90% AV conductions, VDD. If you have a six-sinus syndrome, no P wave, there is no point putting the dual chamber or a VDDR. It is better to have a single chamber micro. Some people, when we started doing RV angiogram. We have moved from RV angiogram to direct temporary pacing, lighthousing, piggybacking the temporary pacemaker. Pacemaker, temporary pacemaker, if you go to RAO, you know where the apex lies. So you go little above on the top of the temporary pacemaker, do not go below the temporary pacemaker silhouette, because pacemaker silhouette tells you the inferior surface, the apex. You try to stay above the temporary pacemaker tip, which is around from 1 o'clock to your 5 o'clock. If you think that the temporary pacemaker looking at 5 o'clock, so 4 to 1 o'clock is the best that is seen in LA on RA view. And as I said, in conduction system pacing, if you start doing conventional way, now move from conventional way to angiography, you can finish conduction system pacing in 10 minutes, 20 minutes. But if you have this kind of informations in micro implant, doesn't help much. It is all your understanding of the location, mental locations of the apex and the lower part of the septum. This is the first pacemaker who had upgraded because he developed LV dysfunction after myocardial infarction, suffering from suffering from AV block, and he opted for a single chamber pacemaker. That time elderly man, but later on he developed heart failure because of lack of AV synchrony, and he's the first one to have this upgradation from single to a double chamber VDD micra. And it looks, and up to 3 micra can be implanted, but if you have Abbott, you can retrieve, you can keep it. Since micra is there for just for few years, you cannot have any human being who is living with 3 micras or 2 micras because the longevity of this pacemaker is almost 12 years. He is the first man in India to have a BDD, and he is immediately walking after extractions of the lead. Now some people, they extract the lead, put it by micra once the blood culture is negative. Some people do the temporary pacing, then after 2-3 days do the micra. But there are different variations of practice. If somebody is not having fever, remove the lead by laser or even simple pull, open the pocket and put the micra. And once you have pre-existing atrial lead, the atrial whip can produce a mechanical sound, so it's better to remove the atrial lead at least. And again, just like Dilip has done many cases so far, and he knows Dr. Bera has done here. So this is the large dilator, goes there. I have only one patient in a female, 9 years, who had micra pacemaker from the groin after opening the iliacs because she had developed infections 6 times and all the veins and subclavians were occluded. It is not indicated in less than 35 kg and is not indicated in 120 kg above because the wand cannot interact with the micra. So you go there, never try to push hard, and micra, there's a lot of energy, static energy generated when you deploy this. So just relax and just take off your hands from the hands of the micra device, and that takes the form of the right ventricle, then little swan necking. This is swan necking. With little swan necking, then you know how to release 3 points. Now, if you really want to retrieve micra, go to a different place because of lack of threshold. Now, Abbott has a different mechanism. Even if you do not release the wireless device, you just go to the apex and you can sense, you can program, you can have all the parameters like ROA, threshold, etc. because that's a different mechanism, screwing mechanism. So out here you have to release. So most of the time, the Abbott wireless pacemaker is possible to implant in 1 chance. Whereas micra pacemaker, you can retrieve 3 to 4 times, nothing happens until unless you damage the cup. And if you are happy, that means your threshold should be at least less than 1. But most of the time, the 60% is less than 0.3, which is better than the conventional pacemaker. And this tether out, and it stays there. This is your lead extraction, and this is the wireless pacemaker from Biotronic, and ICD without atrial leads. This is all kind of atrial leadless pacemaker. It's a new variety. Now coming back to the programming, as I said, this A4 is very important. And if you do not have A at all, that means A is not there, 6 sinus syndrome. But if you have A, but it's not sensing, there are a lot of things you still can do. Either it is sensing something that is mean A3, A1, A2, which is much before than A4. So these kind of permutation and combination will be there. If somebody is sensing A4, over-sensing, then you increase in the number of like a conventional pacemaker. If something is, normally the A3 segment we don't want to sense, A1, A2, A3 don't want to sense. So keep the number from, example, from 2 to 10, all the time it is 10. So it does not sense the A3, but has to sense the A4. So A4 number is small, A3 numbers are high. If it is doing something, over-sensing and under-sensing, those things can happen in real life, then you change the number of sensing number of A3 to A4. A4 can go up, A4 can go down. The A3 segment sensitivity number, like conventional, can go up and can go down. But most of the target is your A4, and this is the algorithm. Like if you have over-sensing and AM coming after BE, then increase the A4 threshold or A3 window. So window is also a time window. Up to that, you can stretch on the left side, you can stretch the A3 window on the right side. So those kind of very complicated to understand, but this can be done most of the time. Thank you.
Thank you very much. But the shortcoming of the micras is important, that is the cost. Second is the particularly dual chamber facility not there. But what is the current situation of the dual chamber micra at present?
Dual chamber Abbott will be available next year. First in man has been launched in US, but only during a conference. Single chamber micra was there for 600 syndrome in elderly people, where you can think that he can live with single chamber pacemaker. You can put a single chamber micra, and the price has come down after the introductions of VDD micra. VDD micra is definitely indicated in high grade AV blocks. And if you do not have any POA, there's no point thinking of dual chamber VDD. Just like a VDD, you can think it is VDD versus VVI.
Can I make a point? Yeah, thank you. Wonderful presentation, sir.
Just one question. Somebody is asking.
Sir, may I complete? So, what has been seen is with micra, the chances of perforation is higher when the TPI is there. So we shouldn't be keeping a TPI just for kind of marking where we should go. Rather, we should avoid even in CHB with normal heart rate, something like 50-60 or 2:1 A block, where we can avoid TPI, should be avoided, because they both get entangled and push and pull happens, and perforation happens. So this is a
You're right. So if you have a temporary pacemaker placed already, while you're pushing the sheath, if you have not tied the temporary pacemaker nicely, it can dive in. But in spite of having good tie, sometimes it dives in because of the change of the curvature. So you have to be very careful. So what do? You just lift up your hand from the handle. So automatically the micra knows that it is facing resistance, and it will conform to your shape. Then what you do is just pull the temporary pacemaker a little bit, somebody pull the temporary pacemaker, then you go again. Yes.
Are you talking about perforation by the temporary wire, or you are talking the
temporary wire, sir?
Yeah.
Right. Go for a balloon tip. Go for a balloon tip.
No, that's exactly right. Whenever it's possible to avoid, you should avoid. But temporary pacemaker, you should always tell your fellows to do septal, mid-septum. So we have stopped going to the apex now. Even temporary, just do the mid-septal. No, just I wanted to ask you one thing, that what is the reliability of AV micra of sensing the atrium and working as a dual chamber pacemaker in the patients who don't have sick sinus syndrome? Like we have AV micra now.
Yeah.
How much is the reliability of the atrial sensing in that?
So A4, if you can, first target should be to reach the right ventricle. Second target should be, if you reach the right ventricle, try to finish the micra in one chance. And third target, have a good threshold. So if you meet three criteria, and anchorage is almost 100% good. The secondary target will be the A4 segment, whether the A4 segment is sensing properly or not. Now, should we aim for better A4 or better threshold? So you say fight between better A4 and better threshold. But winner would be if you can get a good threshold of 0.3, 0.4 in first chance without producing any complication. Now, A4 segment, like this is AM, there's 20 millisecond, as I said, 100 POA plus 20 millisecond given in the micra pacemaker. So 120 millisecond, the micra senses 120 millisecond of the mechanical contraction of the ventricle. Now, if you are sensing something, like if you are sensing A3, then obviously it will not be followed by a QRS or AV synchrony. Then you have to reduce the oversensing, you have to make that A3 segment less sensitive, or you increase or the zone, the sensitivity zone of A1, A2, A3 together, you have to cut short. So it does not sense the A3 segment and A3 heights or A3 mechanical, some flow like diastolic flow of the ventricle also sensed in the A3 segment. So those kind of combination permutation can be achieved later on after 4 hours of waiting. If you do not achieve, then your basic purpose of having AV micra is gone, and that is almost to the tune of 10 to 15%.
So anatomically,
last question.
The atrial capsule is exactly same or it's a smaller atrial capsule in the dual chamber micra, which is hopefully coming. So the atrial capsule is same size. Is
So far it is of same size, the same same atrial about AVIA, but I have not seen it physically. They are claiming that the same thing with a different mechanism of placing, the sheath placement will be different.
Right.
So you go to the RA and RA appendage angiogram, then you put the into the.
Okay, thank you, Dr. Hajira, for excellent, brilliant presentation. But last question, okay.
Does AV micra, which is available about sensing the accelerometer of the atria, can cause oversensing of the ventricle, failure of the ventricular pacing because of oversensing?
Yes, it is. Yes, if you stretch too much, like AM segment instead of 20, it can be stretched up to 250. So if you stretch too much, then what will happen? The escape ventricular rhythm will come like just a regular pacemaker. If you stretch the PR interval too much, then original ventricular ectopy will come, and it will not be followed by AV synchrony. Patient own ventricular rhythm makeup. Appendage angiogram. Then you put the.
It will not do anything. It will not do oversensing. It does do oversensing. It can do undersensing only of the atria. Am I right?
Yes.
How much heart rate it will have AV synchrony will project?
Less than 100, I think. If
minimum is 50.
120 to fix the optimum.
AV synchrony required particularly when the patient is walking, running.
Yes,
okay.
yes, yes.
So up to what rate? Once what they have found that if rate goes up over 120, only 50% no doesn't sense.
The satellite experiment. The satellite experiment when micro was put on the video I have shown in satellite, it went up to 120 with gravitational force. A mechanical force, day-to-day working, it still can go up to 120. So there are different accelerations, like in the satellite, there is no atrial flow, there is no atrial sensing. It is the speed, a change of gravity. But in walking, there are different movements, and the flow also changes with your movement. Atrial flow, atrial preload, afterload, walking, running, breathing. The atrial contraction, it is a mechanical contraction. So
it's just like a physiological matter, except the outcome, that is the particular 25% cardiac output cannot be managed.
Yeah,
that is shortcoming of the single chamber, same like this thing.
Yeah.
But it's just like a physiology, heart rate up to 120 can be adjusted.
Sensing. It is a mechanical volume sensing, it is a contraction sensing. There is so many things which micro senses differently from the conventional perspective.
Okay, Madam, last question to you.
Dislodgement, sir. Any dislodgement reported?
Dislodgement, never in my, I think, 150.
Reported ever,
No.
like?
Reported, no. I don't know.
Okay, thank you. But those are the early procedure, say, early little experience, the chance of embolism to pulmonary, very 1 or 2 cases reported only. Thank you very much indeed.
Thank you, chairpersons, and thanks to all the speakers. So we will, the lunch we have made a running lunch, so there will be no break for lunch. So we will continue with the next session, and may I invite the chairpersons for the next session, Dr. R.D. Yadav and Dr. Indrani Shyam to be on chair. And may I request the first presenter, Dr. Deobrato Bera. He doesn't need any introduction, and over to him.
So the topic,
boss, Dr. Yadav, I think there is a, like, people are saying we can have a 5-10 minutes quick
Yeah, 10
lunch.
quick lunch and then we'll come
you
back.
must be clear, yeah. So we are taking 5-10 minutes break. 2:30, 2:20 we'll assemble. Yeah.
Hello. Ma'am, can you hear us?
in the other city.
What we do here, so whatever the date, let's say they fix the date, let's say 10th February.
Yes, sir.
Bangla, Rhythm, Society. We call it BRS.
BHRS, sir. Bangla Heart Rhythm Society.
Bangla BHRS. That's a good idea. BRHS, BHRS on 10th. So you have one day only or 2 days?
Now this program will be one day, sir.
Bangla?
Yes, sir. A small group.
Right. So what we do is that we do case 9th Feb. And whatever is the commitment in this meeting, we will do, and we will continue to do case on 10th also. And 11th, we go back.
So, welcome back, and I request everyone to settle down.
Lead instruction. I will give the mixed cases. There is
I request Dr. Arijit and Dr. Subhasis Rai Chaudhary to join, and Dr. R.D. Yadav and Indrani will follow after the lunch. And we can start the program, the session.
So it is finalized.
Yeah, good afternoon everyone for to a post-lunch session. It usually starts off with a bit we see less crowds here, but I'm sure that as the session goes on, we'll have more people coming in after finishing their lunch, because we have 3 excellent speakers coming up. To start off with, we have Debabrata, who doesn't need an introduction. He is a very eloquent speaker. He's one of the most knowledgeable persons in electrophysiology in our state, in our city. And he's going to speak on follow-up and troubleshooting in ICDs, and I'm sure that he's going to concentrate more on the practical aspects than on the theoretical things. Dr. Debabrata, please.
Thank you so much for the kind words, respected chairperson. I must thank Dilipda for organizing this compact program, which actually invites many of the youngsters in the city and from outside the city. So my job is to discuss about post-ICD follow-up and troubleshooting. Actually, many of in the audience are not electrophysiologists, but who do ICDs, and I'm trying to do some part of the ICD troubleshooting, so mainly case-based discussion. I'm sure that I'll exceed my time. Please stop me whenever I'm there, because I try to go slow so that some of the things are at least understandable. Because many times we feel that the intracardiac electrograms are a little difficult to interpret. So on follow-up, what do we see? Whether the patient is doing well or not, how is the battery and leads, if the patient develops or gets any therapy, whether it is appropriate or inappropriate. Sometimes patient comes with an alarm, and although most of the time we do use ICD for therapy of the ventricular tachyarrhythmia, sometimes they do, they are used as pacing. So in those patients who develop over-sensing, they can have a lack of pacing. So why do I specifically mention about over-sensing? Because ICD leads or ICDs, in contrast to the usual pacemakers, are much more sensitive. They pick up even small signals because they have an auto-sensing ability. They can even pick up any electromechanical interferences and any small noise, myopotential, etc. So I'll go by case-based discussion. Before that, this is one of the basic things to be understood. Classic article by Charles Wedlow et al. In Circ EP. So what is there in the ICD? What are the components of the ICD? If the mouse is visible, so this is the pulse generator or the battery, and the lead goes in the heart. So presently we are using most of the time the single coil ICDs. The leads are single coil. There are usually 3 or 4 channels when we look at the intracardiac electrograms. One is called a leadless ECG. Second is called the far field or the shocking channel. What do you mean by this far field or shocking channel is, this electrogram is the interpretation from this PG or the pulse generator to the coil, or sometimes we call CAN to coil. This is called CAN. This gives you a bird's eye view of the whole electrical activity of the heart, and generally it appears like a ECG. If you look at the next one, it is called near field electrogram. This electrogram gives you what the lead is looking inside the heart. So this channel comes from the tip to ring. So whatever activity is happening inside the heart, it only gives you the local information. But one important thing you have to remember, they go hand in hand, because the far field, although looking at the overall cardiac activity, it picks up the QRS complex, and similarly the near field also should pick up the QRS complex. The far field sometimes also can pick up the P waves, because it is almost like a unipolar, something like a ECG. So the near field doesn't usually give rise to the P waves in the electrogram. Generally we call this electrogram as V electrogram. If you have a atrial electrogram, if it is a dual chamber ICD, we call it a electrogram. So what we find, this is called marker channel, and this marker channel is finally what your lead or the device is seeing at. So this marker channel generally interprets the finding coming from the near field. So it always do not necessarily reflect what is seen in the far field, although the device looks at the far field electrogram. The near field, that means whatever the lead is looking inside the heart, is reflected to this marker channel, and finally on basis of that the device takes action. We'll mostly speak about therapies in this presentation, and whenever a patient gets a ATP or a shock, we generally, first thing we need to know whether it is an appropriate therapy or an inappropriate therapy. The EGM, as I told, that both the far field and the near field activity should go hand in hand. Let's say if we are talking about a ventricular arrhythmia, if it is a VT or VF, always you will have both far field and near field should show much rapid QRS complexes. There are some rule of thumb for which you don't need to know EP. For a dual chamber pacemaker, if the number of V is more than A, it is always a VT or ventricular arrhythmia. If your number of A, that is P wave, is more than V, or the more number of A than QRS complex, then it is atrial arrhythmia. For single chamber, you do not have this luxury. You can have three components called morphology. That means whether the QRS morphology is similar to the sinus. That means it will suggest SVT. Or the tachycardia onset is sudden. If it is a sudden onset, it generally excludes sinus tachycardia. And third one is if it is regular or irregular. If it is regular, it will call either it is a ventricular arrhythmia. If it is irregular, generally for the device, it is atrial fibrillation or SVT. If we look at couple of case examples, let's look at this patient who recently had 3 shocks, and this is the electrogram. So there are, you can see lot of, in the initial part, there is a atrial channel, and this is the atrial channel. It is written as, it is all are bipolar electrogram. In St. Jude devices, it is called A sense and V sense. This discrimination is called, it is the far field electrogram. So what we find here, this lot of FFFF, this means the device has detected some ventricular fibrillation. If you look at the electrograms, there are a lot of something looking like a noise. Sometimes even VF can look like a noise. But if you look at the electrogram, the atrial lead also has similar noise. So there is no other thing other than electrical mechanical interferences which appear in all the channels. So EMI generally appear in all channels, atrial channel, near field, that is the ventricular channel, and also the far field channels. And these near field channels are actually reflected in the marker channel. For the device, it was very rapid firing from the ventricle, and it has delivered a shock. So this patient was actually taken into an operation theatre without turning off the therapies of the ICD, and cautery was used, and the patient developed or actually received multiple shocks. So this is one of the example of EMI. In contrast, if you look at this ECG, this is one of my senior colleague in R.N. Tagore. So this patient recently presented with a vibration from the pulse generator. No therapy, no shock, nothing, but just the pulse generator vibrated. The patient is otherwise asymptomatic. What we find here, this is a single chamber pacemaker, single chamber ICD. This V sense amplitude is the bipolar or the near field which is inside the heart, and discrimination is cant to coil. If you look at this noise which has been reflected into FFFF almost like a VF, this is only seen in the near field channel, not in the far field channel, from which you can almost with certainty exclude EMI. EMI should generally happen in both the channels and more in the far field channel, which is looking at the overall cardiac activity. It is a big antenna as shown by many of my previous presenters, because the unipolar or the far field has a larger antenna, it can pick up EMI. In this case, it was opposite. So this is most likely lead noise from anywhere in the circuit. but the most common culprit, as we know, is the lead. So this is most likely lead noise, which is actually being detected by the ICD well, and it has called it a lead noise. On basis of this, there is a discrepancy between the number of QRS complex. You see the very clean QRS complex in the far field electrogram, but in the near field there is lot of junk. So there is a discrepancy between these two. So you know that this is not definitely a ventricular arrhythmia or ventricular fibrillation. This is the same patient's front page or the summary what you see, but there everything is normal. They say there is impedance is normal, threshold is normal, impedance trend is normal, as I was discussing in the previous presentation with Sanjeev's presentation, that patients with lead noise often do not have any other clue other than the lead noise initially before the lead goes off completely. So the lead failure initially presents with lead noise. In pacemaker patients, it can be lead failure, pacing failure. In ICDs, it can be inappropriate therapy. In next 3 minutes, I will discuss more couple of cases. This is one of the patient who has ischemic cardiomyopathy with VT and AICD. Now he comes with AICD shock. So what is our interpretation? When you interrogate the device, retrospectively we see this is the sinus rhythm, this is the atrial channel A, and this is the ventricular channel V. When it develops a tachycardia, we see the rapid rates here. Your number of V is more than the number of A. That means you are actually having a true ventricular arrhythmia. For this, you don't even need to know EP. Your own ECG knowledge tells you that V more than A, this has to be genuine VT or a true VT, and he receives the therapy for that. For this, you need to give drugs, you need to consider ablation as well. Initially, if there is multiple shocks, you can consider sedation and deep sedation even. And the last option could be a bilateral sympathetic denervation. If we go to the next case, this is a 63-year-old gentleman with non-ischemic DCM with very fast documented ventricular tachycardia with ICD. Now he comes with multiple episodes of shock. From the EGM, what I am showing here, couple of important things. One is, you note the tachycardia, but there is a significant irregularity. The tachycardia cycle length is continuously varying. This itself tells you the patient is most likely having atrial fibrillation. More so, if you look at the morphology match, this is the morphology match. What does it mean? It means, let's say this beat has a 90% resemblance with his own sinus rhythm. The template which has been taken in sinus rhythm is very well matching, more than 80% matching with sinus rhythm. So this tells the patient is having a atrial fibrillation. And I'm not going into the details why he developed shock for this. Initially the device detected it is SVT. Later on the morphology match worsened a little, maybe because of rate-related aberrancy, and he received a shock. So we need to reduce the template percentage score, or you can make it a more robust. Only if you have a 3 morphology, onset and stability, all 3 fulfills the criteria, then only you give therapy. That way you can troubleshoot the patient. So this is one of a patient of hypertrophic cardiomyopathy with very fast AF. Initially you can see, I put up this slide because you see the atrial channel. In fact, you can see the atrial fibrillation. In the ventricular channel, you can see the irregularity. And later on, he actually develops almost like a BF. And this patient finally had to undergo a AV node ablation. Coming to my next patient, this patient, I don't know whether you are hearing the audible thing. So there is a noise almost like an ambulance. So this patient can come with a recurrent ICD shock, and there was something like a siren. So what we find here in the device log, so this is the shock which she received, one of the shocks which she received. If you look at the electrogram, you can see discrete QRS complex at regular intervals. But if you look at the marker channel, the number of ventricular marking are much more. It is because it has been reflected from the near field. This is called the near field, which is inside the heart. There is lot of junk here. So again, discrepancy between the near field and far field. That tells you this patient. I'll stop in another 30 seconds with this case, if with your permission. Yeah. So there is a discrepancy between the near field and the far field. The far field shows almost a regular slow rate, whereas the near field shows lot of junk, and those has been reflected. So there must be something abnormal. When you looked at the device, the impedance trend was normal. This was the impedance trend in the RV, whereas the threshold has gone almost immediately 2-3 days after the implant, the threshold has gone up. So this patient, when you took an X-ray, the lead was almost outside the heart. and it was picking up the diaphragmatic myopotential. So she required a lead revision. So I'll directly go to the concluding statements. So discrimination between the artifact, lead noise, EMI versus arrhythmia is very, very crucial. Impedance may not change in the early part of the lead failure. Differentiate between VT versus SVT. If it is atrial fibrillation, drugs is cornerstone of the therapy. If it fails, you can consider RF ablation or the pulmonary vein isolation. For VT, you need to treat with drug, ablation or sympatherectomy. For VF, occasionally you can have trigger of PVC which triggers the ventricular fibrillation. As such, you cannot ablate ventricular fibrillation, but you can actually ablate the triggering PVC. And sometimes you encounter SVTs which degenerate into ventricular fibrillation. So this is more commonly seen in hypertrophic cardiomyopathy subset. You can actually ablate the SVT and you can take care of the ICD shocks. Thank you so much.
So, Arijit, we will continue with Dr. Brijit in between because he is online. Please join on the chair. And so we welcome Dr. Brijit Oswald, and he will be talking on lead extraction. And it's our privilege and pleasure to have him online, and we can have his presentation. Sir, over to you.
Okay, do you hear me?
We can see you, we can hear you well, sir.
Okay, that's great. Thank you very much being able to join your really very interesting session. I've seen most of the topics so far. So today I'm talking about lead extraction, and I did have the opportunity to visit India in November. It was really impressive, and I'm really very happy about having, I think, many of you already in the audience as well. So lead extraction means always expect the unexpected, and this is really important because it's either indication as diagnostic, but also some intraoperative findings which will be a bit different to what you expected beforehand, and even about the techniques you sometimes don't know when you start where you will end up with. And so you will have also some intraoperative hazards you have to think about beforehand. So if we are talking about indications, most of these are still infections, and they are sometimes very obvious, as you see here in the upper left. You see the aggregate coming outside of the pocket, or if you have some dehiscence or some pus coming out of the skin, it's really obvious, or if you have large vegetations, which is really something which may also occur with micros or some further intracardial devices. This may happen, and then you have to extract directly. Sometimes it's less obvious, and you see down there, this was a patient with an allergic reaction. It turned out when I got this third patient in a row from the same hospital, everything appeared the same, and with the second and third, we left it inside. The first I really replaced because I was really worrying about having some infection, but nothing was there, and it disappeared after more than 6 weeks. So sometimes you also have to wait, but don't wait too long, because if there is any infection, it is really dangerous for the patient, and we know that any delay is causing a lot of mortality. You sometimes even don't know from the echocardiographic view whether this may be a vegetation or whether this may be some fibrosis. So it's sometimes not really easy to decide. It's sometimes easier if you have some dysfunction, and you see here very clear forward findings where you sometimes have also to do some magnitude to see it easily what happens down there. You may have some subclavian crash, which is sometimes really easy to see, sometimes even not. And you may have also some really weird findings like that. But you may also expect to have some dysfunction if you have a young patient with a long-term implanted device where time by time the lead is coming about outside. But about this case here, I didn't know what happened, and when I opened up, there was just a remnant in there. I don't know why. So if we are talking about dysfunction, it may be also something which you do not like to see sometimes. We have here 3 cases. The first is a stylet which has been remained within the left ventricular lead lumen, and the stylet was just cut down at the lead connector, and it was connected to the aggregate, and by time the left ventricular, stylet pushed outside of the insulation, and the left ventricular lead dysfunction occurred after about 3 months. Another finding which is uncommon but may occur and which you don't see easily sometimes is if a patient has an SVC occlusion and the stent has been implanted, perhaps also over some DDD system. In this case, it also caused some dysfunction, so this may also occur. Another very crucial thing is the externalization of some leads. So this is known for the Reata lead from St. Jude, but this is also known for the Sprint Fidelis from Medtronic, which may occur. It's sometimes not easy to see, but if you remove the lead, it's easy to see all the conductors which are coming outside. For diagnostics, I always request to have a chest X-ray, and sometimes even the PA view is just a little bit impressive. As you see at the left side, you may know if you have to extract everything, you may need a lot of time. But there may be also some weird things going on which are not to be seen easily if you just go for the patient without a chest X-ray. In this case, you see that the ventricular lead has been placed through the arterial system, which is fortunately uncommon, but it may occur. If you imagine going there with any sheath, you may have a lot of problem causing from thromboembolism through perforation. It's really weird. So we have to know where we go through. And I always recommend to have also the lateral view, because sometimes the PA view is just looking fine. You see it here. There seems to be the ventricular lead in the right position, but if you go to the lateral view, it's easy to see this is within the great coronary venous system. And if you imagine going there with a sheath as well, this is paper thin, and it may create a lot of perforation. It may be even worse if you go there. It looks quite nice on the left side from the PA view. In the lateral view, you see that the lead has been placed in the left ventricle through a persistent prorama ovale, which may occur sometimes. I see it sometimes, so it's not really rare. Furthermore, it's very important to know what has been placed, because even beside misplacement, you may have lead remnants which are not documented sometimes. You may have some previous attempt for lead extraction, which is important to know if you start with a procedure. You may also have some anomalies like a persistent left upper venous system or something like that, where you may have to go with another approach. I know that some people are relying on CT scan preoperatively, but to be honest, in some patients I also prefer to have it, but in most I just go with a chest X-ray, because this is an example of a non-perforated VVI system. 7 years after implantation, the patient was completely fine, but she was sent because of this image with a helicopter to our institution for lead extraction, because it seemed to be a perforation, which was not, and it seemed to be, two leads inserted, which also haven't been. So this was by calculation of a CT scan, just a perforation and a second lead which inside, which is absolutely not the truth. But sometimes it may also help if you have here on a young patient which was implanted long time ago, you may see the extravasation of the leads very easily. So especially in young patients, I also recommend to have those imaging. Sometimes you may also have some intraoperative findings indicating that you may have some problems if you go with a transvenous lead extraction. If you have a calcified, massive calcified pocket of the CID, you may also expect to have a similar finding within the venous system. So in those cases, I do not take the laser, because the laser is not really good in calcified lesions, but I go for a mechanical rotational tool if necessary. You may also have some cutting already, either from a suture which was placed through the sleeve, or some cutting of the lead which was just at the connector side, some improper placement or improper attempt to remove the leads But sometimes you may also have some stitches going through the complete lead, through the sleeve, and the worst, which I see unfortunately very often in Germany, is having placed a suture here around both of the leads. So in general, it's just one lead who is showing up with some dysfunction. But in those cases, you have to remove both of the leads by itself. This was an improper placement of the suture causing an insulation defect. The worst thing we also see sometimes is a lead repair, which means the lead is really not in a proper way. So if we do the lead extraction, we go first with a stylet or a lead locking device. Then we go for a mechanical rotational sheath or a laser sheath. And if we fail this, which is only in about 2%, perhaps even less, we go for a femoral approach, sternotomy, or extracorporeal circulation. This is an example of a lead locking device, and you see when it is just put in, this is very smooth, like a kind of stent, and if it's released, you see it opens up there. It's getting really very big, and this holds through the complete lead body, which is very nice because you have most control over the lead if you pull. The laser sheaths are used very often if I have multiple leads, because the laser itself, it doesn't destroy any insulation of the other leads, and you see it's going really smoothly, going apart from the other leads down through the whole system. Sometimes you may also exchange in between the leads if you're stuck there, but this is an example where we just could manage to go through, and this, you see, it's not really scratching any insulation, and especially if you would like to just replace the dysfunctional leads. This is, I think, the best technique. Then we have a mechanical rotational tool, and you see this is a single lead. I prefer them almost ever in single leads, because you likely may scratch the insulation of any other lead if you pass through. And you see you can go with both of the sheaths up to the very tip of the leads carefully, but nevertheless it's possible. I put all the patients under general anesthesia, and I always prepare them for open heart procedure. We do a TEE all the time, and we have extracorporeal circulation back up. So I wouldn't recommend to do those operations without any of those features. If we have some intraoperative hazards, most of them belong to the SVC, and you see here the SVC. Most of those hazards occur at the middle body of the SVC, but also at the SVC right atrium junction. The tear is one of the most frightening complications, but to be honest, it's really rarely occurring. We have intraoperative mortality of those extractions, which is meanwhile less than 0.4%. And even if you have complications, because we have to get a stiff wire also from the femoral side to the right jugular vein, and we are able to place a super compliant balloon if an SVC tear occurs. So in those patients, you may get them in over 86% alive from the table and without any problems. If you don't have that placement of a balloon, then it may go down to 40%, 30 to 40%. It depends on the setting and on the leakage. You see the perforation here, which is caused by a laser sheath in this case, and the balloon is really closing up nicely. We were able to operate there in a bloodless situation, which is very nice. So lead extraction, in most cases you will get without any problems, but you have always to expect the unexpected, which means you have to go really carefully with the indication. You have to look for proper diagnostics. Intraoperative findings may also change the technique you use, and you may have to face interoperative hazards, so it's normally a team approach, and at any steps things may become absolutely different, so you never know when you start where you end up. Thank you very much for your attention.
Very good talk. do you use bridge balloon as a routine or just keep ready?
Yes, I just take a stiff wire which I place from the femoral side to the jugular vein, but I do have the balloon on site at the desk because this is really expensive. Even in Germany, we have to look at the costs, and so we have it ready to use, but it's not on the table.
So if it is costly in Germany, you can imagine our condition, even worse. Right. So overall, I was little late in the talk. I think you have a lot of experience of lead extraction. And can you please give the slide of complications, overall complication in your experience?
Yeah, it's to be honest, I was working since many years now with very different tools, and according to the most common tools which are now on the market, I think they are much better compared to the older ones. This is especially true for the laser sheath. And if you're looking at the literature, you may see a lot of problems around the laser. So the laser was always called a very, very frightening tool, which is causing a lot of risk. It's not the truth. There are more current publications, they indicate that the risk is really getting lower, and for sure it's a matter of experience. This is also sure. But my last, and you have seen perhaps the case where we inflated the balloon and we rescued the patient. He went out of the hospital without any problem. It occurred, I think, 2 years ago now. So this is really rare. And I'm doing lots of those operations. Meanwhile, I'm doing about 200 per year. So this is really rare, but never, you have to be prepared in every patient. And I know that meanwhile, you may see some risk scores on publications. I don't rely on them because I've seen really hard to remove leads even after 1 year or 1.5 years. And you may just get outed without any further sheath if it has been implanted over 10 years in some patients. So you never know. And this is especially where I was focusing on.
So you mean to say the laser had more complications in your experience?
No, definitely not. It's about the same compared to the mechanical rotational tool. It depends really on the patient and on the patient issues where you may have some severe calcifications which may cause by itself the problem, not only the sheath, but if the calcification is entering into the vascular system, it may scratch the vascular system itself. This is something which we have seen, especially in young patients sometimes. It's mainly not the sheath itself, but it may be the pressure you use, and it may be according to the technique in many cases. So I think it's not about
any difference in the complications or difficulties when you remove leads which have been put on the right side because of the acute angle on this?
Yeah, this is sometimes told, but to be honest, from the right side, I'm not unhappy if I go even with the laser. The laser is a bit stiffer compared to the tight rail, but nevertheless, if I do have the impression that especially at the junction from the subclavian vein into the SVC, there's some problem, I go with a tight rail perhaps first, and just go later on with a laser sheath again. But it's sometimes harder. But if you do many of those procedures, I think it's not a big difference. And this is also the same for an active versus passive fixation at the lead tip. I'm always asked for that, but I don't see any huge difference.
Yeah. May I ask you a question? Brigitte, it was a wonderful presentation. So how do you decide? What's the threshold that you are going to use laser in the patient? Because in my experience, I have done around 5,000 CIDs and maybe, extracted 35, 40 leads. But if, and mostly, it's mostly pacemakers because ICD's lead extraction, it's less common here. So, and most of the time, around 100% rather, we could extract by untangling the lead and with taking the stylus down. With the traction, you can take it out. So which cases you choose directly go up front for laser, and how do you decide? Or you try it first with, otherwise, and finally you take a call that I will go for laser there in this case?
Yeah. It's a kind of escalation strategy. So I just put in first a starlet or a lead blocking device in most of those cases, and I just pull. In some cases, you will manage to get them out. This is about 30%, and then I go for whether there's any calcification, which I assume is inside the vascular system. Sometimes you feel it also. If you pull, you see whether there is a huge dense fibrosis already at the upper venous system, or if it's more on the cardiac structures. Then this is one of the decision criteria. But also, as I told you already, if I have multiple leads, I tend to go with a laser first because I don't disrupt the insulation of the other leads, so they maintain their shape, and also the insulation is not scratched, which is very important, especially even if you have to remove all of the leads. It's very nice to have every lead just in a good shape and not scratched, not any injury to the insulation or even to the conductors, because then you may get into trouble because you have then a high risk for lead fragmentation, which is really hard to overcome. Then you have to go for femoral tools and all these things. And so if you have multiple leads, I tend to go with a laser. If I have single leads, I tend to go with a tight rail. And if I have very old leads, I also go in tendency more for the mechanical rotational tool, and the newer leads with a less dwell time, I go with the laser.
Any advantage of doing a CT or a MRI before starting the procedure? Does it help you in any way to plan your strategy?
Yeah, as I told you, in young patients which have been implanted in very young ages, when they grew up, I really like to have the CT scan. But the CT scan in general doesn't help me a lot, because you have seen perhaps the patient where I put the balloon in. I did have a very bad gut feeling in this patient. I don't know why. I was just wondering, and I did a CT scan. I did also a 3D CT scan reconstruction, but it didn't help me. It looked quite fine. There was everything inside, but nevertheless, in this case, a perforation occurs. So we don't have so far any diagnostic tool which tells you really whether the risk is high or low. So I think it's in most cases it's also a matter of just the vascular system is itself. Because in this guy, he had a chemotherapy for many times, so it may be a fragile vascular system itself, and there are further risk factors which may occur.
Thank you, Dr. Oswald. That was a very enlightening session. If there have been no questions from the audience, I think we can move on to the next one.
Thank you.
Thank you, Dr. Oswald. Thank you for being with us. We'll continue with the original session, and I think we'll have the three speakers first, and then we'll go to the questions, if that be okay. Though the topics are a bit unrelated. So we go to the next part of the previous session, a talk by Dr. Dilip Kumar on tricks for an uneventful CRT. And again, I think Dilip will highlight the practical aspects of how to do CRT on a day-to-day basis. Dr. Dilip Kumar, please.
So can I have my slides up there? Yeah. So I think CRT, because of schemes coming in West Bengal, numbers have really increased. The scenario which we saw 5 years back is not there now, and even a small town, they are doing around 10-15 CRTs a month. So important to know how to do an uneventful CRT and not to complicate that. So it is a wonderful therapy, we all know, and it has given us results. So I'm not going in the recommendations and all. So this is basically, we have to find a proper vein. So we have to be aware about which vein we should target. And it's not a particular vein which is important, it's a particular site is important. The latest LV activation is important. So look at QLV before going for implantation. And this is how it's seen in RAO and LAO. So my posterolateral vein, posterior vein, sometimes lateral vein, and finally, in extreme situations, you can go for a middle cardiac vein as well. So we have a publication where we have done a middle cardiac and RVOT placement when there was no other option, and we got very good results in these patients even, and we published that literature. So uneventful CRT, the first is to start with a puncture which should be proper. It should not be a kind of a puncture which is going to be intrathoracic and can complicate. These are very, very sick patients with very less reserve, so a small pneumo or hemo can decompensate the patient. And you have to have your puncture lateral to the first rib, the medial border. Sometimes we can go for a cephalic cut down. So I did a cephalic cut down in 2011, and I did 2 cases, but they were really, really difficult. And this is, you expose the vein, and you directly puncture it with Zelco, and take 3 wires down, and then you can dilate it serially and take 3 leads. But even if you do it, the success with cephalic is only 64%. So better not to try cephalic. This is my option. If you are okay with extrathoracic puncture, go for that. And if you're not very confident, then you can definitely try cephalic, because in West Bengal there is a culture of looking for veins and going for cut down and then do it. So extrathoracic puncture should be the ideal way to go in. Next comes the venous access. So venous access sometimes can be very tricky, and especially right side. You see this patient had a left-sided, I was upgrading this from VVI to CRT, and there was a severe obstruction of left SVC, subclavian vein as well. And you see from right I had to go, and that was such a sharp angulation that I ended up with staining and all. So as long as it is staining and nothing going out, it's okay, you can continue the procedure and do it. So once your access is done, you have come to the RA, RV, then comes the CS cannulation, which is important. And this is, you see, the access-related problem. We had to dilate the subclavian vein and SVC, and to take our third lead down. This is a balloon venoplasty, and we again publish it. So especially when you are taking a patient with a DBR or a single valve replacement, post-CABG patients, they have a very complicated venous anatomy. Now coming to coronary sinus cannulation, you have 2-3 ways. One is to take an Amplage catheter and look for the coronary os with a contrast, or sometimes you can surf with a thermowire, or sometimes you can take a quadripolar catheter. But in failing heart, angulation is very steep sometimes, and it is difficult to engage and go up. So you may require some additional ticks and drips. I will be showing that. So this is basically, you have to take a quadripolar catheter, and you can telescope that. Those who are doing regular EPs, who have a good hold of that, an idea about that quadripolar lead, catheter, how it behaves, it will be better for them. And this easier option is take for Amplage, depending on the curve of the RV, dilatation of the RA, and then you look for the os. You see here, now we have reached there, give in contrast, take the thermowire up, and then telescope your Amplage over wire and sheath over the Amplage catheter. Sometimes the angulation is very steep and RA is very dilated. So once your Amplage is in, you don't get enough support to take your sheath up. In these cases, you have to replace the Teramo with a stiff wire. So with the Amplage in, you take a stiff wire, and with this support, you can take your sheath in the coronary sinus. And once you are in sinus, you can give injections either with balloon occlusion, or with, if there is a backflow, you can directly inject, you can see. Or a levophase injection, we all know. We have a idea before we go in which vein to be targeted. Many times you land up with CS dissections. So you should not be worried. You see this case, one of my junior was doing, and we found that there was a CS dissection. But we took a little hydrophilic wire, we went in, and we could do the procedure. Sometimes when you are surfing for the coronary sinus, you can come across structures which are really confusing, like this structure. Every time we're going in, we're finding this. And then we got a normal sinus, and we did the procedure. It was an abnormally enlarged singular Thebesian vein in right atrium. So you should not be worried. You should be relying more on your levophase injection. We had an idea what we are dealing with, so we were not disturbed with that particular structure. Now coming to the tricky thing, that is LV lead placement. And LV lead placement is nothing but finding the right vein and support. You have good support, you can do it quickly. Support can be escalated by first one buddy coronary wire, which we know we do it in coronary many times. And second would be you can do a balloon angioplasty. You see here, This was a kind of a diseased, or there was an obstruction here in the branch where we were trying to get in. So we balloon dilated that. And after the balloon dilatation, you see here, we dilated a 2.5 balloon, a 12 millimeter balloon, and then we could do the procedure. Then the next level of expertise is having a hold on subselect catheters. Once you are okay with normal, you get a good coronary sinus vein, you take your wire down, take your lead down. But sometimes the next level of expertise is taking and controlling subselect catheters. And subselect catheter is important, and it should be known that you have to take the subselect inside the branch. It should not be just pointing out there. It will not give you enough support. It has to dive in the desired branch, and then you can do the procedure very easily. So you see here, it was a difficult, lead negotiation. So we took the subselect very, inside the tributary, and we could do that procedure. And then this was, sometimes you have to use JR catheter because subselect doesn't give that angulation. It comes in 90 and 120. And this was a RVOT, and a middle cardiac placement. This was an interesting case. You see here, this is basically a levo phase injection, and we could see our targets here. And there I was planned to go in, and then we took the procedure for a CRT. So this was the situation. This was a persistent left subclavian to coronary sinus. Then we had to shift to right side, and from right, you can appreciate the flow was so much that I was not able to see because levo phase was there, so we knew where we have to go. And you can see the subselect was not at all pointing there. So this is a JR diagnostic catheter, and then this is a loop, coronary loop, which went in through collaterals now into coronary sinus. You can even exercise this through a snare, and you can make a rail there, and with support you can place your leads. So finally we could do that procedure. Patient is still doing well. And then obviously lot CRTs we can do. And this is a word of caution, since the talk was on uneventful CRT tips and tricks. You should avoid this kind of actions. You see, you can make out that this patient is going to have complication, and it happened indeed. And this was a large contained pericardial effusion, you see. And then we had to drain it after some time because the patient was decompensating. Or we can see the pericardial, the fluid here and the collection here. And once we drained the pericardium, we could do the procedure after that. So it's not if you are careful enough to guide your procedure, you can do it even after complications. So with this, I conclude. Thank you very much for the patient hearing.
I think in the interest of time, let us have the three speakers speak, and then we'll go to the questions. Dilipda, if that be okay?
Next case, next presentation.
So next, may I call upon Dr. Shuchit Majumdar, who is going to speak on new algorithms in CRT and ICD. Shuchit had to attend to various other events at home, I believe, and he had rushed in after finishing all those.
Thank you. Thank you, Dr. Dilip Kumar, for giving me the opportunity to speak in this gathering. Thank you, chairpersons, for this deliberation. So the thing is that new algorithms for ICD and CRT, the new thing is not that much, I think. There are few things, but it is not that heavy, and that lot of things has come recently. What is new, that is also another thing. Because things in the last 5 years, if I think as new, then there is not many things, maybe 2, 3, 4 things maybe there. So I will be focusing a few things which have happened recently, and then a few things which has happened maybe in the recent past. So the evolving concept of ICD and CRT is to minimize the appropriate shocks in ICD while maintaining the safety net of ICD to prevent sudden cardiac death. So inappropriate shock should be prevented, but it should not miss an appropriate shocking opportunity. That is the most important thing. Secondly, CRT, for CRT it is that we have to have a maximal CRT therapy with minimal battery consumption, better waveform fusion. And algorithms usually change over time to address these needs. So, and this necessity is the mother of invention. So we have to think what was the necessity to bring these newer algorithms. Now I will come to one concerning case report. This case report showed that a patient, which was, I am just telling the history, I have not got it here. So it's a 29-year-old patient with a dilated cardiomyopathy, and he had this ICD, and patient had a polymorphic VT, during which ICD did not shock for first 5 minutes, and after that it shocked. The patient came in anoxic encephalopathy, but finally the patient was resuscitated and went home. So this is the ECG for the patient, which showed that if we see the far field, we can see very clearly that there is a polymorphic VT or VF running, but the near field, because of the undersensing, it was not detecting it as VF. Also the counter was changing between a sense rhythm and then a fast rhythm. So all this confused the ICD, and it did not shock for the first 5 minutes. Finally, it shocked after 5 minutes of VF. Fortunately, it detected and committed, and then when the patient came, it came with anoxic brain injury and had a prolonged hospitalization. So these things we should avoid. So why this happened? The patient had polymorphic VT. So there is an algorithm in St. Jude ICD, that is the sensitivity. So it dynamically adjusts the sensitivity, and the average interval is determined by measuring the current interval. Now the average sensitivity is determined by the height of the maximum height of the previous QRS complex, and then the threshold for detection starts at a particular delay, that is called as a decay delay. That is set maybe at, you can set at 60 millisecond, 100 millisecond, whatever. And that threshold also can be set at different values of the highest peak R wave. So this can be set at maybe 60%, 75%, 80%, so that thing. Now what happened here, because of the Torsades de Pointes, the threshold start was, values were less. So the next was not detected. And this resulted in an erratic or unpatterned fashion of detection. Secondly, there is a concept of binning. In St. Jude devices, you have to have an average interval by measuring the current interval plus 3 prior interval divided by 4. So this, whenever we are adding the intervals which are larger because of the undersensing, the average cycle length is increasing, and that leads to underdetection. So these are the two reasons why this has happened in this case. So to avoid these things, there are different ways. So this is for ICD, we need an accurate sensing, that is enhanced sensing, filtering, true bipolar read, remote monitoring alerts, T-wave sensing algorithm, and better lead. And also we need to reduce the inappropriate detection, but have to facilitate the appropriate detection. So if we see the death in ICD patients, even after putting an ICD, 32% of the cardiac deaths seen in ICD patient are still due to sudden cardiac death. And if we break down this figure, we can find out that out of that, primary electromechanical dissociation is 19%, VT storm is 60%, post-shock EMD is 35%, and shock failure is 30%. So this was the need for developing another algorithm which will take care of this problem. And this is the VFTA algorithm. I am going to detail after this thing. So physician desired to avoid inappropriate shock led to programming with higher therapy zones and longer detection time. And this led to delayed or withheld therapy for true arrhythmias. This is another article which looked at life-threatening ventricular tachyarrhythmia missed by ICDs. So because of the complex and unanticipated interaction. So in this thing, they have taken the, I'm not going into detail because of lack of time. There were failure of device therapy due to deviation from consensus programming, and even with consensus programming, there were reason of failure because detection rate was faster than tested in clinical trial. So here also what has happened is due to the long NID for detection and zone toggling, because it's toggling between the fast zone and then a sinus zone because of undersensing, the device is not detecting and not shocking. These are all different examples. The right one shows a false termination of episode. There is no termination, but it is showing a false termination of episode because there is undersensing of the near field signal because of the sensitivity issues. These are all another examples where fine VF has been detected, fine VF has been not been detected, then VT has been detected as VT, these things can happen. So this can result in failure to detect life-threatening arrhythmias in ICD. And this is false termination. Even in false termination, most important, we can see that though the near field EGMs are small and they are not detected, they are not counted, the far field EGM will have some clues during that time. Now, what are the different clues it can have? It can have one thing, it can have like a pause sort of thing, or it can have very small QRS complexes. So all these things has to be detected. So how to go about it? So this is again the same things. I am not going into detail. So this algorithm. This algorithm takes takes the discrimination channel to check for far field undersensing during a potential VF episode. And if this undersensing is present, then this VFTA algorithm is triggered, and this leads to some changes in the program parameters. So I'm going to here, so I'm going to just directly, this is not very important. So VFTA trigger criteria, there are two criteria. One is a low amplitude counter which looks for signal dropout, and it counts the number of signal dropout. So it triggers only when the low amplitude counter is more than or equal to 2. So if there is a small signal, 0.3 to 0.6, then the counter is increased by 1. If there is a large signal, the counter is reset to 0. The other thing is a pause counter where it counts at 2 seconds or more, every 2 seconds it counts, and if there is a pause during that time, then it counts as 1. If there is a large signal, then the counter is reset to 0. So what happens when VFTA is triggered? The detection is changed to a single therapy zone. Then the new VF detection rate is decreased to a lowest programmed active therapy zone plus 100 millisecond. The number of intervals for detection is increased to 6, and end of episode criteria is increased to 7 terminals, and permanently the patient is programmed to a VF therapy zones. So these are all examples. I am not going into detail due to lack of time. So these are all examples where the VFTA algorithm was working, and it adjusted to a VF zone and shocked successfully when this algorithm is working. So those two things, the difference between the far field EGM and the near field EGM, and the far field EGM is if it is locating low amplitude signals or detecting a pause, this algorithm is activated, and this algorithm leads to a proper detection of VF, and the patient is saved. So these are not, so coming to the algorithms for CRT, there are different algorithms of CRT, the SYNC-AV, the conducted AF response, the effective CRT, these algorithms. Now the SYNC-AV algorithm is a dynamic feature where it automatically adjusts the AV delays based on intrinsic patient rhythm, and it can complement the multi-point pacing. What it does, it senses the right ventricular lead, and then it paces the LV lead according to a particular thing, means it calculates something. I am coming to that. So what it calculates, every 256 cycle, the AV delay is increased and checked for intrinsic conduction. If the intrinsic conduction time is found, then it gives a minus delta, means minus some 50 millisecond, and calculates the pacing. And when it paces, so that measures the conduction interval, and then it results in a narrower QRS because of better fusion. So now coming to the conducted AF response, the conducted AF response is a Medtronic device. It modifies the ventricular pacing rate to be faster when the ventricular sensed event occur and slower when the ventricular pacing pulses occur during periods of ATAF. It increases the percent of ventricular pacing without significantly raising the average pacing rate. In conducted AF response, ICD we usually do not prefer because it increases the ventricular pacing. For CRT patient, conducted AF response is designed to promote delivery of BiV pacing during conducted ATAF episodes, and it works in conjunction with VSR to achieve 100% BiV pacing during ATAF. It is nominally on in a CRT. How it works? It senses. If it senses, then it increases the pacing rate. If it paces, then it reduces the pacing rate. This is how it works, and you can change the level at which it changes. Now effective CRT, so here optimal CRT requires a high percentage of effective pacing or LV pacing. Now how to ensure that LV pacing is capturing the LV, and for that you need to look at the LV EGM. So this effective CRT looks at this thing only. So it determines the percentage of effective CRT pacing by evaluating the morphology of LV pacing cathode to RV coil EGM, and it provides data about the effectiveness of CRT pacing in this quick look screen. So these are, I'm not going into details, what are the criteria for effective CRT pacing. It analyzes 100 consecutive ventricular events every hour and determines the percentage of effective CRT pacing. And how it determines? It looks at the Q wave. So whenever there is a Q wave in the LV lead in the particular EGM which is looked at, it indicates that the LV is captured. So it measures that these are the effective CRT which has occurred, and effective CRT taken as a percentage of ventricular pacing and sensed complexes. Now during AF also, we need an effective CRT for the delivery of optimal CRT therapy, and again the diagnosis is same. So here during AF, initial phase 30 beats of beat to beat rate adjustment, then maintenance phase, what it does, it paces for 30 seconds at the particular rate, then again checks for 10 seconds, like that. If any ventricular sense response comes during that period, again it goes to a 30 seconds of initial phase adjustment. So in conclusion, the algorithm of CRT and ICD will continue to evolve based on clinical needs. For ICD, it is to avoid inappropriate shock while avoiding missing a single arrhythmic death. For ICD, for CRT, it is to assure maximal biventricular pacing and CRT response. Now, for this data to develop, you need more remote monitoring data, and that can help us to find the loopholes in device therapy, and AI will help us to perfect the algorithms. So we need more data for that. All said and done, the best resynchronization depends on optimal patient selection, goal-directed medical therapy, appropriate LV lead placement, and often combined with physiological pacing for great result. So clinical research and innovation should go on and on. Thank you.
Thank you, Sushit, for finishing on time, and please join us on the front seat for the questions. I think we have some time for questions. May I start with just a couple of them? So this is a trade-off of the sync AV pacing that we were discussing in one of the last meets. So this is a trade-off, because we should always try and achieve 100% pacing. We should try and achieve 100% pacing.
So there is some percentage decrease in biventricular.
We should always endeavor to pace 100% in case of a CRT. So that's a trade-off of a sync AV.
Is 99% optimized pacing, so that you're getting optimized, no fusion, no pseudo fusion. It's pure biventricular pacing. So ultimately, anything around 95% plus should be having a good CRT response. So 99% or 98%? 98%, this will be giving you almost 90. Yes, this is effective BiV, exactly what you said is right, sir. Effective BiV pacing will happen here.
But these are very genuine concern. You see, if 1% is gone by your this algorithm, and if the patient has VPCs and all, some in between atrial fibrillation, then another 1 to 2%, and he flips, down to like a less responder, non-responder category.
Even
It's a concern.
response from
Outcome studies will tell us.
Electronic, they also do not work because they will sense the RV, so RV get excited and then the LV will work. That is also not effective CRT. He says response of the electronic.
I had a more basic question for Dr. Devobroto. I think he's been doing a lot of CRTs. In your day-to-day practice, how do you set your VT-VF zone in a patient in primary prophylaxis where you don't know, he has not had a previous event, so you don't know the rate of the VF or VT. So what do you do usually?
So for secondary prevention, it is well known that you set a VT zone which is around 20 to 30 beats per minute lesser than the documented VT. For primary prevention, it has been said that generally you set two zones. One is for which you have a VT zone like ATP plus followed by a therapy of VF, and in the second zone will be above 130 or above 230 to 40, which is around just VF zone, setting only shock, and you can program a ATP during charging. So this is the usual for all across, I think. So.
Another is VFTA, that is ventricular fibrillation detection therapy, can have inappropriate shock where the arrhythmia terminates and may not need.
I did not get your question, sir. If you can repeat once.
Their ventricular fibrillation detection therapy.
Or VFTA, what Suchita was describing, is
so
ventricular
where, say
VF therapy
VF
assurance.
terminated, and it may give because it's dedicated 6 bits only, and it gives shocks, so it becomes unnecessary shocks. Would have been.
This was a comment. Yeah. So thanks to chairpersons and all the speakers. So we had a fantastic session. Now we'll move on. And this is something very interesting. We'll have some programming and session on with simulator. They are on screen. May I invite Devobroto, if you stay back, and Suchit, if you can join Devobroto for the next session. And may I invite Arindam to give his presentation. Arindam, it's yours now. Bridget has already done, na? After? Yeah, already done. Your presentation, then the simulator it will happen.
Thank you very much. May I have my slides? So after very fantastic talks on the programming and newer aspects of CRT and ICD, I'll be showing a new device. Not new, it is by this time I think 10 years old, but not yet very, very popular. Due to many reasons. So subcutaneous ICD, the topic of the talk is potential and promise. So I can remember Dr. Devobroto Bera is there in the chair. We published a paper, I think 6 years back, a review article on the subcutaneous implantable cardioverter, and at that time it was introduced to the Indian market. So we thought let us discuss the pros and cons of the new device. And at that time, many things have changed after that, but some important issues still remaining. Probably those are the issues which still not making this device a very popular one. So we'll discuss briefly on that. So I'll distribute my talk on the patient selection, longevity, size, and patient comfort of the device, inappropriate shocks, ATP and bradycardia pacing, which all are very, very important regarding this device. So as you all know, this subcutaneous ICD, they are preferred for young patients, particularly channelopathy or those kind of patients who require the shock rather than the brady support or ATP support. And why I am saying young patient, because the issue of lead failure is actually more important for young patients. But of late, if we see the data, we'll find that in US, more and more older patients are actually getting subcutaneous ICD. This is the data which is showing the number of older patients more than 40 years of age. The implantation of subcutaneous ICD has gone up. Now, how do we select that who are the candidate who might require brady pacing in future? If there is a class 1 indication for pacing, that is definitely, we all know this patient probably is not suitable for subcutaneous ICD, but there are some other indicators, say for example, history of atrial fibrillation, age more than 80 years, or a PR interval of more than 230 seconds. Those are actually some indicator probably which indicate that in future the requirement of brady therapy is more likely to be more in this kind of patients. So they are not very ideal. So apart from that, if we see the other parameters, say for example, if the life expectancy is more than 10 years, history of device infection, prosthetic heart valve, hemodialysis patient or renal insufficiency patient who are not yet on hemodialysis but might need them in future, they are actually more suitable for subcutaneous ICD. So what is the current rate of lead failure? There are different estimations. If we look into the data, we'll find more or less around after 10 years, 20% lead failure is actually notable. This lead failure actually is more common than the conventional brady pacing. And 3 to 4% have lead malfunction at the end of 1 year. That is a very significant number. And if we see the patient who are actually getting the ICD therapy, a good number of them have some other parameter or comorbidity which tells us probably they are actually might be more suitable to have a leadless pacemaker, leadless ICD. And if we see the lead extraction rate, that is also going up gradually, though these are not our own data, they are all from US data. So cost, complication and mortality rate were significantly higher for infected device, making subcutaneous ICD a better option for those with risk factor for infection. And if we see, whenever the lead is being extracted, 1 out of 7, so that means around 15% of patient, there are some injury to the vein. So that may or may not lead to some catastrophic event, but a significant proportion of lead extraction do have some injury. So lead related issue is very important, which can totally be taken out if you are going for an ICD which is subcutaneously implanted. Now, second very important question or debatable issue is the longevity. As you all know, probably the conventional ICD are actually they last longer, but if you see the real world data, then our subcutaneous ICD also nowadays comes with a longevity of 9 years, which is not very bad, because if we compare that, Medtronic have around average life expectancy of 12.6 years, Medtronic 11.3. This is the PPR model. So if we compare with the conventional ICD, yes, it is still less, but it is not very, very less. It is comparable. Size and discomfort, many a time, the conventional ICD, as they are placed in the subclavicular fossa, it is seen from outside. So for many people, due to cosmetic reason, subcutaneous ICD may be a more preferred option because it is not visible from outside. And if we look into the size, yes, the size of subcutaneous ICD is larger, but if we look into the thickness, actually it is thinner than conventional ICD. So that is having some plus minus effects. So quality of life, this is very interesting. Quality of life, this was evaluated on patients who got the implantation of subcutaneous ICD. It was found that anxiety level, patient's anxiety level was far lesser in subcutaneous ICD, whereas the depression was almost similar. So not a very strong indication, but those are other advantage of this new device. So inappropriate shock had been a very important topic which was always discussed about subcutaneous ICD. Initial devices, due to different algorithm issues, the inappropriate shocks were higher, but after good development in the algorithm, the number of inappropriate shock has come down very significantly. We can see almost from 13.1% to in 2019 it is 2.2%, which is very much acceptable. So that has also been taken care of. Now, many a time, how many percentage of patient, because anti-tachycardia pacing is not available with subcutaneous ICD. This is a very big limitation of the device, but if we see how many percent of patient they need anti-tachycardia pacing, that also is important, because this is important, one of the very important limitation. If we see Who are the candidates who requires anti-tachycardia pacing? Mostly the monomorphic VT subset of patients. Now, in different literature, it was found that not more than 1.8% of the total ICD, implanted patients, they do have this issue. So that is also not huge. And how many percentage of patients they actually get ATP? If we see different device, Medtronic, Boston, St. Jude, around 3.2 to 2.5 to 3.2% actually really are getting ATP. And not only, very interesting factor is that whoever is getting ATP, 33% ATP are actually not successful. They ultimately need a shock. So it is important. Always we should try to avoid the shocks, but ATP is not the final answer. Now, bradycardia pacing is very important because I already showed anybody who has a definite class 1 indication for bradycardia pacing, they are not a candidate for subcutaneous ICD. But if we look into the data, we'll find the implanted patients who are actually getting ICD, less number of patients are actually having, in current data, not more than 90%, they do not have any brady indication. And I'll show you from further research in this field. This is one of the case reports where a subcutaneous ICD, this is the first of a kind case report where subcutaneous ICD was accompanied by a micra, so total leadless solution for that. So this can actually alleviate the issue of bradycardia pacing. And not only that, Boston has further continued the research, and they have one option known as modular cardiac rhythm management. So here a empowered leadless pacemaker, they have their leadless pacemaker named as Empowered along with Emblem subcutaneous ICD. And what is the advantage of this device? Because both of them from same manufacturer, they can communicate with each other, and they are working very hardly to have ATP facility with this leadless pacemaker along with subcutaneous ICD. So that will be a very big step in forward, and this has already happened. It is available, not available for practical use, but it is available. The device is already ready, and this is the report, first in human report of this. And with that, I'd like to finish here. Few comparison from the article which we published. Limitation of the subcutaneous ICD, need for DFT. So at that time, it was a mandatory need to get a DFT for now, but future probably will have answer for that as well. Implantation time for subcutaneous ICD is higher because we are not accustomed, we are not doing huge number of subcutaneous ICD implantation. So any new device will take more time, and probably we need to have some other people who are helping us. But when we implant more such devices, probably this issue is not going to be, important. Now, remote monitoring facility, it was not available in the initial subcutaneous ICD. I'm not sure the current generation device, it is available or not. Initially, the MRI facility was not there, but now the devices are all MRI compatible, and already MRI compatible devices have been implanted in our city also. So these are the, comparison, pros and cons of subcutaneous and transvenous ICD. Most important to me is the venous access. Many a time we get patients where there is no venous access. So in those cases, subcutaneous ICD is the only answer. And very important is the infection. Infection, many a time the infection is recurrent. In those cases also probably it is very important to go for a subcutaneous ICD, particularly in a young patient. And if the patient, many times say that their heart failure patient, if it is implanted for primary prevention, in future there might be requirement of upgradation to CRT. In that case, if you are going for a conventional ICD, yes, putting another lead into the coronary sinus will be sufficient. But for subcutaneous ICD, you need to extract and do a fresh implantation. But at the same time, the venous access related issue are all there in ICD. Many a time we have seen, Dr. Kumar has shown us cases, we get the venous access site issue. Many times it becomes very difficult to upgrade the CRT rather than going for a fresh CRT. So those issues are there. At the time of availability, it was 15 to 18 lakhs. Now the price has come down. Probably it is now less than 15 lakhs. In future, if we use more, probably the cost will further come down. So if I just categorize who are the candidates for this new device, But strong candidates definitely when there is no vascular access, history of recurrent lead infection or pacemaker site infection or lead fracture, many a time that is also very common. And in group of patients, say for example, renal failure, CKD, hemodialysis, diabetes, immunocompromised patient, this can be a very good, strong candidate. Reasonable candidates are the young patients with primary electrical problem, patients with primary prevention indication, prior VF arrest, prosthetic valve, those can be a reasonable candidate. Inappropriate, definitely bradycardia pacing, but in future probably with the availability of newer generation leadless pacemaker come ICD, this can be taken care of. So these are the indication, and I think I should stop here. Thank you very much.
Excellent presentation by Dr. Arindam Pandey. As usual, we can ask, we can have one or two questions.
Extravascular ICD. Extravascular
ICD from Medtronic, which is...
This is also extravascular ICD. There is no relation to vessels because this is implanted in the subcutaneous tissue. So this
that is also implanted.
That is a little different.
I think Medtronic people, they can...
Govind, can you highlight some...
It's on the heart, you can give ATP with that. You can pace also. Yeah, you cannot...
See, but there is a debate is there. See, maybe 8-10 years back was a trial where, and there was a kind of idea that the ICD should be a ATP device rather than a shock device. And now gradually it is turning up some evidence there that ATP is used in less number of patients, maybe subcutaneous ICDs, but as the industry is pushing more and more trials. But I still feel ATP is very important tool, isn't it? Those patients, maximum are IHD patients with a kind of scar, and they do well with ATPs as well.
Yeah, ATP is very important, though it is not required for many patients. That is why the researchers, they are trying to develop, combining the subcutaneous ICT with leadless pacemaker.
already published 1 month back, I think, in NEJM.
Yeah, so this is published, and then this is not yet available commercially. But then the main difference is, yes, it is extravascular, as he pointed out. So there is no lead that is put inside the vessels. There is not transvenous, but the lead is, instead of suprathoracic, it's substernal. So it's a sinusoidal lead where there are multiple electrodes. Some of them, when placed properly, can touch the myocardium or close to the myocardium, and then it can actually pace. So you can actually program ATP for a VT, and it can also do post-shock pacing, unlike a transthoracic pacing from a...
Device is safe.
No, its device is also slightly different, but it is as big as the conventional ICDs.
See, we have been, learning about WISE CRT, where there is a, extra, what Arindam just showed one, is a subcutaneous pocket, there is a generator, and there is a crosstalk between two devices, and there will be therapy will be delivered, like a CRT or maybe here pacing and shock. So what's the status of that? Do we have any kind of clinical studies and on the way to clinical use? Something like these devices, crosstalk devices? No.
Boston people.
Ours,
yeah, go ahead.
Yeah, no such device is available commercially. So there is, as you pointed out, a passive device that is placed inside the left ventricle. On the right ventricular sensing of pacing, it stimulates ultrasonic, wave to go, and then it will make the passive device in the LV to stimulate, generate current and stimulate the LV. So it becomes a biventricular pacing, but I guess it's not yet commercially available.
So just one question for Dr. Pandey from my side. So is there any way to minimize the inappropriate therapies, because it is known, sub-Q ICDs is known for inappropriate therapies, any specific way, or what to avoid, what not to avoid?
So, initially it was 13%. Nowadays, the inappropriate shock has come down to less than 2%. So, it is already not very high. In fact, why there was high inappropriate shocks, they evaluated. And what they found, that most of these subcutaneous ICD were implanted in young individuals. And as you all know, young individuals, they have higher inappropriate shock. And there were actually, studies which compared the young individual who got conventional ICD, and they compared the same with the subcutaneous ICD, and they found actually the subcutaneous ICD, the inappropriate shock is far lesser than the conventional. So it is actually the age is the confounding factor.
If there is no more question, we go to the next session. Dr. Arindam, you can join here us in the chair. And next speaker is Dr. Rakesh Sarkar. He is presently working as EP in B.M. Birla Hospital. He is a very well-known electrophysiologist in the city with a lot of publications. And his talk will be on pacemaker programming for patient benefit along with the simulator. Dr. Rakesh, please.
So very good afternoon, everybody, respected chairpersons, seniors, and dear colleagues. So at the outset, I would like to thank Dr. Kumar for having me invited in this session. And today's topic is programming of pacemaker, simulator-based and case-based discussion. The objective of the presentation is to simulate possible clinical pacemaker follow-up situations. And this is to put more controls in the hands of the physician by creating awareness and to reduce the potential risk. I'll start with some cases, some clinical problems, and that may sound sometimes very basic and simple to the audience, mostly the senior people who are attending. So just apology for that. So I'm going ahead to the first case. So Mr. David is a 16-year-old male with congenital complete heart block, and he was having an dual chamber pacemaker in situ and came back to the clinic with a complaint
You
of...
wanted to have a split screen, isn't it, Sabri? After that, huh? Okay.
So he presented with the complaint of discomfort and lightheadedness when he exercises. So just I would like to ask Mr. Sabri sir if you can just show the simulator based what is going on. And yeah, and so if anybody can volunteer what is the thing. The next slide I will just show just to help you out if anybody can answer or.
So the patient is being put on a treadmill, sir?
Yeah.
So the patient started having a slightly higher rate.
Sabri sir, I have a doubt. You said the patient is put on treadmill.
Yes, sir.
Why suddenly treadmill? Because patient has come with patient with a pacemaker. Means what could be the reason for you have put on the treadmill? Is there a specific reason, Dr. Rakesh or Sabri sir?
So what tried to build up, like we tried to create a scenario where the patient was put on the treadmill, just what is happening with the increasing heart rate, what kind of discomfort he is having, whether he is developing.
He was having reproducible symptom with exertion.
Replicating the scenario by doing that, putting on the treadmill. So, yeah.
So the rate has gone to 110.
Yeah, with the higher heart rate, what is happening?
And the rate has gone to 120. And his maximum tracking rate is 120, that you can see it in the lower screen where the parameters are there. And some phenomena is happening now.
We can actually pause and ask for a volunteer what is happening. Any of the postgraduates in the hall.
Yeah, anybody if can volunteer and just, it's very basic and I think most of the people can understand already.
Saroj, you want to volunteer? What is happening here? Winky back. Yeah, you are right.
Yeah. So perfect. So just going ahead with
separate behavior.
So this is nothing but upper rate behavior, or you can say this is the winky back phenomena. So with the increasing heart rate, there is a situation or a particular condition where you can have the kind of missed atrial sensed beat which is not being tracked, and on further elevation or the increment of the heart rate, there is another situation which is created here. Can you just tell me what is happening on top of winky backing?
So the rate, actually the atrial rate went up to 140, 150.
Right. So basically it went from the winky backing to 2:1 AV block. So this is the scenario where the heart rate goes up high and the patient or the person who is completely dependent on the pacemaker behaves initially as a kind of winky backing, and then it goes to 2:1, and that may not be the required heart rate to meet the demand of the body, particularly at the time of exercise, and the person can easily have the symptoms of lightheadedness or fatigue and so many other things. So I'll just try to point out this particular area. So this is a bit different, that winky backing and the 2:1 block. In the initial phase, the winky backing keeps on going, and after a certain situation, it has the kind of behavior of every alternate P wave which is not being tracked, and that may be the culprit in this kind of situation. And this situation, that is a 2:1 block rate, is calculated by the particular parameters, that is the TARP, that is the total heart rate, if we can consider as 60,000 divided by the TARP, that is nothing but the sensed AV delay plus P verb. So that is the TARP which is being divided from 60,000. Yeah. And you can get the 2:1 AV block at what situation it can generate. And from the previous case, you have seen well that in that context, that AV block generates, the 2:1 AV block generates at what heart rate. So that is well anticipated, and how to avoid the precipitous fall in heart rate. So the aim to have the 2:1 AV block rate set higher than the MTR. Definitely you cannot keep the 2:1 AV block heart rate at the same level. You have to be little higher so that you can avoid 2:1, particularly in the younger population, in order to accommodate high intrinsic sinus rate. And to minimize TARP also, there are few algorithms, that is you can shorten P verb just to avoid this kind of situation, but at the cost of having PMT and some other nuisance. AVI can be programmed to be rate adaptive. That is one of the features that is customizable, and you can keep it on. Normally it keeps switched off, but if you can keep that AV delay, that is dynamic AV delay on, so you can very well manage this kind of situation, particularly in the young population. And program to DTDR mode sometimes can help you out to get the sensor driven rate smoothing, because sometimes sudden rate changes can create the situation when patient might be very much uncomfortable. So that is the final situation which we try to reprogram. That is program rate response AV delay to high 2:1 AV block, and along with that we made that maximum tracking rate 150, and you can see that mostly it is 1:1 conduction going on. At the same time, that program rate response P verb is also on, that is kept here as 150 post-ventricular atrial banking, and at the same time that rate responsive P verb is low as kept here, and as a result you can get away from this 2:1 or winky backing most of the time. So the second scenario or the case, that is one lady 65 years old who brought to ER with the almost collapsing situation. She had a single chamber pacemaker implanted 5 years back for the intermittent CHB. An external temporary pacemaker had to be inserted at ER to just control the situation, and pacemaker lab assistant was called and device was checked, and the permanent pacemaker device setting was for amplitude and pulse width at that time was 2-fold at 0.4 millisecond. So I'll just ask Mr. Sabri just to show the simulator. If anybody can just tell us what is happening.
Go to the
Please
programmer.
Yeah. Please.
Yeah, keep it running. That is as it is be. So, if there is any volunteer, otherwise the moderators will volunteer. Anyone? Shobik? So it looks like the V pacing marker is coming, but there is no QRS. So there is loss of capture.
Right, right.
So this is one finding. Anything else? Okay, I think that is all what we have now.
Right. So as Devuda picked it up very quickly, as he's an eminent electrophysiologist, so device is showing V pacing, but it is not actually capturing the myocardium. It is the capture losing. That is the capture not happening at the level of myocardium, although it is falsely interpreting as V paced. So what can be the situation? That is definitely there is some issue with the threshold or the output level which is not adequate to generate the evoked potential. That is the crux. Now, how to get away or troubleshoot this situation? So there is sudden increase in the patient's ventricular threshold as anticipated from the simulator, and it was increased from 2 volt to 0.4. 2 volt at 0.4 millisecond, because already it gone high, and on new threshold level at 2.25, it actually keeps on pacing, which we found later. So basically this is a problem sometimes happened when we anticipate that the longevity will be expected at high level with the low output level, but somehow there is some problem with the higher threshold, and at that time, at that fixed output level, patient might have some kind of capture failure and all these things, resulting in a kind of situation when patient can present with that collapsing situation at ER. Now, to get away from this problem, there is some algorithm and one a very good tool that is called auto capture, which is available in St. Jude, and at the same time Medtronic and other vendors have the similar features, which can be set as automatic way of looking the threshold and measuring the threshold bit to bit, and you can keep the threshold as a dynamic, keep the output at a dynamic way slightly higher than the threshold level, so that you can ensure that the capture will not, there will be no capture loss and the output will be adequate every time. So one more thing just to tell, that performance of the auto capture is available at with the programmer for every devices, and should be done with at least few days after the implantation, so that the lead gets stabilized. And there is something called auto capture setup test prior to go for the auto capture threshold test. So these are the thing I want to skip, because this is more like a simulator session, and if there is anything with the capture loss at the time of auto capture threshold test, there will be definitely some backup pulse. So the last case I am trying to show, this is a routine pacemaker follow-up clinic. There is
Rakesh, if I can make a pause for a second. So couple of things. In last case, we knew that the way you described how to tackle the situation.
Yeah.
We also possibly need to know why this happened, why there is a sudden rise in threshold.
Yeah.
Who was otherwise capturing at 2 volt,
Yeah.
now has not capturing. So I would put it in a way that either there has been recent rise in threshold which we call exit block, maybe that local myocardium has got some injury. For it, there may be a myocardial infarction which has got that the threshold in the local area has gone high. There are other possibilities as well, like a patient with a diabetic ketoacidosis has a hyperkalemia, it's a transient rise in the threshold. There's other possibility we need to exclude is some lead failure. Like if this is a lead which was doing well otherwise for last 5 years, now suddenly why the threshold will go up? Maybe we need to look at the lead impedances. We need to also do some dynamic maneuvers whether there is any noise or anything.
Right.
And if we exclude that the lead is okay and there is no treatable entity like hyperkalemia, acidosis, and we will assume that this is a exit block in the local myocardium, and the way you have treated is absolutely fine. Just for the discussion for the youngers.
Yeah.
Thank you.
Appreciate it.
You can move.
So because we cannot expect sudden rise from 0.75 to 2.5. Now this is the last case. This is Jim, 50 years old male, implanted with a dual chamber pacemaker for 6 sinus syndrome with intermittent high grade AV block. And here, follow-up 6 monthly schedule. Please, on interrogation, some observation we noted. So I just would like to ask Mr. Sabri just to go for the simulator display.
So Suchita, you want to volunteer? What is happening? Because I see everything is all right, so I cannot volunteer.
No, actually, I think I cannot see all the parameters and all these things there. So there is initially it was a 6 sinus syndrome. No, there was a high grade intermittent AV block also. So what is that? So maybe there something A-sense V paste is happening. So what was the AV delay? It is, I cannot see from here.
Yeah, 140. That is.
Okay. So 140.
Yeah, on the real screen that has been set. That is after programming, which is displaying in the lower panel. But I think this 140 or something. What is there in the simulator, Sabri sir?
Now something else is happening.
Yeah.
So the some VS increased number was there. So 50 years in his. Apart from that, I cannot see.
So Sabri sir is the volunteer now. Sabri sir, you are the volunteer now.
Yeah, actually, this was like a googly. Nothing is happening actually. We wanted to ask you that, but this was basically we were trying to create a pseudo fusion. So if your sinus beat is same when the ventricle pace is occurring, so what could be the reason and what could be the algorithms which can be of use there? Sorry about it because it was coming earlier, but suddenly I'm not getting the pseudo fusion now.
So yes, spot on.
The idea of putting the slide, it looks like very normal as Suchita said. Apparently there is nothing problematic, and you can see that A-sense V pace is going on. So what is the harm of this problem? With the system. So basically, as I told, that is an intermittent AV block with a slight stretching of the AV delay which has been set here. We could be able to see that it is actually A-sense, V-sense going on in the underlying rhythm, and whatever is coming as V pace, it is nothing but the pseudo fusion, because V pacing is happening, but there is intrinsic 1:1 conduction with slight stretching of AV delay. So we can avoid actually unnecessary V pacing in a lot of situation by by some modification and keeping it a dynamic AV delay with the available option of VIP or sometimes MVP or AV search, something like that. So the idea of putting the slide is that to avoid the unnecessary V pacing is possible always. And if we look at the slide on the right panel, you can see that if we keep that AV delay as 145 or something like that, that V pacing will be there, but it will not actually capture the myocardium because it is already activated with the intrinsic 1:1 conduction. So here lies the idea or the essence of some algorithm called ventricular intrinsic preference or managed ventricular pacing like that, which can look at the intrinsic AV delay all the time and avoid unnecessary ventricular pacing beat to beat or in a very short cycle or interval. So as VIP goes, the search cycle length can be 1, 2 or 3, which is customizable, and the search interval is also modifiable, that is 30 seconds, 1 minute to 30 minutes, sequentially. And by programming that ventricular intrinsic preferential pacing on, that the total AV delay becomes higher and you can avoid that unnecessary ventricular pacing. So with that, I would like to conclude here. And you can see here that after certain situation, that A pace, B pace gone up to A pace patients. And if it is not coming with the 1:1 intrinsic conduction, again it will go back to the already optimized AV delay mode, that is A pace, B pace, but that will not be too long as a non-physiological AV delay. So thank you. I conclude here.
Thank you, Rakesh, and thank you, chairpersons. Now, brainstorming session has started. It was just a trailer. We will have by Dr. Aftab Khan, Dr. Rabin, and there is a quiz. So I better advise everyone to have break for 5 minutes for tea. Get yourself, on, and we'll go with the next sessions. So 5 minutes coffee break. There will be random questioning now. Aftab sir and Dr. Rabin will do. At least Dr. Rabin will do.
এখানে হবে তো
একটু হেল্প করতে হবে, একবার ট্রাই করুন তো। ডিটেক্ট হচ্ছে না, ডিটেক্ট করছে না। ইয়া
যদি এটার মধ্যে 2 ঘন্টা থাকে
Going to commence the penultimate session. So I request Dr. Sanjeev Patra and Dr. Sanjeev Mukherjee to be on chair. Kaushik, can you help inform Dr. Sanjeev Mukherjee there? Kaushik, Dr. Sanjeev Mukherjee. First, we'll wait for 2-3 minutes. Let them come. I request Dr. Gosajra sir to be there in chair, sir. Bush sir. We are starting, sir. Sanjeev, we can announce. You can invite the speaker.
This is the one.
Should I start? You have already announced? Already announced? Yes. Okay. Dr. Aftab Khan, who needs no introduction, is one of the premier intervention electrophysiologists as well as the intervention cardiologists, will speak on troubleshooting ICDs for appropriate therapy. Simulator session. Please, Dr. Khan.
Yeah, good evening, and I know we've been keeping you up before the match starts, so I think let's finish this up fast and all go home. So today the talk is going to be on troubleshooting and ICDs and appropriate therapies, and this is again a continuation of the simulator session like you had the pacemaker session the last time. And so this means that there's likelihood of more interaction. So I speak less and you people help out more. And we have Mr. Sabri there who's going to do most of the work there. So my role is really limited here. So just the purpose of this session is basically to understand and all of us learn how to handle ICDs. The problem with ICDs is that most of us, like a pacemaker, are quite competent to implant it. The problem starts when there is a trouble and the patient comes back with inappropriate therapies. And that's the time I think we all realize how little or how uncommonly we handle these patients or help our patients to manage them better. And that's the reason of learning from this present 3 cases. So this is the first scenario, and this is a common scenario that all of us face. This is an elderly gentleman who has come in for a secondary indication of an ICD. So he's had a documented VT, a monomorphic sustained VT at a rate of 190 beats per minute. And this is a post-myocardial infarction patient. Though his EF is 45%, here the indication was because he's already had one episode of VT, which was documented, and that is the reason he is coming in for an ICD implant. So there are two things that we do. We of course put in an ICD, and we know that there are options that we can probably do a DFT testing, or we may not do a DFT testing. And frankly now, there are trials which show that there may be no difference. But the only reason for doing a DFT testing in many of our patients now would be if you're doing an unconventional ICD implant. For example, if you don't have a device on the left side, but you put it on the right side, you wouldn't want to do an ICD DFT testing. Or if you have really a patient who has had, say, an anomalous, you have a patient where you're putting in a subcutaneous ICD, for example, or where you're just looking for an ATP where you'd want to look at. So there are different indications where you would really want to do a DFT, but I think if you look at these present indications, and there's hard data to say that DFT testing alone may not be needed in majority of the routine implants that we're doing. This was a case that was done way back, and therefore this is a patient where DFT testing was attempted. Now, when we did a DFT testing and we found that we could induce a VT at a rate of 160 beats per minute. So what exactly would you do? And we've done a DFT testing, and the DFT turns out to be at 20 joules. So this is where we are now, right now. This is a secondary indication for a ICD implant for a secondary VT. This is a patient who has LV dysfunction, who has had a clinical VT at 190 and an EP-induced VT in the cath lab at 160 beats per minute. And this has been successfully terminated with a DFT of 20 joules. So what are the therapies that we would want to put on? So if you look at the lower side there, you can see that there are certain therapies that have been turned on and certain therapies that have been turned off. So how would you want to program the device? So there are 2-3 things we can do. We can sometimes program it only in 2 zones. So we can have a VT zone and we can have a VF zone. That is what we can do. Or the other thing is that we can put it in 3 zones. We can have a VT, an FVT, and a VF zone. So again, this comes to the discussion is when would you want to have a 2-zone and when would you want to have a 3-zone therapy? So usually when you have a slow VT also going on, similar to the 160 that we are seeing here, we would want to have a slow VT zone where we would want to try mostly the ATP therapies. Whereas if you have a patient who has fast VTs, where you do not want to really try the ATPs, you would probably want to go on to just a single, the FVT zone that we talk about. You would want to try just one ATP, and you probably want to go on to a cardioversion right away. So when this patient has had a slow VT inducible in the cath lab at 160, what we would want to do is to program him in 3 zones rather than in 2 zones. And we would want the first zone as a VT zone, where you would keep the VT from 140 to 150. The second VT would be the FVT zone, where you would program it from, say, 170 onwards. And then you could have the VF zone when you could have it more than the 200 beats. And as I said, in the slow VT or in the VT1 zone, we would probably want to try more ATPs rather than trying cardioversion. Whereas in the FVT zone, you would probably want to give a trial of ATP, just one trial of ATP, which is usually burst rather than ramp, and then go on to cardioversion. And in the VF zone, you always try only cardioversion. We do not try ATP there. We have an option of what we call as ATP during charging, which of course we will talk about later. The other thing is what is the threshold of, or what cardioversion dose do we start with? So here we had a DFT at 20, and now what we usually do is to keep a safety margin of 10 joules. So because you had a DFT of 20, your first cardioversion would be at around 30 joules to start with, and then you put at the others at a higher to max device zones. Or in the VF zone, you would probably want to start with the max right away. Again, there is no much data now, unlike the past when we talked about a low voltage shocks, because that time earlier it was believed that low voltage shocks were probably better off, but now we know that low versus high, there's not much of a difference in the outcomes, and therefore a low joules cardioversion is usually out, and we would probably want to go to the high joules right away. And the second option, as I said, could be to program it into the 2 zones itself, but again here the problem would be that you would end up requiring a lot of therapies in the slow VT zone, which sometimes can be difficult. And the third option is, of course, is to use monitor zones. So would you like to, somebody show us the screen? Okay, you have the screen here. So can you show us the induction in the cath lab? I don't know, do you have the fibber there which you have shown the BT? So while Sabri is bringing it out, I think the data for the reason for using ATPs rather than cardioversion immediately comes from the pain-free trials, which was done by the Medtronic. So the pain-free and the pain-free 2 trials have shown us that even in fast VTs, where there was initially a concern that if you try ATP, you can accelerate these ATPs into a VF zone, it has now been found that up to a rate of almost even 250 beats, you can try an ATP first rather than trying a cardioversion first. And it's been shown that cardioversion, ATPs rather than cardioversion may improve the quality of life of these patients. And trying an ATP in the fast VT zone without the need for direct cardioversion also improves the patient's quality of life without compromising the safety and or a worsening of his clinical hemodynamic consequences. So here in this trial, it was found that as many as 72% of patients, this was a prospective trial. And what was found is that in the two arms, as I talked about, an ATP arm or the shock arm, when you tried an ATP in the fast VT zone with an ATP sequence vis-a-vis a time where you do not try the ATP and go on to cardioversion alone, in the shock arm versus the ATP arm, it was found that there was, in the fast VT group, 75% of patients had a successful pace termination with an ATP itself without the need for a cardioversion. And we do not want to, because of the fact that these are fast VT zones, here we do not try many attempts. So what we just do is one cycle of an ATP, which is usually a burst, it's not even a ramp. And then if this does not work, you go on to directly a shock or cardioversion with your high energy. Yeah. Yeah, you could do an induction and show us what happened that time.
So you are using a DC fibber that is
So that's what we were talking, sir, a few a little while back. You were not there regarding subcutaneous ICD and the need of ATPs. And so in pain-free, I think this trial came in 2013-14. And then there was a kind of idea that devices should be more of ATP devices rather than shock devices. And when subcutaneous ICD came, the data emerged that we only require a need of 2 to 3%, we terminate with ATP only. So sometimes things changes, like when the CSP came, 5% LV dysfunction went to 20%. So never know, but it has to be our, wisdom decide things.
Yeah, I think it's more to do with the clinical situation of the patient. And I think that cannot replace your any data that we look at. So I think you're as a clinician is the best person to decide how clinically significant the VT is. I mean, we do see patients who have VTs at young ladies also who have probably a scar or a sarcoid, and they can sometimes tolerate the VTs pretty well. Whereas a patient with an ischemic LV dysfunction, who sometimes even at a rate of 170, could be pretty hemodynamically unstable. So I think it all comes down to the clinical scenario also. Yeah, so Sabri, you want to take us through this? So this is a patient where you have induced the...
So this is a place where we started it, sir. So there are many therapies like DC fibber is one, shock on T is the most common one which is used. So we are using DC fibber. This is 2 seconds of 9 volts of energy. And after 2 seconds of energy, it induces a fibrillation. And immediately it is getting sensed. And when the detected number of intervals matches the one which we have programmed NID, it started charging. And after some time, it gives a charge. And after the shock, the patient comes back to sinus.
So this was at 20 joules that you had a conversion to a sinus rhythm. So therefore, this is what we talked about, that we either, we keep a safety margin of usually around 10 joules, and in the patient where we have a slow VT which has been induced in the cath lab as compared to the clinical VT which was much faster, the option would be probably to program into a 3-zone therapy where we would keep an ATP for the first, for the VT1 and an FVT, an ATP before charging, and then in the VF zone it will be ATP during charging. And this is what the trials have shown us, and you could have two different things. In the VF zone, unlike the earlier devices which were committed, where if once the device started charging, it would go and deliver a shock, we now mostly have non-committed devices. So in these patients, while you are charging, while the device is charging, what we would want to do even in the patients in the VF zone is to give a small ATP whilst the device is charging. And then the device would again look at the rhythm prior to delivering the cardioversion or giving the defib shock. And if the device finds that you've come back to sinus interval, it will withhold the shock. Or if your patient is still in VF, it will go ahead and deliver a shock. So this is what is known as VF or an ATP during charging.
So we'll go to the second case, sir.
Yeah, I can go to the second case. So this is again a 60-year-old gentleman who's had a dual chamber ICD implanted for a secondary prevention, and he's come for a routine follow-up, and he's not had any therapies as yet. And this is the slide. I'm not certain whether the slide, can you put this on the programmer also?
Yes, sir.
So
sir, it has come through.
Volunteer then. So I don't know if it's seen well. So basically what you can see is that if you look at the first line, that's the lead one, and then there are the marker channels, the atrial and the ventricular marker channels, and you have the A sense, the V sense, and the discrimination. So in the atrial channel, you can see that there are more A's as compared to V. And what has happened is that after the fourth beat, the device has detected it as a mode switch because it detects it as atrial fibrillation, because there's more A's than V's, and it has gone into a mode switch where it has gone into a ventricular pacing alone. So what is the problem here? What do you think is the issue here? So, okay, so just for want of time. So this is basically what is happening is that the atrial channel, you're sensing something. When you look at the corresponding ECG, you find that there's nothing in the atrium to suggest that there has been an atrial fibrillation going on. So what is happening is that the atrium is over-sensing. It is picking up signals from somewhere else, and this is what is known as far-field R-wave sensing. So what is happening is that the atrial lead is over-sensing the R-wave signal, and this is known as far-field R-wave sensing. And because of this, the signals, the distance between the atrial sense and the far-field RV sensing, because they are very close together, the device picks it up as atrial fibrillation, and then it goes into an automatic mode switch. Now, how do you change this? How do you make sure that this does not happen? Now, this may be okay for a patient with pacemaker, but the problem is that in a patient with an ICD, this could be something that could be dangerous. And the reason is that if you do not pick it up, and if the patient has ventricular tachycardia, even if the patient has ventricular tachycardia, the device may not pick up the VT, because again, it will still fall into V less than A. So the atrial impulses will be still higher than the ventricle, and the device may still not pick up a ventricular tachycardia, and inappropriate SVT discriminators may start applying, and the patient may not get the therapy for a VT that may be needed. So it's important to correct this. And what are the ways to correct this? So I think I'm sorry I was not there for the pacemaker session, but I think what we need to do here is to understand that there's something known as the P-warp, which is the post-ventricular atrial refractory period. And amongst them, there's a period of the P-warp, which is the initial period, which is known as the post-ventricular atrial blanking. And this is the time frame where the atrial channel is blanked. It does not look at the far-field signals there. And this is the initial part of the P-warp. And this is initiated with the ventricular, either a sense beat or a paced beat. So what you could do here is that you look at the distance from the onset of the Q wave, and you look at the refractory signals there, and you look at the scenario. So basically what you try and find out that how far your far-field sensing is happening after the ventricular sensing. And then you increase your P-warp to a longer period than that. So here what we're finding is that the far-field R-wave sensing is almost 98 milliseconds after the ventricular signal has been delivered. And here what we could do is to increase the P-VAB to a higher level. Here we could increase it to say around 120, 130, and that will make sure that there's a blanking in the atrial channel, and the atrial channel will not pick up this far-field R-wave signals. There's something else that is also known as the decay, and something that is known as the threshold. So again, unlike a pacemaker where we have fixed sensitivity, what we need to understand is in ICD, the ICD has to select both the R waves, and it also has, which may be almost more than 5 millivolts, and it also has to sense the atrial fibrillation, which may be as low as 0.3 millivolts. So there's something known as variable sensitivity that an ICD has, unlike a pacemaker. And making it very sensitive would make sure that you may miss out the ventricular fibrillation, or reducing the sensitivity too much will make sure that you may end up causing over-sensing. And therefore, what you could do is you could make it either here, because if your far field ventricular sensing is smaller than the P wave, you can just increase the sensitivity, make the P wave, reduce the sensitivity of the atrial lead. So make the atrial lead less sensitive so that it does not pick up the far field R waves. Or what you can do is to increase the decay delay. So once it delays down so that it picks up the signals in the T wave or the far field signals, if you increase the delay, the decay delay, say to more than 30 seconds or 50 milliseconds, you may miss out those signals in the period. I don't know, Sabri, do you have anything to show there in this?
Yes, sir. We have actually increased the PVAP. Now the AMS has gone. Because earlier it was getting the far field sensing, and because of that it was mode switching. And now with the PVAP more than the far field sensing time, so it has blanked out the far field, so it has come back to normal. So it's come back to ASP.
And the third scenario, I think we'll just run over this. Now, this is again a gentleman who's had an episode of ventricular fibrillation, and he's now received an ICD. He has dilated cardiomyopathy, LV function for around 35%, and he's on amiodarone for more than 4 months. And this gentleman is taken up for an ICD implant. Now, what we find is that when you're doing a DFT testing in this patient, we find that there is a 25 joules which has failed. After you've induced a ventricular fibrillation, 36 joules has also failed, and you had to use the external defibrillator. A 200 joules biphasic had to be given to convert him to sinus rhythm. Now here, this is a gentleman that we are dealing with, is what we call as a high DFT. So what would be our schedule here? Because as I said, we normally would like to keep a 40 joules margin between your DFT and your maximum therapy of the device. And here at 36 joules, if your device is, DFT has not worked, if your therapy has not worked, then you're looking at a patient with a high DFT. So what are the problems here, and what are the options that one could take in this scenario? So I think I'll just skip over this. Why this is important is that many of the deaths that are seen in ICD patients is not because the device is not fired or because it's not given the shock. It may be because of the fact that despite giving the shock, the therapy is not terminated, and this is known as shock failure, or because of the fact that post-shock there is a pulse-led electrical activity. So the patient basically remains in VF despite giving the shock, and therefore it's important sometimes to make sure that we look at this, and this was one of the reasons why DFT testing was so important earlier. So how do you predict a DFT which is high? So there are certain reasons in a patient who's already implanted with the device that you could look at. There are certain metabolic causes that I think was also discussed for the pacemakers. This could include metabolic factors such as hyperkalemia. It could be other things. In fact, even amiodarone, a long-term amiodarone is known to increase the DFT. And many times what we may need to do is to shift from amiodarone to sotalol. If a patient has a high DFT, you must stop the amiodarone and move on to sotalol to prevent the DFT from going up. So there are no perfect predictors, but what is important to understand is that many of these high DFTs are associated with poor LV function. So there's a substrate that is abnormal, or previous cardiac surgeries of patients who have a VF, who have had VF in the past. And what is also important is that DFTs can change. So a person on an implant, when you have a DFT of say 20, sometimes the patients can come with a failure because of a rise in DFT, and one has to be careful in this group of patients. So there are certain things that you could do in this patient, and this flowchart tells us how to do that. One is to verify the RV coil polarity. So trials have shown us that when you keep the RV polarity as anodal or positive, and you keep your CAN as the negative, it's most likely that this vector is the one that gives you a higher success and a lower DFT as compared to a reversal of your polarity. But if you have a patient who's come back with a high DFT and not responding, we may want to change the polarity also. That's something that can be attempted. Or one may need to add additional coils. So this could be an SVC coil, it could be an azygous coil, it could be an external cardiac subcutaneous coils that can be added. And again, the one option that is there in the Abbott device now, or it's not there, it's been done earlier also, is to change the tilt of the waveform of defibrillation. So just to tell you what exactly this is, I think what we need to understand is that now all the devices, what we use is a biphasic waveform. And the first shock that is given, the first waveform, is basically given to charge the cell membrane. And the second waveform that is there, which is on the reverse side, is basically to remove the residual charge from the borderline cells and return them back to the baseline. So there is something known as a tilt. So most of the time, this tilt is kept at 65% in most as a default, and the second tilt is also kept at 65%. So there are devices where you have a fixed tilt, which is where we don't have you cannot program the time or the pulse duration of the defibrillation. But Abbott has a device where we can change both the tilt duration as well as the pulse duration as well as the tilt waveform also. So we know that usually the truncation should happen along where the sensors are most responsive, which is usually in the mid part. But there are people who are either fast depolarizers or slow depolarizers. So for example, in this patient has had depolarization which has happened earlier, say around 2.5 seconds. So here the tilt should happen earlier rather than happening very late. And patient who has a depolarization which takes almost 4.5 seconds, here the tilt should be a little later rather than happening earlier. So this patient where we had a DFT which is very high, there are 3 recommendations that are given. You could have slow, medium, or fast pulse width settings that can be taken place. And here what you would want to do is that in this patient, rather than having a fixed decay and a fixed pulse duration, one may want to play around with the pulse duration. So the first tilt of 65%, you may want to give it faster or say for 4 seconds. And the second tilt would be for a shorter period of time, say for 2.5 seconds. So how do you decide that is what you go down is measure the shock impedance. And your HV shock impedance will tell us which form you're filling in. And then you look at the impedance, and this chart can sometimes tell you that in a typical patient, how much your pulse duration should be in the first wave, and in the second wave, how much your pulse duration should be. Or the P2 and the P1 and the P2 milliseconds, you can adjust that. So based on this, Mr. Sabri, do you have something to show us?
It's already there, sir. We are programming that.
Okay.
So as per that 42 ohms, we are going for 4 and 3.5.
So here, when you look at that chart there, the 42 ohms there, can you just point a pointer there to just tell them what exactly we're looking at? I have to put that pointer there, sorry.
Yes.
So this pointer does not work. So what you're looking at is looking at this chart there, and you look at the 42 ohms, and it tells us what your tilt could be. So rather than having a fixed pulse duration, you can change the pulse duration. And here what you have done is gone on to
4 and 3.5.
4 and 3.5. The first phase is at 4 and the second at 3.5. And then once this was programmed, and this patient again had a DFT testing. And we know that 36 had failed the last time. So here, once you induce the VFib has been induced. Great. And here you see that the termination has happened. So this has been with
31 joules, sir.
31 joules. So you have come down from the earlier 36 joules where you could not get a response to here a 30 joules where your therapy has worked. So these are the small things that can be done in this group of patients. And thank you for hearing me out.
Thank you, Dr. Khan, for your nice presentation. My only submission is that when do you pre-plan DFT before ICD implantation?
Yeah, so that's what I said. See, most of the times you do not need to do an ICD DFT testing now, unless you're doing it for unconventional ICD implants. So for example, you're doing a right-sided ICD CAN implant. So if you're putting an ICD on the right side, it's always preferable to do a DFT testing. If you have a patient who's very hemodynamically unstable, you probably do not want to do a DFT testing when you're putting it convention from the left side. Again, if you have a patient who has, as I said, we are putting in a VT which is very non-tolerated. So here again, you do not want to probably go in for a DFT testing. So the sicker patients, you would want to stay away from DFT testing if you're putting in the conventional methods. But a patient that you're not putting in the conventional methods, well, you would want to probably do a DFT in this subgroup of patients. Or a patient who's probably had a history of a shock, or you're doing a replacement, for example. So a patient who has a replacement, you would probably want to do a DFT testing again in this group of patients.
Does it help in shock delivered but the patient is not reverted? DFT can help in those situations? DFT can help in those situations when the shock has been delivered but it has not reverted to sinus rhythm.
So you're talking about a patient who already has had a DFT, an ICD implanted, and he's come with a failure of the therapy. No.
Failure.
So here I think what we need to look at what exactly is the etiology for the failure of the therapy. So why has the shock not delivered? So one of the methods, yes, you want to do a DFT testing to find out whether the therapy has been, the first thing would be to find out whether it was an appropriate therapy or it was an inappropriate therapy. So you may want to play around with your therapies to find out why it has not worked. But again, yes, as I said, you want to look at metabolic factors. And yes, you would also want to do a DFT testing in a patient who has had a failed therapy with a previously therapy that has worked for him. So if you have at a high joules, you have put at 30 joules and you have had a failure of therapy, you may want to do a DFT testing in this group of patients also.
Yes, as a broader rule in secondary prevention, when we are going for secondary prevention ICD implants, we don't do DFTs. For primary prevention, because we don't know the rate of VT and so that we can induce and can decide. This is the idea. And we have two clarities. One is we have seen mode switches in your case presentations.
Sorry?
Mode switches, atrial fibrillation, and there was a ectopics and mode switches were there. So we have a algorithm called reactive ATP, which reduces the AF recurrence. So is it all across? St. Jude also has a reactive ATP, or it's only Medtronic has this? Number one. And one more question. Second is the nature of shocks. So there are some committed shocks. There are some devices. If it has detected a VT or VF and on ATP it is not reverted, and it has started charging. Now it has to shock. In the meantime, there is a termination. So whether it is going to shock or not, is there any difference in the make of the device, Medtronic or St. Jude? There is a committed and non-committed shock. These two.
Right. So the first thing I think Sabri can probably tell us about, he wanted to know about the AMS with
so when we have a
reactive ATP algorithm which is there in Medtronic, St. Jude also has that, or any other kind of variation?
Yeah, we do. That is different, sir. This will be different. But as such, your question was that suddenly when the therapy...
Yeah, the capacitor is charging, and then it is aborted, terminated. Sorry. So is it going to abort or not? Whether there is a difference in the from Medtronic, I think there is a non-committed shocks.
It's a non-sustained one. Yeah. That's what you're meaning, right, sir?
Yeah.
So if it is a non-sustained one, it will not give a therapy unless otherwise you get two consecutive non-sinus beats, that is VT or VF beats. So it will wait. And between this time, if you get 5 consecutive sinus beats, it says return of sinus and it will abort therapy. So it is always looking at it. It is never a committed shock. Even if the charging is over, it will wait for 2 more non-sinus beats, then only it will go for that.
Earlier, those battery drainage, nowadays that also has been taken care of.
So I had an impression that one of the device one of the company has a kind of all committed shocks. Once the capacitor has started charging, it will deliver shock, but one has not. So maybe Govind, can you explain a bit?
Biotronic is actually much more complicated. Medtronic is straightforward.
Yeah, to comment on the Medtronic devices, it's a non-committed shock, which means that after the VF is detected, during the charging, if the intervals become longer, there are algorithms, for criteria for that. If it finds 4 intervals longer than 4 out of 5 intervals longer than that criteria, then it will abort charging. And if, let's say, the charging is completed and it has to deliver the shock, our device will deliver a shock on the second short interval. But simultaneously, it's once again, if it is looking at longer intervals, once again, it will look at a window of 5 intervals. If 4 are longer than the criteria, I'm not going into the detail of that, it will abort the delivery of the shock. So, yes. Yes.
But do you have something known as timeout therapy? Do you set that nowadays, or no, you don't do that now?
You're probably talking about the high rate timeout. Right. Is that, sir? Yeah. So, yes, it is there, it is nominally off, which means that, let's say, a device is discriminating a rhythm as an SVT, right?
After some time, it has to then go and give a therapy as
right. So, that is a high rate timeout. Nominally, this is off because very often that results in an inappropriate shock. So, it is there, but it is nominally off.
Yeah, same with us. It is nominally off because SVTs can run for days.
Right.
So it will keep on discriminating SVT.
Can you
and
little explain the reactive ATPs?
Yeah, so to describe reactive ATP, we have ATP for atrial arrhythmia. Let me not say it's atrial fibrillation. ATP is not going to be effective in atrial fibrillation. So the concept behind reactive ATP is, if there is an atrial arrhythmia detected by the device, if you deliver ATP, if it is not atrial fibrillation, then there is a reasonable chances of success. But in the event of atrial fibrillation being detected, no ATP is going to be successful for atrial fibrillation. But it has been found that even in patients with sustained duration of atrial fibrillation, there are periods of stable arrhythmia that happens. So on detection of atrial fibrillation, the device will deliver all the programmed ATPs in the atrial channel, and most likely it will not terminate because it's an atrial fibrillation, but it will wait for an opportunity for the atrial rhythm to become stable, although faster. So at that time, if you deliver an ATP, it has a higher chance of success. So it will keep on attempting it every time when the rhythm becomes stable, and that has a higher chance of success. And we have shown by the Minerva trial, the chances of success are higher, and it has it's a 3-arm trial. So we've been able to demonstrate that progression of paroxysmal atrial fibrillation to persistent to permanent atrial fibrillation was significantly reduced when reactive ATP was on, and that is what reactive ATP is. It is looking for an opportune moment to deliver ATP when the atrial rhythm is stable, and that's why we call it as a reactive ATP.
I have a small query to Dr. Khan. Sir, we are discussing, though it is not your topic proper, we are discussing about the AF suppression algorithm. Different companies have different algorithm. So nowadays in paroxysmal atrial fibrillation, we do implant dual chamber pacemaker. At one point of time, we used to go for single chamber pacemaker VBIR. But in my practice, I do not see the success story of this suppression. So what is your experience?
I think we need to understand that AF has multiple pathophysiologies, and what we are trying to induce is basically PAC-induced or PAC-induced AF, where we try and prevent the emergence of future atrial ectopics by overdrive pacing. So some of these algorithm works, but because there are so many other mechanisms which are responsible, it may not work for all of them together. So this is, we usually keep them, all of them on, and hope that the patient can get a success. But I agree with you, not all of them work all the time.
Yeah, totally agree with that, sir. Actually, we promote AF suppression, but it's not for all patients. Yeah. It's for a particular number of patients who are pause-dependent tachycardia.
So, thank you, Dr. Khan. So, next, we'll invite Dr. Robin Chakraborty, who's a pioneer and one of few who started the electrophysiology services in Kolkata. So, he will guide us about some simulation regarding this resynchronization therapy.
Thank you very much. So I think this is the slog over of the day, I believe, but we need to rejuvenate after 6 o'clock for a very obvious reason. So I won't make it longer. So very quickly I'll take you through. And I think that was a very nice presentation by Aftab on this ICD and other things. So the whole idea of this particular session is to simulate possible initial CRT. I'm going to talk on CRT and follow-up situations, and also practice troubleshooting skill in the follow-up, and also talk about a little bit of decrease in non-responders. So we'll start with the case straight away, and rather than me, probably we should talk together. And with me, Sabri is there. Govind, you don't run away. Where is he? Oh, why you are so... Yeah, come in front. So, and it is very important for all of us to recognize that for device therapy and device follow-up, the industry's participation is of paramount importance, because they work mostly as a partner in this care, and we, all of us, take their support in the lab, outside the lab, and also during follow-up. So let us talk about the first case. A 56-year-old lady who had an implantation of the CRT 2 years ago, and is on medication for heart failure and other drugs. And also she complains of episodic palpitation, off and on, and therefore she came for consultation a week before, with shortness of breath and with intermittent palpitation. Doctors has changed her medication and asked her to return, and has been come for follow-up. Still she continues to remain unwell. ECG shows again atrial fibrillation, and of course the device needs to be interrogated. This is the electrogram found in the program app. Anyone from the floor? Anyone? Just volunteer? Anyone? I'm not going to volunteer myself. Anyone? What is it basically? Can you see that? Where is the arrow? Can I have the arrow or something to go? So what is this? What do you think is this? So some of them are complex, some of them are narrow. Some of them are complex, some of them are narrow. So forget about the narrowness and completeness and narrowness and kind of wideness. What is essential is that they are all R, by the way. They are irregular, right? So clearly this is atrial fibrillation. So this is, so you can see this is white. So white is narrow, white is R. So maybe that some of them are, so this patient had a CRT. So clearly some of those beats are biv-paced beats. And some of these beats are not biv-paced beats. But once the patient is on CRT, it is essential that patient should remain all the time on biv pacing. So we expect that all the complexes should be narrow QRS complex because of biv pacing, which is not happening here. Some of them are wider. So clearly there is no biv pacing, and at the same time they are irregular. So patient has atrial fibrillation. So during atrial fibrillation, patient is not being 100% biv paced. So that is the observation that we found. So why it is happening here? It is because what is happening here that sometimes it is being synchronized properly, it is being sensed properly, and once because of irregularity, clearly the atrial sensing doesn't happen. So sometimes it senses, sometimes it doesn't sense, right? But what you need to do, we need to ensure that A, atrial fibrillation goes off, patient remains in sinus rhythm, and B, if patient continues to remain in atrial fibrillation, we must ensure that patient continues to remain on biv pacing. Let us see how this can be done. So we know that even in heart failure patient, 20% patients may have CRT interruption because of atrial fibrillation, and it interferes with CRT response by two mechanisms: the deleterious effects of atrial fibrillation on the course of heart failure in general, and interference with the effective biventricular pacing as it is happening in this particular lady. The effect including rapid ventricular rate, irregularity of the ventricular response, tachycardia induced cardiomyopathy, and loss of atrial contribution to cardiac output. So this we all are aware of it. So what are you going to do? So we know that the treatment of atrial fibrillation is so we can rapid rate control, irregularity, loss of atrial contribution, all those things are well known, and eventually because of these things there is diminished CRT response, which is well known to all of us. So how to treat? We know that there is medication, beta blocker, amiodarone, so many blah blah blah, and sometimes some electrophysiologists may also consider pulmonary vein isolation or AV node ablation, or since the patient is already in CRT, sometimes external cardioversion or even internal cardioversion people are doing, and device programming. So these are the options what we can think of. Now you have already tried medication, patient is not responding properly, patient continues to remain in atrial fibrillation, maybe paroxysmal atrial fibrillation, and pulmonary vein isolation results may not be that promising in all cases, and AV node ablation is not that complex, not that simple procedure, it has its own problem, what we have to be aware of. So device programming can be an option. I'll skip that slide. So, and then again, so let us see whether we can do anything on this. So at this point, I will ask Sabri to take over, but before that, I think it is important to understand that we already talked about atrial fibrillation, mode switch and this kind of thing, which can be acceptable in a patient with a DDD pacemaker, or even sometimes in AICD with dual chamber, when it can sort of, auto switch, or mode switch. But problem is biv, we have to ensure that this should pace all the time. So that is possible. There is a program which we are all aware that we actually forgot, but we should remember that, called DDT pacemaker. If it is triggered, then what will happen? Then these pace complex will actually trigger, and therefore this this complex will be, all the complexes will be BiV complex. So let us see, so whether we can think about the DDT mode or permanent during the mode switch. So when there is a mode switch, then you can actually go into DDT mode. Then therefore, but normally in mode switch it goes into single chamber, BBI or BBIR, whatever, but DDT mode. And therefore, by doing so, it is possible to have a complete BiV response. Sabri, can you just show this?
Yes, sir. So in DDT mode,
yeah, you can stand here, you can come so that they can see. They will think that I am talking. But I don't have habit. When he talks, I move the lips. Okay, loud and clean, so that they
Thank you,
understand
sir.
what
Thank you.
Yeah. Can you help him from your side? Yeah.
Yes, sir. He will take care of that. So basically, as you rightly said, when the patient is in AMS, there is a lot of sinus coming through, and because of varying intervals, it comes through. So where we can program this biventricular trigger, or as you rightly said, DDT mode, which has been programmed now. So in AMS, this has started going into a DDT mode. But this DDT mode is slightly different because in atria, it will be still sensing, but not triggering and inhibiting. But whereas in ventricle, it is going to sense and trigger whenever it sees a ventricle beat. So it is going to trigger a biventricular paced beat whenever it sees a ventricle beat.
Although the atrium will continue to have fibrillation.
Yes.
Is it clear? Any question on that? Devabrata got a question. From your face, it is obvious that you have got a question. Yes. So before the question, yes, he wants a mic.
So the thing is, the way you have troubleshooted Sabri sir in this patient, let's say you get the V-sense and you trigger the BiV pacing, it will still have a fusion. Maximum it will have fusion. It will be not a completely BiV paced bit. So we were actually discussing that we could in another way, maybe a simpler way, just to increase the lower rate to 75 or 80. So that also will give you a completely
that rate tracking, that decrease the lower rate response also can be done.
After what rate does it switch to this mode? Rate like 80, 85, less than 70. It should be a normal, BiV pacing.
Like, as he was saying, in AMS it starts switching into biventricular trigger mode. Here, as sir was saying, we can also increase the base rate and keep a higher rate. Like we have kept it only at 60. This can be kept at 80. But if you are comfortable at 80, yes, it's better. But in case if it is faster than 80, then it's a situation where this might be of use.
Do we have any study which shows that your this trigger fusion beats, they are going to give you equivalent result as a BiV pacing?
It is not going to be equivalent, definitely.
Yeah, obviously.
It is because already the RV has been depolarized, then only it has been sensed by the RV lead. So it is far more better than a sensed beat, but not definitely as equal as a CRT beat.
The reason of presenting this case is to make you aware that this DDT mode for ventricular thing is an option which is already available in the programmer. So when you see the patient and think the patient is in paroxysmal atrial fibrillation, heart failure patient, it automatically there is a mode switch and goes to a different thing. So both the options can be done, but this is one option which people may forget. People actually completely forgot that DDT mode, that has almost gone. We don't practice anymore. So there are clinical situations where this DDT mode can be clinically used for some benefit of the patient. We have some data, it is not the data is zero, it's still there some data. It is certainly much better than the other one. Is it okay? Now move to the next one. So I think we have already done that. Can you just explain to that? Sorry, you will go back. Yeah, now you can see that. Yes, Sabri.
Sir,
this is the one. Now you can see the atrial fibrillation is going on, but each complex is narrow complex.
It is better than biventricular this sensing beat, but not as good as a pure biventricular pacing. So at least we are trying to get something out of this because all these conducted beats are going to be sinus beats. Now it is going to be partly a biventricular capture.
So therefore, in your follow-up patient, we see, and then when you do interrogation, you find that patient had episodes of atrial fibrillation. So you can actually program it that during such episode, you can actually sort of mode switch to DDT mode. Therefore, that What is happening to the status? What is happening to the clinical follow-up? Is there any worsening of heart failure clinically or even echocardiographically? So it's worth looking into it. So this is the option. Let us go to the second scenario. A 45-year-old lady with the dilated cardiomyopathy, complete left bundle block with CRT-D device, which was implanted a year ago with a history of atrial fibrillation and ventricular arrhythmias. She comes back for routine follow-up. She had, since the last visit, she has remained stable and in fact has started resuming regular exercise in gym. However, you notice her biventricular pacing percentage is only 70%, whereas PVC burden is 20% since she has implanted the device. So clearly, there is a significant reduction of biventricular pacing function. So what can be done? So before that, this is the situation. So what is happening here? Anyone? Any comment from the expert table? Suchit, I can see. Suchit, go ahead.
Here actually all are ventricular sensed, means IV is not occurring, probably due to the short intrinsic AV delay of the patient, because when he exercises also, this AV delay shortens more, and that allows the intrinsic conduction rather than a biV pacing.
That is one option. One that is a good thought. Any other thought you can think of. Now, can you blow it up? You can blow it up here. So this is A and this is the B. So what is the other possibilities? Any other possibility?
The other possibility also could be the upper rate is kept low. Maybe someone has kept upper tracking rate of 110. So above 110, no beats will have a biV pacing. So that is one option.
So very good. Both of you really made a very good comment. The only question to all of you that after the CRT P or D implantation, what is the common kind of upper track rate we fix normally? What is your practice?
In fact, because in CRT patients we want to keep the rates lower, I think they come with a default, even the St. Jude devices, they come with
what is that understandable.
Okay.
But
So-
what do you keep normally? What upper tracking
in
rate?
pacemakers is around 130.
MTR, the maximum tracking rate, what do you keep? What do
is
you keep?
130 for
130.
pacemakers.
Suchit,
for
what do you
CRT.
keep? 130. So you keep 130 and sort of many people even to go for a little higher. The only problem that many doctors, I could see Atahar there. What is Atahar in Bangladesh? What do you do? What do you keep at upper rate, the tracking rate, highest rate?
Nominally, usually 130, sir.
130, right. So many doctors are a little anxious because that if they increase the rate, upper tracking rate, and if the atrium goes faster as happens in heart failure, then heart failure, the failure component may not improve because we know that the heart, if it tracks all the P, then naturally the oxygen consumption will be more, the heart failure may become worse. So people are sometimes anxious. So therefore, with that kind of anxiety, they want to reduce the MTR or maximum tracking rate or upper tracking rate. And therefore, thinking that patient will not have those kind of palpitation, those kind of worsening of heart failure, so those kind of increased oxygen consumption. So therefore, they reduce the tracking rate. But what can be done? Probably you can increase the rate. At the same time, you can concomitantly, we always prescribe beta blocker. You can increase the dose of beta blocker and see the device has a higher tracking rate, but patient is on medical treatment for the lower rate. Therefore, even if it goes up, it automatically happens. So anyway, very good comment by both of you. So in this particular case, as you have seen very clearly, that the upper tracking rate is low. So now this is an option. The moment you see that, or your industry, the programmer says that this upper tracking rate, the moment you see, he says, okay, what is the upper tracking rate? Upper tracking rate is 110 or let us say 120. So immediately you should tell the industry person, increase upper tracking rate. Make it 115, 120, 130. Yes, Suchit, you are coming.
No, I am just telling, if this is the cause of issue, the upper tracking rate, then there should be intermittent ventricular pacing and then sensing. Means initial period when it is starting with the AV delay and then we will be prolonging the AV delay. So there is no ventricular pacing seen.
Sabir, can you go back to that ECG? The other one. Yeah. So that's what Suchit is trying to say, that if it is purely what is called, this is a sensing problem anyway, he said if it's a upper tracking rate problem, then we would have expected
But there is a dynamic hysteresis, negative hysteresis which is programmed, isn't it, Sabri?
See,
Yeah.
just like reverse of the MVP, there is a dynamic p-warp response should be there. So automatically the tracking rate should
Take
be
the-
high.
take the microphone.
Yeah.
That was purposefully switched off.
Okay, that, okay.
So to store this thing.
Okay. So the devices has an automatic negative hysteresis, so they will go back to high tracking rate in BiV pacemakers. So for this, demonstration of this case, this was switched off.
No, but then how you negate the points what Suchit raised?
Sorry, I didn't hear.
Sanjeev, you got a comment from your side, from this side?
No, actually, this. Sanjeev, automatically done by no. Just
Sanjeev.
if it is a. Go ahead. No, if it is means upper tracking rate is an issue, then it will initially track, and then one maybe there you can have a prolongation of AV delay, and then the intrinsic can come. But initial bit, you should have a ventricular pacing before ventricular sensing. If you have not kept the AV delay higher, your paced AV delay higher than your intrinsic AV delay.
There is no pace beat, that's
So I think the problem here is the intrinsic AV delay is this thing lower than your paced AV delay. Is it so?
So what you are trying to say, let this look at the right side of the screen, which sir is showing.
Intrinsic
So,
AV
yeah, so whole screen is actually showing at a rate of 150. Let's say assuming that we see a running screen. Initially her heart rate was, let's say, 100, and now when he or she exercised, the rate went to 150. Then you will be able to see the transition. When at the rate of 100, it was Ascens BiV pace, and as she went into a transition of 115, 120, that cutoff of 110 would have exceeded. In this case, we see only one single shot of the screen where it is all.
We have not shown the entire episode.
That is what I am trying to
Sir,
say.
I think this question is not proper because none of the device has got this kind of strip which you get. There will be automatic AV searching and it will be pacing. And you seldom see such kind of incidences.
No, what Suchit is trying to say, if you record it right from the beginning, then you can see it is not like this, it is just a screenshot of that particular time.
And just to add, sir, the maximum tracking rate is put at 110, and the ATL rate has gone beyond 110. So in that situation,
that is a different situation.
Yes.
If someone has put MTR as low,
Yes.
then
In
it can
this-
happen. Yeah.
SR will be coming to
Then
that.
it can happen.
That is the reason why it was actually sensing.
Short AV, Suchit, short AV is not going to stay in normal cases.
Suchit, one more point is that, let us say you are right, but if you now increase the upper tracking rate and see it gets corrected, then probably, since we have not seen the right from the beginning, no, we have seen just a little bit, but just few milliseconds, few seconds. So this is a thought which should come, you increase the upper tracking rate and see what is happening to this.
And coming back to sir, just 1 second, as this AV delay is also slightly kept longer so that the sensed is coming. So if it was actually shorter, you would have got a Venki back at this time, and yeah. So that was basically kept like it.
Yeah, if I can add a point to what Dr. Suchit Majumdar raised is that, so you are right in saying that at some point we should say Ascens BiV pace, right? If it is Venki barking. Actually, that will happen only if the patient is in AV block where the AV time goes on increasing. At one point it paces at a maximum time.
Correct.
And then the next one is paced at the normal AV interval. But in this case, none of it is resulting in a V pace. So it is Ascens, V sense. And the V sense is not happening at a longer interval.
Rakesh?
If there is a prolongation, the initial AV interval, if you had kept a shorter paced AV delay than your sensed AV delay, then this situation will not arise. The main problem is that the paced AV delay has been kept longer than the intrinsic sensed AV delay during exercise.
Which is a possibility. But then in this case, going by the ongoing rate of 115 and the upper tracking rate of 110, there is a Venki bark going on behind this. Your point is also right. It is possible that we have programmed a AV delay which is longer than the patient's intrinsic.
No, so then you are telling that the PR
Rakesh,
interval should increase.
comment and then we can move on. Yeah. Any comment?
Sanjeev, can you just take?
So, just one comment I'll still make, and both of you are here. So, taking this Suchit sir's comment, even let's say in this case, the lower upper tracking rate was set at 110, and she is having a sinus tachycardia. Whatever you keep the AV delay. Even if you give it 20 seconds, it will not have YP pacing. Because the upper tracking rate we have set at 110 and her sinus tachycardia is 115. So, initially, okay, you are, okay, I got you.
In between strip which you are getting, you may not
Okay,
find
now
it.
see, anyway,
You
so
can go
coming
ahead,
back
sir.
to
You can
this
go
case
ahead.
again, what we have done, after that, the programming, Sabir, can you just, Sabri? Yeah, take the microphone and explain to them. Let's keep that. So we will not get into all those.
This is the
This particular
transition.
thing as a discussion, whatever you say. Now, this has been done. Supper tracking rate to 140, and what happened? Now, Sabri, can you explain?
Yes, sir. This side, if you can
This
see,
resolves the crisis, huh?
the other side, it is 115 is the sinus rate with 110 is the maximum tracking rate.
It is 140.
Yeah, when it goes to 140, it becomes 1:1 conduction.
Gone. And the QRS morphology changed. So, finally, sir, who won this game? Is it yeah?
MTR.
MTR. So you won the match. Science. You did not win the match. You are wearing Argentina jersey. Did you notice? Okay, I think we are going to finish it the last case. Now this is another one. You can see. I'll just go to the story first. A 55-year-old lady has implanted CRTP 1 year ago. She comes for consultation and she tells you that she feels more shortness of breath. You decide to perform an interrogation look into the diagnostic and real-time ECG. So this is the scenario. What is happening here? What do you observe? The real-time ECG. What do you think is the QRS like? Is it a bi-V paced or non-bi-V paced? This side, Devopriyo, we start with you.
Sir, properly it is all A sense followed by both RV
Both
as
are
well
A
as-
sense, but what is this? Is it a bi-V paced or non-bi-V paced? You can see here also, no?
It's bi-V pacer because LV as well as RV both are showing pacing simultaneously.
So is it so there is interventricular synchrony or dysynchrony?
So there is a delay between the RV and LV, but supposedly the LV should come before. I mean,
So both of them are pacing. It's a bi-V pacing.
It's a bi-V.
Synchronous, interventricular, dysynchrony.
there is a interventricular dysynchrony here.
Here?
Here, yes.
Why?
Synchronous.
So what do you observe?
Is it LV paced at all?
Say it again.
See the LV.
Who made comment?
Devopriya wants to see 12 DCG.
Okay, Sabri.
Sorry, sir. We don't have it.
Now you can see this is one, the one we saw just now. This is another one. Sabri, can you take over?
Yes, sir. As you were seeing the initial ECG, that is bi-V pacing ECG. And the other one, which you see in the right side, it is a only RV pacing ECG. So do you see any difference between these two?
There is no difference. Apparently, there is no difference between these
So
apparent ones.
in case if both of them are not different, what could have been the possibility?
LV not capturing.
Yeah, LV is not there. I mean, LV is not switched off.
Not switched off, it is.
Pacing, na, by pacing showing, so it's not capturing.
Yeah.
So why LV is not capturing? What can happen? Very simple, no? Threshold.
Threshold, high threshold.
The threshold must have gone up, so it is not. So what you do, you increase, what threshold has gone up, increase the output. That we do normally, no? Regularly we do that. So that has been done, and after that is being, any comment from this side, the expert table, Devobrata, Argentina. Did you hear what you were talking or you are talking? Is it intra-table talk or inter-table talk? Say louder. Microphone, microphone, microphone.
Sir, I think as Devopriyo mentioned, the LV bipolar is sensed later than the RV bipolar. That means the LV is sensing something later. Although there is BiB pacing, means LV is getting paced at some point, but the sensing is later compared to RV bipolar. And as you can see that RV only pacing and BiB pacing is having the same morphology in terms of the sensing.
But if LV also sort of pacing,
Yeah.
if it captures.
Yeah, I mean that we cannot say.
We cannot see the capturing. We cannot see the capture part in the surface ECG.
That spike we cannot see actually. I presume that at least it is simultaneously paced or LV is paced little earlier compared to the RV. But as far as the sensing is concerned, as it is delayed, so I feel this is the case of or scenario of anodal capture, where you can have the similar kind
I
of.
think more or less right. I think it's almost same. I think same thing.
I want to say one thing, small thing. So if you can see the LV bipolar, you can see initially there is a positive component. So that also goes in against a pacing from that lead. So it goes against a sensing. So some impulse should be coming towards it to cause a bipolar initial positive deflection. So that also goes in favor of LV sensing rather than LV pacing there.
Yeah, almost all of them. So basically what it seems, so what do you do? Actually this thing is a ECG wise, but when you start interrogating through the device, you can clearly see that by the LV capture lead has been, the threshold has gone up. So you have to increase the output, and once it is being done. So threshold rises in LV lead, cause down capture, maybe high threshold, anatomical scar, macro displacement, loss of LV capture, increase output by reprogramming and lead repositioning rarely being done. And after that, and sometimes increase pulse amplitude. And final one, can you go to the final one? I think we'll close it now. The final ECG. This is with me. I think there's all theoretical discussion. The last part. This is the last. Okay.
Sir, we have put it in the programmer. You can use
Sure.
that.
Now, can you do the programming?
Sir, done. Sir.
Thank you, sir. So, big round of applause for this simulator-based session. Dr. Aftab Khan and Ravin Chakravarti. Yeah.
So I try to make it
Thanks
short.
to chairpersons.
Try to make it short so that everybody talks.
So now we move on the final session, and this is a quiz. And I request Dr. Ravin to be there on chair.
One more
and
thing.
with me, I will be there. Yeah.
No, call them. Call that. I'm going to listen.
Okay. So Suchit and Sanjeev, please come. So now everyone has to be, participating in quiz chat through mobiles, and we'll come to know who won. Through mobile, anyone can participate. The QR code, isn't it? The QR code will be there, Sabri? You have to scan the QR code. The quiz will be active on your mobile, and after it is projected there, you have to answer. And you will come to know who, it will be anonymous, obviously, till we say. So we can have the quiz. Okay. So we will go ahead.
You can.
Ravi sir, please be there, sir. No, there is no role there. There is no role there, sir. So one who is there who is not going to participate in quiz, sir. So please go there, sir.
Oh, I think we can on the quiz. So,
sir, you need to wait a bit. We are. QR code is coming.
So we will have a rapid fire session. There is not much of explanation to be done because all of us are there who know everything. So just 1 or 2 points and you go to the diagnosis. So,
Dr. Shikdar, just hold on for half a minute. We'll just keeping things ready.
So,
sir, everybody kindly log on to Kahoot.
So you can explain the way that we are going to conduct it. So there will be 4 choices for each question. 2 of them or 3 of them may also be correct. It is not that only one will be correct. And
Are you able to get scanned? You can better use the pin, sir.
the main screen for the electrogram should be big, because people may not be able to realize this. So that has to. Okay. So. So we can go to the slide, or is it? Oh, wait. Dilip, you have some prize for this one?
Yes, special dinner with Sunanda.
You got it, sir? Kahoot. And Kahoot, you can just log in into that. You need not log in. Yeah, install, please, or else you can directly go with this pin.
I can see the technicians there also. I think they should also participate.
So we could get 3 participants already inside.
Dr. Pandit is already there.
And where?
You always will surprise.
Maybe if you can go to the TV screen you can get the QR code, sir. Sir, TV screen, you can go. Sir, don't do anything, sir. Come on, sir. Come
Surajit, you also participate. All of your technicians should also participate.
Yeah, got it.
Okay. Suvidha
is participating.
এই সুবীর দাও আছে, সুবীরদাকে বলো, সুবীর দাও আছে।
Sir, you are coming. So now, what's his name? Sunil. Yeah, great. I think we keep it like this all the time.
একদম এক নম্বরই চলে যাচ্ছে।
Sir, just a simple housekeeping rules about this. Each question will come in, and you will be also able to see the same thing in the slide also, because the slide will be showing a bigger picture of the ECGs. The only thing is, when the option comes in, your timer starts, and it will be 20 seconds. And the marks are scored like this. Whoever goes first for the right answer will get more marks than the person who gives the right answer, but on the 20th second. So that is also there. But yeah.
Okay,
so
the questions are mine, but this slide part marking part belongs to Sabri sir. So I have no responsibility on the marking part.
So neither me, sir.
Sabri sir is going to get the prize.
Sir, I think we will start, sir. I'm going to start it.
Yeah.
You can go for the first question.
Together, they are copying from each other.
So going to the first slide.
So you can go for the first slide, please.
So this is just how the electrograms look.
Question.
We go to the question.
Question.
Yeah. So a 60-year-old lady with VIR presents with dyspnea and syncope.
Time
Very
starts
simple
now.
question.
So thinking of going fast, don't make a mistake. That
Start.
will take away all your marks.
20 seconds, you give a beep.
Sir, it is coming on the timer on the screen. So already 3 seconds more, 2, 1, and it will close.
Okay.
Hardly 7 people have answered. So not a good thing. There are nearly 20 people over there, but only 7
Thank you.
have answered.
Going to the answer. So, how many people have, can you see the percentage there?
Yes, sir. Now 7 people have answered. We'll go for the leaderboard. The leaderboard will give you the at present point of time who has got the most marks. So RM1, I don't know who is that, is the first one, 387. So this is the marks, and all people are right. And if it was 2 questions, probably 1 answer would have been
The
right.
person who has given 2 correct answers is the best one.
Yeah. So we'll go for the next question, sir. Or you want
No,
to
I
explain?
don't think we go to the directly to the, yeah. So, this is a dual chamber pacemaker. Patient had an ischemic CVA. Any diagnosis? 1, intermittent AF, B, lead malposition, 3, C, perforation, D, epicardial pacing.
8 seconds more, only 4 people, 7 people have come in. Good. 8. So we are going better than the last one. It is 0 marks. Sir, now the question is done. We are going for the leaderboard. So let's see who is number one. So Gaurav has overtaken.
Important thing is,
Yeah.
what are the causes of right bundle branch black pattern in lead V1? One of them, and the most common, is misplacement of the ECG leads, one space up or down. But here, because the patient has an ischemic CVA, so it is likely that there is a misplacement or malposition of the lead, and there is an endocardial pacing by an ASG. So this is the ECG. So the lead is placed in the left ventricle through an
Shovik is
ASD.
the most common name in Kolkata.
So coming to...
So just give me a second, because now you're out of the question. They have more time for this.
So CRT with increasing SOB, it is an AF, LV non-capture, long AV delay, RV non-capture.
Still only 2 answers, 3, 4, 5. We are running out of time. Soon we are going to stop. 4. Oh my God, only 1 second gone. 17 people again, not bad.
So we all know that lead an AVL should show a Q wave, and so there is a lack of capture, intermittent lack of capture.
So we have got a new leader now, and that leader seems to be really ahead of others.
So we have a 6 sinus patient with a single chamber VVIR pacing and dyspnea.
And the options are coming up now.
Options are atrial fibrillation, LV dysfunction, COPD, pacemaker syndrome. Three, two, one.
Yeah.
So there is a retrograde P wave, and likely that this is a pacing syndrome.
So going for the leaderboard, sir, can I? So there is a small change. Dr. Gaurav has come up, and still there is a close fight for the first 5 people. Yes, sir, we can go for the next one.
So case 5, high atrial rate episodes. What is the cause? Is it atrial tachycardia, atrial flutter, atrial lead fracture, far field sensing? Zero, okay. So as we can see, the atrial channel is sensing, far field sensing is there. Near field always have a sharp deflection which is not present. In far field we have a small wave.
Sir, I'm going to the leaderboard, sir. Let's see who stands at what status plus. Oh, again, there is a lot of change. Suddenly a new star has emerged. Let's see.
So one of these causes is the proximity of atrial lead to the ventricle or high sensitivity. Actually, this is one of the more common causes. And solution is to decrease the sensitivity. This is a very simple syncope after 5 months of pacing, lack of output, under sensing, over pacing, loss of capture.
So I thought I'll give more time. So the options have come up. You can go for answers.
When this was said, I didn't know there were so many experts here rather than students. So this was kept actually.
Okay. So everybody have answered that. So you can go for the explanations, please.
Yeah. So there is naturally a loss of ventricular capture here. Very simple. Now,
So just give me some second. Come back to the slide, previous slide, please.
back, na?
Back. So we'll see the leaderboard. Oh, the star is holding on. And Araman has also come up slightly. Dr. Rakesh, you have to buckle up. You lost 500 points almost.
So we come to the next question. Recurrent AICD shocks. Is it a lead fracture, ventricular fibrillation, electromagnetic interference, myopotentials.
The answer up the screen, you can go for it.
Okay. So what is the score?
So let us go for the scores. Just 1 second. Give me. Oh, holding on. But the second, third, fourth portion are suddenly changed. So there has been dramatic movements in this time.
The master is above because he has a case report on this, I think. Okay, coming. This is a very high amplitude and high frequency signal. And far field is, however, normal. And impedance rise is there, as we can see. From this was not given, this data was not given there. Okay, coming to the next case. Asymptomatic patients. Dual chamber AICD. What's happening here? Pectoral myopotentials, VF, electromagnetic interference, diaphragmatic myopotentials.
So we had enough time. I think this time all should be answering.
6, 5, 4, 3, 2,
1,
0.
So 3 people didn't answer. Should we go for the leaderboard, sir?
So, one important thing is the patient is asymptomatic. Both of the atrial and ventricular lead showed almost same amount of irregularity in the signal. Very high frequency but small in amplitude.
Sir,
So,
please come back,
yeah.
sir. Please
Yeah.
come back.
Yeah. So it is an electromagnetic interference. Very short duration. Patient passed through some scanner in airport, so he didn't have much time and problem.
So 3 people are holding on, and 2 new people have come into the top 5. So Dr. Rakesh, I think yours went back and came back, I believe.
So going to the slide.
Yes, sir. You can go ahead for the next questions, please.
Asymptomatic patient with AICD. You can see the event that has been marked in red is at a pectoral myopotential, option A, VF, option B, electromagnetic interference, option C, diaphragmatic myopotential, option D.
Sorry. We can go this side.
7, 6, 5, 4, 3, 2, 1, 0.
My God, only 13 people have answered this time. This time, people didn't even want to give a try.
Connection is lost.
Sir, we will go for the leaderboard.
So, one clue to this answer is the ventricular lead only shows the sensing part, but atrial lead doesn't show anything. Patient is asymptomatic. Likely it is a diaphragmatic myopotential. If it was a pectoral myopotential, both atrial and ventricular lead would have shown it.
Yeah.
So these are the different characteristics. I think it is already, everybody knows it, just for purpose. Yeah.
Sir, come back, sir, please. Go to the 9th one, please. Sir, we are going to the leaderboard now. So it seems that Dr. Bera has a point to make here.
I'll tell you the reason. If you go back to the EGM, no, just go back to the EGM for the learning purpose. The same reason what you told, it appears that the atrial lead also has a noise, if you look closely.
No, actually atrial lead in the marker channel doesn't have it.
No, that I okay. And in the EGM there is looks like noise.
But
you
in
are
the
right.
marker channel it doesn't.
You are right, okay. Sometimes atrial marker channel may not have. If there is a VF, the atrial marker channels will come in the blanking. You may not have them.
Thank you, sir. Now there is a close fight ensuing. The first 3 people are only separated by few
Holter.
marks. So
It is a Holter tracing, but just there is some phenomenon which is, I can say, interesting. What is happening here? So there are 2 intervals which have been shown, marked in blue. The PR interval. So is it a lack of capture, VVI with AV block, AF, and AV hysteresis. Three, 2, 1, and 0.
So consistently now it has become 15, 18 people are there, but I
So
don't
what
know
is
why
the situation?
3 people are not answering. Okay, sir, now I'm going for the leaderboard. Should I? Or you have some explanation?
So this is basically a rate adaptive AV delay. We have discussed, I think, in the morning. Whenever the rate is higher, the AV delay shortens, rate is slower, it is lengthened. What is the scoreboard?
Yes, sir, going for that, sir. The top 3 are fighting between themselves. They are still, just a little change has happened now. Let's go for this. And for everybody's information, we have 12 questions only. So we are in the last quarter. So let's go for it, sir.
Hey, who
please.
is this epic? Epic. Who is the epic? So we have case number 11. DDDR LV dysfunction. What is the possible cause? Is it a pacemaker syndrome, atrial tachycardia with aberrancy, programming issue? Thirteen, 12, 11, 10, 9, 8, 7, 6, 5, 4. Where is your timer gone?
So
Okay.
timer actually took off early. Sir.
So, what is the... Achha, I will go to the explanation, then we'll go with the scoreboard.
Yes, sir.
So, somebody actually forgot to start the mode switch, and that is a programming issue. Mode switch was not active.
So now as we are going to the far end of the questions,
So
let
mode
us see.
switch activated, and this is the CC.
Good, sir. Sir, shall I go for the markings?
Yeah.
So going for it. So there is no change actually. Only thing is the difference is still remaining is only 4 marks between the first and the second. The third is slightly different, and fourth is also quite nearby.
So we come to the last question.
No.
Yes.
Which is Argentina and this team, or which is France? So
Are you going to close it now?
Last question. During programming, this patient had severe palpitation. What is the possible diagnosis on the right hand side that is happening of the EGM? AVNRT, PMT, VT, AT with aberrancy. Three, 2, 1, and okay. So this is the ECG. So it is very obvious from diagnosis. PMT can be induced during the programming. PMT may occur during atrial threshold testing. So one of the important reasons why it may occur is if the VA interval is more than the PVARP and you have to extend the PVARP. So what is the situation on the scoreboard?
Yes, sir. I think, Dr. Dilip, are you ready? Dr. Dilip, are you ready to give the gifts? Okay.
I think it will be...
So
you show them the World Cup match at some hotel. I think that may be...
It can be shown, only police permission has to be taken.
So the wait is going to get over. Let's look for the final results.
So
The
this
podium.
extension of PVRP is important.
So Dr. Pandey is number 3. Dr. Devrata is number 2. And Dr. Somnath.
Which means Argentina is going to lose today.
Oh my God. Please don't say that.
So this is also an invitation for the heart failure session that we will have in Barasat in January 28, 2023. Thank you.
Thank you.
So, thank you so much. And what a better way to end the program, the device update 2022. So I would like to have some the concluding thoughts from Professor Chakraborty, and we can have some feedbacks from the participants and speakers and chairpersons, how we can improve it further. Thank you.
Thank you. Thank you very much. I think it's very seldom being talked about a pacemaker device. I was always being passionate about it, but I'm very happy to see that now even in Kolkata, people are taking interest to learn the pacemaker, the integrity of pacemaker circuits, the abnormalities and how to correct them. This kind of little small workshop, a single day, a half day is very extremely useful for people like who are interested. I'm sure that many such cardiologists will come and participate and try to educate and re-educate themselves. So that the pacemaker we do every now and then, but we don't understand much. We are always dependent upon the industry people. It is very important that we also know a little bit about it. And at the end of the day, we will be educated, our patients will be benefited. Thank you very much. Thank you, Dilip, for a wonderful time, and thank you all of you, including companies, Medtronic, Abbott, St. Jude, as well as the Boston. Any other company participated? Or Philips? Philips also is there. And of course, our medical hospital. Okay. Thank you. Thank you very much.
So now may I invite the industry representatives, like maybe Sabri, Govind, Souvik, Arnav, Datto, and Kaushik to come here. And if you have anything to say, please say. And then we'll have a group photograph, those who are left out. And come, anyone? Souvik, you have to. So they have really worked hard. Debu kothay acho? Are last comment da ekto.
Come.
So quick 30 seconds, responses from them, and then we'll have a final photograph.
Okay, so hi, good evening everybody. First of all, I'm so glad that everyone joined in for the entire session, even though it's a Sunday. And for the matter of the quiz, I'm so happy everybody participated so enthusiastically. The idea is in the coming years, we are obviously going to replicate this further. And thank you so much, Dr. Kumar, for giving us this opportunity to be a part of this session and for being so intricately involved. Thank you.
So thank you for participation, and we have good learning sessions in this entire day, and next year we will do it in a further bigger way. Thank you.
So thank you for participating and sharing this platform with us. It was a very interactive sessions all the way, and this kind of session will keep on happening, and we will definitely try to replicate this in future as well. And thank you very much, sir.
Yeah, thanks everyone. I think the Philips for the first time participated in device update, and the entire team was on live on the Zoom watching the session, and they were very happy the way things happen. They really want to be part of this event going forward, and it's really a great event, and we look forward for the next year. Thank you.
Anyone else? I think this time it was really wonderful, sir.
Thank you. Very well done.
Thanks for participating in this. I had the privilege of, associating with the first session that Dr. Dilip did. It was 6 years back, right? 6 years back. And I can see that it has been growing in stature, and participation as a patient has increased. I believe, and that is your ultimate goal as well, to make it kind of a national platform, which I'm sure in the future years it'll be realized. And we will be happy to be supporting you at that time as well. And thank you very much for giving us an opportunity. Thank you very much for participating. Thank you.
Okay, sir. Anything? Atharali, sir.
Thank you.
Sir, Sujit, come. Deopriyo, we'll have a photograph. Arindam? Sobi, you can come. Anyone? Chale asho? From friends from Guwahati. Come. So So we'll stand, one team will stand down. हम लोग नीचे सर we'll go table which one?
Thank you. Thank you very much.
Thank you, sir. Thank you. Thank you.
I 1986 and mentioned very good. We only know why they do that.